or timely treatment, and close follow-up are essential to prevent blindness and visual impairment, thereby improving the quality of life in diabetic patients. These are all about my presentation. Thank you so much.
Now, I would like to call our next and last presenter, Dr. Binay Kamath, for his presentation.
Good morning, all. Today I'm going to present a study conducted by me. This topic is the assessment of optic discs, retinal nerve fiber, and ganglionic cell complex in patients with type 2 diabetes mellitus. I declared there was no financial support, sponsorship, no conflict of interest related to this study. Now, coming to the introduction, as we know, the diabetes mellitus is a chronic metabolic disease causing hyperglycemia due to insufficient insulin, leading to multi-organ damage. As you see, the incidence in 1980 was about 108 millions, whereas in 2024 it is 589 million. In Nepal, the prevalence of prediabetes is 9.2 and the diabetes is 8.2, showing the shift towards the non-communicable disease, causing ocular complication like retinopathy, papillopathy, cataract, and glaucoma too. Now, early retinal neurodegeneration can occur before visible diabetic retinopathy. Now, how can we detect? One of the means is by OCT. Now, how OCT is helpful? The OCT enables the early detection of subtle retinal and optic nerve changes with high precision. These were my objective of study. As you see, the primary objective to assess the optic nerve head, ganglionic cell complex, retinal fiber layer in patient with type 2 diabetes mellitus with no retinopathy using OCT. To compare the optic nerve head, DCC, RNFL between the non-diabetic people and people with type 2 diabetes mellitus without retinopathy. The secondary objective was to correlate ONH, DCC, RNFL with IOP and metabolic blood parameter. The material and methods, the type of study was a cross-sectional comparative study. A duration of study was 1 year. The population participant, the patient with age 40 or more with diabetes mellitus without retinopathy, age mass control without retinopathy. The sample size were 110, 55 case and 55 control. This is the flow chart. These were the flow chart of my study. On result, the mean age of case was 52 years, whereas the control was 49 years. The maximum number of the both case and control group had visual acuity of 6.6 and followed by 6.9. The comparison of retinal fiber between case and control, as you see, the inferior nerve fiber layer of right became significant, whereas rim area of right eye, coptic area of left eye was also significant, and rim area of left eye was also significant. The DCC came significant, except the inferior DCC of right eye. The 55 diabetic without retinopathy, no correlation was found between optic nerve head, DCC, RNFL with metabolic parameter and IOP. On discussion, the inferior RNFL quadrant of right eye was significantly thinner in diabetes, indicating early localized neurodegeneration. The previous study also reported the sectoral RNFL thinning and asymmetry in diabetic patient. The significant optic nerve head alteration was found in diabetic without retinopathy. suggests the early structural optic disc changes preceding vascular damage. Significant GCC thinning observed in diabetes without retinopathy, indicating the early retinal new generation. The finding aligns with the previous study. Now coming to the conclusion, diabetes mellitus was found to introduce early neurodegeneration changes in retina, even in absence of clinical visible diabetic retinopathy. Highlight the value of OCT as sensitive tool for detecting preclinical retinal and optic nerve weight changes in diabetic without retinopathy. Early detection through OCT allows the timely monitoring and potential intervention, helping to prevent the progression to sight-threatening stage of eye disease. Now coming to recommendation, the further research should adopt a longitudinal design with a larger sample size to establish the causal relation and validate the early OCT detect changes in diabetic eye. These are my references. Thank you.
Thank you so much, Dr. Vinay, for this informative talk. Now, I would like to call upon our NVR's president, Dr. Sayam Bajimaya sir, to give his view, and the room is open for discussion now. Thank you.
Yes. Thank you, all the speakers. Very good presentations and nicely presented. I have just the floor is open. Questions for anyone. If there is any questions from the audiences, please. So I have one question to Dr. Chandra. I think he nicely presented. Where is Dr. Chandra? Okay. So do you recommend the IC simulator for residency training in Nepal? Like, is it really worth? Like, you have been through the IC simulation training for both enter-segment and poster-segment. Do you recommend it?
So this FECO simulator and retina simulator, it was installed in BPK Alcius a few months back, like 6 months back. Initially it was planned to install only FECO simulation, but I was a beginner in retina fellow, so for 1.5 months it was also installed there. So yeah, definitely it is very much helpful for younger generation like us who are starting new in fellowship or in residency program. Yeah, residents in BPK Alcius right now, they are doing fabulous job in FECO simulation. And they are now moving towards patient's eye. And for me also, it helps me to reduce tremor, proper depth perception in posterior segment, and tissue touch. It helps me very much so.
And do the residents are allowed to do the FECO in the human eye or not?
Right now, I am not aware of that, but they are shifting towards human eye after completing their course in FECO simulation.
This is very important for our aspect in society also. Like, you know, this association, our society should also give a guideline for residency training, whether to incorporate a FECO emulsification, because in many centers in India, I think they have already started teaching FECO. So since BPK Alcius is pioneer for having an eye simulator, I think undergoing through the eye simulator and doing a FECO in the human eye, I think it's really worth. And it should be the protocol, I think.
So
Somnath is there. Do you have any comment, Dr. Somnath?
So I am very much thankful to BPK Alcius team for providing this platform. Thank you.
Yes. So as Dr. Sanyam correctly said, in Arvind also, they initially used to train on both sides, but then I think by the time I was about to leave around 2019, they have brought this simulator and in their Coimbatore branch. And since then, it became so helpful for the fellows and the trainees. Now they have a simulator, I think, practically in Madurai, Tirunelveli, as well as all 3 branches. So yeah, so that shows, as you rightly said, it is really helpful for people to, because we also used to think that if you don't do it on a physical eye, if you're just doing a digital simulation, how will it help? But as time has shown, somehow it really helps. Thank you. Yeah.
Thank you. So any questions from the audience for Dr. Giria, please?
So regarding how will you calculate the cumulative dose of hydroxychloroquine? Do you consider the body weight, body mass weight, and the age of the patient? Because once you have started, the damage is a long-term process. So when the damage starts, by decreasing the dose also, you are not going to benefit the patient. Either you have to completely stop the patient. So before starting and before doing pre-investigations like OCTA, and if there is no maculopathy, what are the things do you consider before starting the hydroxychloroquine?
Right. For the cumulative dose, actually, regarding the cumulative dose, the previous school of thought was to calculate the ideal body weight of the patient to calculate the cumulative dose. But now, because nowadays the SCQ, they say the SCQ also deposit in the fat tissue, so they have ignored the ideal body weight and they just take the real body weight of the patient to calculate the cumulative dose. Even calculating cumulative dose, so we do not take the weight in that matter. We just multiply by the milligram to gram, then just convert accordingly. So, now we are saying in our study we are saying actually the guidelines say if the patient the cumulative dose is more than 1,000 grams, then the patient needs to get screened frequently. But in our case, even in 500 around 600 cumulative dose, the patient is getting hydroxychloroquine definite retinopathy. So that's an issue. So we are working on that now. So I think in the near future we'll publish an article about that.
Thank you so much. Since we started a little late, so we're running out of time. So we hand over it to the task, Dr. Mechi.
Thank you so much, sir. Now, I would like to request our NBRS President, Dr. Sayam Bajimaya, sir, to felicitate our chair, Dr. Gyanendra Lamichhane and Dr. Ranju Bharail Sitola, ma'am. Please, sir.
Certificate na focus karakin.
Dr. Gyanendra Lamichhane. Big round of applause for him, please. Now I would like to call Dr. Ranju Bharail Sitola, ma'am, to take her to.
Okay.
Dr. Amit Basala.
Inside में होंगे. Okay.
Dr. Chandra Bahadur Shrestha. Dr. Sumit Singh Maharshan. Dr. Priyanka Singh. Dr. Vinaya Kamath.
इनके साइड वाला खींचना है कि अलिक पर वाला खींचा रहता है तानेर खींचा 70-200 मगाऊ 70-200 छैन
अनि अरूतिर भ्याउँदैन
70-200 70-200 हालेर खिच्छ यहाँ उभिएर लाइभमा देखियो यहीँ उभिएर खिच्दा भइहाल्यो नि अर्को क्यामेरा छैन
अर्को चलाउनु
अनि उतापट्टि अर्को छैन
We are shortly going to begin OCT angio's instruction course. So for that, all the participants are requested to join this hall A. All the participants for instruction course OCT angio, please join at Hall A. morning and warm welcome to all delegates and participants to this OCT Angio instruction course. I'm Dr. Subhas Pokhrel, currently working as a consultant VR surgeon at Navodrishti Eye Hospital, Iteri, Biratnagar. So our panel of instructors are Dr. Somnath Chakraborty. He is consultant VR surgeon at Retina Institute of Bengal. Myself, Dr. Subhas Pokhrel, and then Dr. Subhas Bhatta is working as a consultant VR surgeon at Drishti Eye Hospital, Birtamod, and Dr. Bipisa Shrestha, she is consultant VR surgeon at Siddhi Eye Care Center, Birganj. So I would like to welcome you all to this instruction session. As we are already delay of time, without any delay, I would like to welcome on dash for our first instructor, Dr. Bipisa Shrestha. She is going to present on fundamentals of OCT angio.
Namaste. Today I'm Dr. Bipisa Shrestha of the Eye Center. I'm going to start my instructional course on OCT angiography. So I'll be talking about the fundamentals of OCT angiography.
Okay, I'll be talking about the fundamentals of OCT angiography. Coming to the types of OCT, initially there was the the time domain, followed by the spectral domain. OCTs came into the view. Later on, came the in-phase OCT, followed by swept source OCT with a deeper penetration and enhanced depth imaging, which had a deeper penetration up to the choroidal layer. And then came the OCT angiography, which we are going to talk about. It was launched in 2014. So these are the various pictures showing the advancement, and we have talking about the OCTA, which gives a 3D imaging system. So OCT angiography is basically an extension of OCT, which can be achieved by repeating multiple B-scan at the same location for around 7 to 8 times. And then we look for the changes in between the two scans, which is caused by the motion contrast. And this is a new, non-invasive, rapid and dye-free 3D imaging technique, which images the microvasculature of the retina and choroid, giving a 3-dimension scan, which takes approximately around 3 to 6 seconds to obtain. So it provides a volumetric angiographic image in a matter of seconds, being very quick. And it has the clinical capability of specifically localizing and delineating pathology, along with the ability to show both structural and blood flow information in tandem. So it is safe, it is repeatable, it is reproducible, and has no side effects. And there's potential application is mainly in the retinal vascular diseases. And the first study was done in 2014. So what are the principles of OCTA? It is based on motion contrast imaging of the RBC movements that are seen within the blood column on sequential OCT B scans, which are performed repeatedly at the same retinal site or the choroidal site to show the presence of the blood vessels. And this is by the laser light reflectance of the surface of the moving blood vessels. They will depict the vessels and to the different segmented areas of the eyes, and will therefore there is no use of any intravascular dyes in these cases. And this OCT retina will consist of multiple A scans, which when done repeatedly will give you a constructive B scan imaging of the structural information. Like this is a scan of the OCT depicting the different layers of the retina. And when OCT along with the time dimension is used, then we get an application of OCT angiography. So when you repeatedly scan the same area in different, and the differences which can be analyzed over time. So this is the main important thing you should know. And they are used to detect the zones which have a higher flow rate or a lower flow rate. Sometimes with a higher flow rate, you can see the changes between the scans. And if there is very slow or very no flow at all, sometimes there will be similar scans, so they can be missed out. So this is a picture of the various cross sections showing the in-phase OCT. And the OCT-A will compares the decorrelational signals, that is the differences of backscattering of the OCT signal intensity and amplitude between the sequential scans at the same cross-section and give you the map of the blood flow. So it requires a higher imaging speed than the OCT. And using the motion contrast to detect the OCT-A, OCT data, so you take two differences between the OCT-B scan, and then you find the difference between them is measured as a flow signal that can be seen as the red dots in this picture. So OCT angiography is basically a flow information at a fixed point in time. So coming to the anatomy, we have to know the anatomy of the retina and choroid of the blood vessels. So the inner two-thirds of the retina is supplied by the retinal blood vessels, whereas the outer one-third is the avascular zone. So in the inner two-thirds, it is up to the outer border of the inner nuclear layer, which is supplied by the retinal blood vessels. And in these 4 layers, they are divided into the 4 papillary capillary plexus for our anatomical application in OCTA. So basically, it is a nerve fiber layer capillary plexus, which lies in the retinal nerve fiber layer. Then second is the superficial capillary plexus, which lies in the ganglion cell layers up to the inner plexiform layer. And this the intermediate capillary plexus is up to the inner border of the inner nuclear layer. And the deep capillary plexus, it is up to the outer border of the inner nuclear layer. So according to these, the retina and choroid anatomically they are divided. So the superficial plexus will comprise of the retinal nerve fiber layer and the ganglion cell layer. The deep retinal plexus will be up to the inner nuclear layer. The outer retina being avascular will have no retinal, no vascular vessels will be seen. And in the choriocapillary and deep choroidal layer, the larger Hattler and Sattler layers can be seen. So this will basically help to localize the pathology according to the level. And an in-phase OCT slab, so it's like flipping a picture, pages. So if you go, the deeper you go, you get the deeper pictures. So in the first picture in the left-hand corner, you can see the superficial plexus up to the IPL. Deeper one, you get the deeper plexus. And the outer retinal zone is seen as black because there's a vascular area. So when you go to the choroid and the choroidal capillary areas, they have bigger, large black spots because of the larger vessels. So this is in OCTA. There's a 3 into 3 millimeter and up to 6 by 6 or 8 by 8 and the 12 by 12 millimeter scan cubes are done, and they are segmented into these 4 zones based on this anatomy. So the superficial retinal plexus, mainly we see the foveal or vascular outline and the vascular pattern, especially in diabetic retinopathy. In deeper retinal plexus, we talk about the capillary vortex and the microaneurysms and in other type retinopathy features. In outer retina, mostly it is for the choroidal neovascularization detection. And in choriocapillaries, you see any flow void that is in the AMD. So OCTA can be also applied in glaucoma, but we'll be mainly focusing on retina in this session. And we should always correlate the OCTA with OCT. So if you give a small angioscan, so they'll give you a better resolution about the pathologies. Whereas when you give larger scans, they are giving you the extrafoveal pathologies and are not used much right now. So there are other wide field angiographs that can give you a bigger, larger views as well. So talking about the normal qualitative OCT angiography, so the the left-hand side, you can see the superficial vessels are seen, whereas in the second is the deeper capillary plexus, in the third is the vascular area, and the fourth is the choriocapillary. So we can see the OCT image in the lower section and the OCT angio image. So we can compare the two, and then we can come to a conclusion. So when you do this cross-sectional view, and in the last we can see the yellow dots. These are the decorrelation that is seen, and the full thickness OCT. Depth related, you can see this red images are because superficial, green is the deeper, and yellow is the the cross-section image. So you should always remember that if you miss the changes of the blood vessels, if it's faster or slower, then you can change the scans. So OCT, actually you can miss the areas where there is very slow blood flow, and increasing the time between the 2 OCT scans will help you to give a detection of the flow between them. So these flows are actually caused by the column of blood. So any other movement other than this can also cause artifacts. So sometimes there is There are other methods to remove these artifacts, such as like eye movement, saccades of blinking, that will be talked on later on. And the lateral retinal blood vessels, which are seen in the choroidal area, they give a ghost image or the shadowing effect. And that is usually in the choroidal layers. So this is a picture showing the choroidal vessels that are appeared dark. So in this, there's two methods to detect the motion. That is, one is amplitude decorrelation, which detects a difference in amplitude between the two scans, and there's a phase variance that is related to the emitted light wave properties and the variation of phase when it intersects the moving objects. So there's a split spectrum amplitude decorrelation technique and volume averaging methods which help to improvise the visualization and reduce the background noise from small eye movements. So currently the Octa devices, they are available as Zeiss, OptiView, Topcon and Heidelberg. So talking about the Zeiss, there's a usually HD OCT having 68,000 scans per second. They're fast tracked and to see the dimensionals. So OptiView, this is having split spectrum amplitude decorrelation, giving quantitative analysis. And the other is Topcon, which includes the detection of the low blood flow. And the Heidelberg, they give better signal to noise ratio. So these are the various OCTAs. And when you come to the quantitative parameters, they are not much used because they're not easily available. And they are used to quantify the vascular features like density and morphology. So they take into account the vessel density areas that can be seen, that is the black areas, that is a vascular area, and the white pixelated areas being the vascular areas. So the ratio can be seen, and they are seen as skeletal density is also there. And other is the vessel diameter index, which is the ratio of vessel area density divided by vessel skeletal density. And then we see the foveal vascular zone and size and a non-perfusion area. So this is a picture showing the skeletal density area. So with these grading, normally foveal vascular zone is around 0.2 to 0.35. So with the changes, we can detect the pathologies. So this is an OptiView scan showing those quantitative analysis. And this is like showing the foveal vascular zone. So when you come to these measurements, they have repeated scans, and we can see the peripheral, like we can see the peripheral foveal vascular zone in millimeters, and we can detect it, and we can measure the size and then see whether the pathology is increasing or decreasing or static. So we can measure similarly the flow areas. The non-flow areas can be measured also, which can be used in diabetic retinopathy, vein occlusions, and these are and the others is a vessel density map that can be used to be seen in retina in the superficial and deep vascular complex, whereas in the optic nerve head for the glaucoma, and in the normal OCTs, normal levels can be seen, and comparing with the normal values, we can say whether it is any abnormality is there or not. So I'm not going into details of the glaucoma. So the advantage of OCT is this is non-invasive, fast. There's a motion contrast to detect the moving object without the use of a dye. It gives you a 3D imaging and gives both structural OCT as well as OCTA imaging to detect the tissue structures as well as the blood flow simultaneously, and detects real-time imaging for saccades, blinking, and drifting. The limitation is that it requires a clear media, and it is difficult in cases of corneal haze, where there's dense cataract, vitreous opacity is a hemorrhage, or there can be artifacts also. And the one thing is that it has a limited field of view, and compared to the FFA, it cannot detect leakage. So to summarize, it is OCTA is a non-invasive, quick dye-free motion contrast of the layers of the retina and choroid, giving you the 3D imaging of the various layers, and understanding the anatomy and choroid is important for interpretation. It's valuable in diabetic retinopathy, AMD, vein occlusions, uveitis, and glaucoma. And mostly we must correlate clinically and also be aware of the artifacts that may lead to misinterpretation. Thank you.
Thank you, Dr. Pipisa, for talking on fundamentals of OCT angio. Now, I would like to invite Dr. Subhas Bhatta to present on image acquisition and artifact management in OCT angiography.
presentation. Good morning, everyone. Thank you, Dr. Bipisha, for providing the overview. Today, my topic is about artifact minimization. As we all know from the Dr. Bipisha's presentation, also OCT angiography was introduced in 2014, but it still hasn't been used as a standard of practice in many places because of some challenges. One of the major challenges with OCT angiography is the artifacts that we see in this image and how to interpret them. There are artifacts in optical coherence tomography scans too, but like with use, we have gotten used to understanding these artifacts and we are better at utilizing them, and it's not a big challenge nowadays. However, with OCT angiography, it's still evolving and we'll need a lot of time and work to understand these artifacts and also to standardize the findings in OCT angiography. Because of time, I will not go much detail into image acquisition. Maybe we'll do this in a demo part. This is a normal Octa printout from an OctoView machine, which is showing different layers of eyes. The top 4 parts are the unfast images of the flow. Then the bottom one, left is that side, your side, that the right side is the structural B scan with the angio overflow, and the other one is just the structural B scan. The lower part are some of the quantitative data which are available in some of the machines and which are still lacking in other machines, so it still needs to be standardized. When you talk about artifacts in OCT angiography, the most significant 3 artifacts I consider are the motion artifacts, projection or reflection artifacts, and the segmentation artifacts. There are some other artifacts like masking of artifacts, shadowing artifacts. There is decorrelation of tail artifacts and also mirror artifacts, but we'll mostly talk about the more important ones in this presentation. So motion artifacts can occur as a white line effect or a checkerboard effect, and sometimes when the machine tries to correct these artifacts, that also produces some artifacts, like we can see vessel doubling or stretch artifacts. So in this image, you can see maybe like whether you can appreciate it or not, you can see that there are some of the vessels. Just a minute. Sorry for the technical problem. If you can appreciate in that image, there are some of the vessels that have been doubled. So this is basically due to the motion artifact. And in this image, you can see a checkerboard kind of pattern with horizontal and vertical lines. These are commonly seen in the motion artifacts. If you try to interpret this kind of images, you will end up giving false results. So we have to be careful of these artifacts. This is another image of one of my patients who had a lot of motion artifacts, and you can see at the topmost part, if you can see it from there, the scan quality is just 3 out of 10. So and one important part is to always check for your scan quality before trying to interpret it. Another type of artifact is a projection artifact, which can also occur from structures from above that layer projecting into bottom layer, and sometimes also from the bottom layers projecting upwards, especially in cases of RPE atrophy. You can get projection artifacts from the choroidal layer into more superficial layers too. This is in this image, like if you can see, this is a fairly nice image. Scan quality is 8/10, but if you look at the second image, that is the deep capillary plexus, you will see some large vessels in that region. So those vessels are projection from the superficial layers, and you can also see a kind of vascularization kind of. So I think this is too dim. Okay. So if you try to, you can look at the foveal vascular zone, you might see some signs of suggestive of vascularization, but that's also some kind of artifact. So when you have motion artifact, it also increases the projection artifact. Herein you can see in the deeper capillary plexus, you can see a lot of vessel-like structures. If you look back into the superficial layers and try to correlate with them, you can easily know that these are like projection artifacts and not the flow in that particular layer. In most of the Okta machines now, we have a software algorithm called projection artifact removal, and it is automatically enabled. So our newer machines are getting better at removing the projection artifacts. It's not as big an issue as in the early days of Okta imaging, but still you have to be careful about this projection artifact. And if you have a PAR, for example, in this case, on the first row of photographs, you can see type 3 CNBM, type 1 CNBM, and with some other bezels. When you put the projection artifact removal algorithm, the vascularization is much more clear after removing all the other projections from other layers. So if you have projection artifacts, like use the projection artifact removal software if it's available. If you think something is it's a projection artifact, go back, do a sequential checkup, means go and check the layers above that layer and below that layer and see if those layers are projection or real flow data. And you can always check that with the structural OCT images. The most important artifact that I consider nowadays in OCT angiogram is the segmentation artifact. If you try to analyze the OCT angiography image just by the printout of the machine, more often you will land into trouble because you will get wrong results. So it's better not to just look at the output data, but also check all the other correlating images and make an opinion about that. So this is a very good image, like 8 by 10 quality, and you can see the layers are nicely segmented as Dr. Pasha showed before, and you will get fairly good results in this kind of output. But if you have something like this, lot of intraretinal edemas, the machine may not be very good at finding out the right layers because they have been deformed. However, with newer machines, it still does quite a good job. Like this is the machine segmentation, and it has found most of the layers in the correct areas. But what about this? It's more deformed. Now the machine is confused. It's showing lines at all the wrong places, and you just try to see the unfast images at the top. You will see there are a lot of ischemic areas in the deep capillary plexus and the choriocapillaries. That's not true because the lines are passing through the large cystic space, which are giving this kind of ischemic areas in your image. So if you just look at the segmentation of the machine, you will find out a lot of the problems with that image and come to a right interpretation. So similarly with this image, for example, this is one of my patients where you can see in the third image at the top, in the avascular area, there is some kind of flow signal. Now, if you go and check the segmentation and look at the line, the black line at the bottom, that should be under the RP, is notching a little bit down in that flow area in between. I'm sorry for the poor quality of the video images, but that, what's happening in the avascular layer is while segmenting, the machine has taken the line of the RP a little bit down. So the flow from the choriocapillaris area is projecting to the avascular area, and you might confuse this for the CNBM, which it may not be. So what you can do is go and check your structural B scan with angio overlay. So if you scroll down that image, you can go through the B scan and check your relevant area whether there actually is a flow or it's an artifact. So when we go through this B scan image, we don't see the corresponding area of flow, Whereas in one of the PEDs here, you can see a small notch of flow right here. So what we can do is, then you can go and make your custom slab. A custom slab is like you remove the segmentation, you do your segmentation yourself. You make a slab of around 30 to 60 micron size and scroll that over your structural overlay to see the area of interest. If that area has a flow, it will show on the on-fast image. Here, just at that red point under a small PED, you can see a small flow, but in other areas, I couldn't see the flow that was shown in the on-fast image in the first image. So I'm pretty sure that area is not area of flow. This is a small image, this can be a small harboring type 1 CNBM, but we need to follow up the patient, but not too much to do at this point of time. So similarly, in this image, you can see some flow signals from your superficial and deep capillary plexus. Is this a type 3 CNBM? But if you go and check the segmentation given by the machine, you can clearly see that the machine is taking the segmentation at that large PED. And the flow from that area is showing up in superficial and deep capillary plexus. Now you can change your segmentation yourself in the OCT machine. It is little tedious, but you can do it. Like in general clinic, like I find it really difficult. It takes a lot of time. But if I try to do a manual segmentation, I change the segmentation in this case, and I was able to avoid that flow signal from the superficial capillary plexus, but I didn't do a good job. I got the flow signal in the deep capillary plexus. But now, next, that's why what I generally prefer is a custom slab. I make a custom slab, go through all these areas, and when I slide that slab over that PED, I can clearly see that in the structural OCT with the angio overlay, there is a flow signal at the bottom and corresponding flow signal in the on-fast image at the top. So giving me a diagnosis that this is a vascularized PED. You have an image like this, a hyperreflective layer passing through all the layers of retina. How to approach this OCT image with an OCT angiography. I do the same thing. I make a slab. I look at the structural OCT with angio overlay and try to get my slab through those places. So if you look at this slab where the green lines are passing, there is a flow signal in the structural OCT. And at the same point, you can see a kind of a dilated vessels in this area. Now I follow it with another place where I get a flow signal in the structural OCT, and I see a small amount of flow in the on-fast image. There is some projection artifact in that area. You have to be aware of that. But when I go down, just at the RPE level, I can see a neovascularization pattern. So this can be a case of a retinochoroidal anastomosis or a RAP lesion. We might need to follow up with other investigation, but it gives you a pretty good clue like which direction you need to go. So there can be some other artifacts like masking or shadowing artifacts which are sometimes used interchangeably. Masking happens when there is a media opacity and the flow signals are attenuated, giving you a fall impression of low flow. Shadowing can be due to different lesions in the retina itself, which can decrease the signals from the layers below them. So this is an image published in one of the articles where you can see that the hyperreflective material is providing a masking effect on the layers below it, especially in the choriocapillaris layer, which is segmented in red lines. So this is OCT angiography from one of my patients who presented with some intraretinal hemorrhages. And when I look at the OCT, I feel like there is loss of flow in the choriocapillaris and like retinal vascular layers too. But when I follow up it with structural OCT, you can clearly see that the intraretinal hemorrhage is providing a shadowing effect which correlates to the loss of flow in the on-fast image. So you always need to correlate your structural OCT with angio overlay with your on-fast images. That will give you a good idea. There are some other artifacts which have been published in different studies, as this is one of the commonly known artifacts, which is an artifact that shows a flow around the PEDs when there is none. This is because of compensatory mechanism of OCT angiography to get the over the PED area which doesn't show any signal, and that results into increased signal around the PEDs. But if you look at the structural OCT in this kind of cases around the PED, you will not see a flow signal in the structural OCT. So this is another of my patients where you can see a kind of a flow signal in the vascular zone because of similar reasons. It's an artifact. So what I want to stress out here is OCT angiography is still plagued with a lot of artifacts, but that's not a reason to avoid it, because like with any kind of new imaging technologies, more you get used to it, more you sit with your machine, more you see your images, you become better at understanding what are the artifacts and what are the real results. So the first important thing is to always acquire a good image with RP aligned horizontally. That will give you the best results. Then check the segmentation provided by the machines. Always keep your eye tracking on. A lot of machines come with eye tracking. Use multi-scan averaging if available. That reduces the noise. Use projection artifact removal in your machine. And as I said earlier, spend more time with your OCT to understand your OCT angiography images and artifacts. Thank you.
Artifacts are always misleading and it will lead to misinterpretation. So artifact management and minimization is the most important part in OCT angio. Thank you, Dr. Subhas, for explaining us the artifact minimization and management. Now I would like to invite on stage Dr. Somnath Chakraborty, sir. He will be discussing on clinical experience and interpretation of clinical diseases in OCT angio.
So good morning, and at the outset, thank you, Subhash, for making me part of this OCTA instruction, and thank you, NOS, NVRS, and Mechi Eye Hospital for the invitation. So already Dr. Bipisha and Dr. Bhatta has beautifully introduced us to number one, what actually is the principle behind OCTA, what is a normal OCTA, and what are the possible artifacts. Now I will just try to share with you how we use OCTA in our clinics. So this is, of course, a lot of it is my personal experience. Maybe other doctors use it a bit differently. Also, I purchased Heidelberg's HRA OCT angiography machine in January 2024. So when I say that my experience with OCTA, it is my experience with the Heidelberg's OCTA, because as Dr. Bhatta, Dr. Vidisha both have beautifully and correctly highlighted, that each OCTA machine comes with some differences. And also the fact that I do only retina. So this particular talk will be only about how we are using OCTA in a retina clinic. So the first and probably the most popular use of OCTA is in wet AMD PCV. So we all know this is the multicolor image and the OCT of a patient with a CNVM. Now we know the OCT tells us what effect the CNVM is having on the retina. So it shows us evidence of leakage, what we call fluid. What OCTA tells you is that, because you can see here, this is the three vascular complexes. The superficial and deep vascular complexes are normal. In the avascular complex, we can see the actual network, which is the CNVM. Now, how does this help? Because if you look at the morphology of the network on the OCTA, you can get an idea of whether it's an active CNVM, because an active CNVM will look like this. It will be a lacy network. There will be a lot of small vessels. Whereas an inactive CNVM will look something like this, called a dead tree appearance, where you have these large branches, but those small closed networks are missing. Now, how does this help? So by just looking at the OCTA morphology of a CNVM, you can probably guess whether it is still active or not. This, we believe, can help you fine-tune your injections. So we all know that in our real world, it's very difficult to keep calling back patients for frequent anti-VEGFs, and we keep trying to find a way to avoid over-treating, at the same time avoid under-treating. So until now, all the PRN protocols that we have are OCT-based, but we now believe that it's time that we also include OCTA while deciding when to repeat our injections. So let me share with you one example. For example, this 61-year-old diabetic patient, you can see a classic CNVM. The lacy network is clearly seen. So we treated her with brolucizumab. This is after 1 month. You can see on the avascular complex that the network is gone. And this is actually something we have seen again and again with brolucizumab. The network really disappears. Now by the 3rd month, you can see the hyperreflectivity is coming back, and it correlates with a small pocket of subretinal fluid on the OCT also. But the patient's vision was 6/6. So though we suggested brolucizumab to the patient, saying that your CNVM network is recurring, but because of the good visual acuity, she did not take the injection. But she came back after another 2 months, and by that time her vision had dropped to 6/18. And you can see also now that the OCTA clearly showed enlarged network with significant SRF on the line scan. So we gave her the second brolucizumab, and this is again after 1 more month from the second injection. And you can see now again the network has disappeared. Also the fluid has gone. But by the 10th month from baseline, you can now see there is no fluid on the line scan, but the OCTA was already showing that the network is coming back. And this time we could convince her, and she has now taken the 3rd injection. In other words, in your practice, you can use the Octa along with the line scan of the OCT to decide when to inject, and this way, you can actually pick up the activity even earlier. The second common disease that we all handle in our retina clinics is, of course, diabetic retinopathy, and that is also a place where Octa finds some unique uses. For example, this is the best way to pick up preclinical diabetic retinopathy. For example, look at this patient. Now, this patient's multicolor image looks normal. The line scan or the OCT also looks normal. Now, if we look at the superficial vascular complex, it too looks normal. Because we know DR doesn't start from the superficial vessels, right? It starts from the capillaries. But when you look at the deep vascular complex, where you can see the retinal capillaries, you can make out the enlarged intercapillary distance, those small pockets of capillary dropouts, which tells you that even though the patient has clinically no DR, but diabetic retinopathy has already started in such a patient. The second is, of course, to diagnose ischemic maculopathy in a non-invasive manner. For example, this patient kept complaining of poor vision, and he also had CKD, but on the multicolor image as well as on the line scan, you don't see really anything. But if you look again, go back and look at the Octa, the superficial vascular complex was more or less normal, but the deep vascular complex clearly showed the distorted foveal avascular zone with enlarged intercapillary distance, intercapillary space, as well as capillary dropouts, explaining why the patient was having the vision problem. And we know in nephropathy, macular ischemia or ischemic maculopathy is often associated. The third interesting use of Octa can be to differentiate new blood vessels, new vascularizations from IRMA, intraretinal microvascular anomaly. Traditionally, we differentiate between the two by looking at angiography. In IRMA, you don't expect a leak. In NVE or NVD, you expect a leak. So let's see this patient. This is, of course, a case of PDR. You can see there is a preretinal hemorrhage and there's an NVD also. But you also see there is some vascular anomalies on the on superiotemporal to the fovea. So is this an NVE or is this an IRMA? So you can just look at the line scan along with the on-fast view to confirm the same. So this is another proof another situation which tells us that when we are analyzing an Octa, we shouldn't just look at the on-fast views. We should also look at the line scan. So IRMA is inner retinal microvascular anomaly. And you look here, if you look at the line scan along with the flow overlay, you can see that the flow overlay is inside the retina. It is not projecting out into the vitreous cavity. So that means this vascular anomaly is IRMA. Whereas look at this patient here, we can again see a vascular loop superiotemporal to the fovea. Now here we did that, go back and look at the line scan, and here you can see this vessel is projecting into the vitreous. It is extraretinal, therefore it's an early NVE. So even without doing an FFA, you can make out, especially if you can pick up that vascular anomaly within your scan area, then by just looking at the on-fast view and also at the line scan, you can pick up whether it's an IRMA or a new vessel, early new vessel. But then there is, of course, a word of caution, as Dr. Bhatta has so beautifully shown. Look at this patient, a clear-cut case of an NVD. But if you look at the superficial vascular complex or the deep vascular complex near the optic nerve, it doesn't show any abnormal vessel. So the reason was, if you look at the segmentation inferiorly, you can make out that the segmentation actually was inside the retina. It was not at all passing through the NVD. So you alter the segmentation slab manually, which Dr. Bhatta has so beautifully explained, and now you can see the entire vascular loop, the entire NVD. So when you are looking for abnormal vessels, you may end up seeing vessels which are not there or missing vessels which are there if you do not check for segmentation error. A third disease where again Octa is very useful is retinal vein occlusion. So here we can study the effect that the occlusion is having on the different vascular complexes by the Octa. So unlike FFA, where you get just a two-dimensional view, and once the dye starts leaking, you basically cannot study the vessels in detail. In Octa, because it's a non-dye thing and depth analysis is possible, so we can actually study each and every vascular complex separately. For example, in this case of STBRVO, the OCT shows there is fluid, but if we study the superficial vascular complex, we can see there are small areas of capillary dropout, but not that much damage. You go and see the deep vascular complex, and now you can see the extent of the damage that has been caused by the vascular complexes. So when you are treating such a case, and the vision is not recovering as much as you thought it should, maybe by checking your octa, you can make out whether there is much more damage in the middle of the inner retina than you could make out clinically. Of course, in vein occlusion also, you can use octa to pick up macular ischemia. For example, in this case of an old minor BRVO, the OCT appeared normal, but when you looked at the deep vascular complex, you can see the extensive foveal avascular zone ischemia, or the dropout, capillary dropout near the foveal avascular zone, which tells you that this patient likely will have some amount of scotoma. Like we could pick up abnormal blood vessels on DR, sorry, I'll just say one thing again. Like I told you that in DR, that by having a wrong segmentation, we can miss picking up abnormal blood vessels. So similarly, whenever we are talking about picking ischemic maculopathy, please be very careful, especially if you are handling patients with large edema. Again, something that Dr. Bhatta showed. So when we initially purchased and started using the octa machine, almost every case of vein occlusion in the acute stage, we used to find a lot of ischemia. For example, this patient of CRVO, you can see there is so much of gross capillary non-perfusion in the SVC, DVC, as well as the avascular zone. And then you feel, okay, all my cases are probably having ischemic maculopathy. But that is not the case. If you go back and look at the segmentation, which the machine does automatically, you can make out, similar to the cystic case with the cystic changes that Dr. Bhatta showed, that the segmentation is all wrong. So here you have the option of physically actually correcting the segment. And once you do that, and then now you can see, okay, it is not that bad a case of ischemia. Yes, there are some capillary focal areas of dropout, but then you can counsel the patient that yes, there is still a chance of visual recovery post-therapy. The third use in vein occlusion is to, again, like in DR, we can differentiate between IRMA and new blood vessels. In DR, in vein occlusion, we can differentiate between collaterals and abnormal blood vessels. For example, in this patient of a chronic ITBVO, you can see the collaterals were seen so clearly on the octa. Now, if you look at the central macular thickness map, you can see that the inferior part of the macula is still showing thickening. There is heat, there is red discoloration of the macular map. Now, technically, one should then think, okay, there is macular thickness, so let me go ahead and give some more injections. But we know once vessel collaterals have developed, probably the vein occlusion is compensating and we can wait and watch. So that's exactly what we did. And you can see after 3 months that the edema subsided on its own without any treatment. A fourth possible area where octa has been of great help is in patients of chronic or persistent CSC. Now, acute CSC we know is spontaneously resolves in most cases, but in chronic persistent CSC, vision loss is, if we do not intervene, there can be vision loss. Now, what kind of intervention you do actually depends on whether the patient has a CNVM or doesn't have CNVM, and whether it's a pachychoroid neovasculopathy case or just a pachychoroid case. For example, in this case of chronic persistent CSC, you can see there was double layer sign, chandelier sign, as well as SRF, but octa showed in the avascular complex there was no CNVM. So in such a case, you can either try PDT, which is the gold standard treatment, or as we have recently published in clinical ophthalmology last month, that even brolucizumab can have a very good impact, especially if you do not have access to PDT like we don't have in India. However, in this patient, again, if you see another case of chronic CNVM, there was something like subretinal fibrin, intraretinal fluid, subretinal fluid. When we looked at the avascular complex, there was clear-cut capillary choroidal neovascular membrane. In such a case, anti-VEGF is the treatment of choice. In MACTEL, this I just kept because in MACTEL, the beauty is that you can actually follow the blood vessel, exactly like Dr. Bhatta was showing in his case of RAP. So you can see how the blood vessels are dipping from the superficial to the deep vascular complex, And as the retina degenerates further, sometimes even reaching the avascular complex. And this way, the confusion of picking up, of misconfusing these blood vessels which are coming from the top as CNVM can be easily ruled out. Another interesting use which I have started doing is in epiretinal membrane. So in epiretinal membrane, we know the OCT tells us how distorted the anatomy of the retina is, or the macula, how disfigured it is. The OCTA can tell us how disfigured the superficial vascular complexes are. Now what I have been doing is, I have been doing pre-op and post-op OCT, and we are doing a study, the results are not out yet, to just see how much time it takes for the vessels to, vascular distortion to get restored post epiretinal membrane removal. But then one word of caution, like any other test, and most probably anything in life, OCTA alone is not enough. For example, if you have a patient of a center involving DME like this, if you do an OCTA, that will show that yes, there is some vascular anomaly, there are some capillary dropout, but you can't plan your focal laser based on this. So you will have to do an FFA to find the exact leaking microaneurysms which you can do focal laser. Whereas in this another patient, which again had a chronic ITBVO, the OCTA showed presence of collaterals, and as I have shown you a case that if OCTA is showing collaterals, it means that the vessel is, the ITBVO is probably getting compensated. But actually these collaterals, it turns out, were from the old macular VRVO on the top, and if you look at the FFA, the ITBVO, which happened later, is actually ischemic with lot of peripheral neovessels, and because at least Heidelberg OCT cannot cover this periphery, it gets limited to around 6 millimeter. So we still do have to do FFAs to rule out peripheral neovessels and CNPs in similar cases. So in the clinics, OCTA has become a new important diagnostic tool. Dr. Bhatta has clearly showed with beautiful examples that we need to beware of the artifacts, otherwise our interpretation will be wrong. OCTA has become very crucial in not only management of wet AMD PCV, but also diagnosing cases like preclinical DR, ischemic maculopathy. But as of today, with the machines that we have, we still can't say that OCTA can replace FFA. FFA has its own unique place. Thank you so much.
Thank you, Dr. Somnath sir, for nicely sharing your experience on OCTA in various retinal diseases. Now, I will be talking on OCT angiography, advanced application and future directions. So, from history of structural OCT introduction in 1991 to work on motion contrast method and high-speed OCT prototypes set the stage for OCT angio from 2000 to 2010s. And from 2014 onwards, OCT angio came into the practice. OCT angio, as we all know, is a non-invasive method for examining the retinal disease. Advent of OCT angio imaging technology. Numerous clinical studies have explored its applications. It offers simplicity and convenience. So to summarize, it is non-invasive, dye-free imaging, rapid processing, and its accurate blood flow localization makes it common in practice. So, as our previous speakers has already explained about different use in the clinical applications, that is in neovascular AMD, non-invasive detection and monitoring of macular neovascular membranes can be done. In diabetic retinopathy, the capillary non-perfusion, microaneurysm, early macular ischemia, and perifoveal changes, OCT angio complements wide field fluorescein angiography for microvascular details. And besides that, it can also be used in the glaucoma, neuro-ophthalmology, uveitis, retinal vascular occlusion for microvascular metrics, which can be correlated with disease severity and progression. So current limitations and ongoing technical challenges from its introduction of OCT angio are artifacts, which was nicely explained by Dr. Subhash Bhatta. So I'll not be going into details. This is the picture of the OCT angio showing different types of artifacts like motion artifacts, projection artifacts, and in this picture we can see after the resolving of the projection artifacts, the image, and there is also segmentation and attenuation artifacts are shown. So future directions are stronger sweep source OCT angio adoption for deeper and wider imaging can be used, standardized quantitative pipelines and cross-platforms calibration to make metrics comparable, AI-driven biomarkers and prognostic modelings combining OCT and OCT angio with clinical and multimodal imaging for personalized risk prediction can be done. And
improve artifacts operation and real-time quality control built into acquisition by the software. So coming to sweep source OCT angiography, it is deeper and faster imaging method.
Principles is it uses a tunable laser with longer wavelength, typically 1050 nanometer instead of broadband light. Advantages of sweep source OCT angio are deeper tissue penetration, which causes better visualization of the choroidal and choriocapillaries vasculature, higher scan speed, which reduces the motion artifacts and allows larger field of view in shorter time, reduced sensitivity roll-off, and the clinical benefit is it improved imaging of choroidal neovascularization, deep retinary capillary plexus, and myopic degeneration. Here in the picture, we can see the images taken by spectral domain OCT angio and the sweep source OCT angio, and we can see the difference of clarity as well as there is difference in the size also. Now, another one is projection resolved OCT angiography. Problem addressed is traditional OCT angio often shows projection artifacts where superficial vessels are falsely projected into the deeper layer. So the solution for this is projection resolved algorithms which separate true flow signals from projected artifacts using intensity and phase information. Outcome is the clearer layer-specific visualization of deep capillary plexus and outer retina, enabling more accurate pathology mapping. Here in this picture, we can see different spectral domain OCT with projection resolved OCT angio of different threshold like 0.5, 0.7, and 1. And despite increasing projection resolved OCT angio threshold, red pixel percentage decrease between the projection resolved OCT angio threshold like 0.5, 0.7, and 1. Another one is wide field OCT angio. Advancement is larger scan patterns now possible due to faster acquisition and better motion correction. Benefits is that it enables visualization of mid-peripheral and retinal vasculature, which is useful for diabetic retinopathy, vein occlusions, uveitis. Techniques is it uses montage stitching or sweep source wide field optics to combine multiple small scans seamlessly. This is the picture taken by the wide field OCT angiography. Another is enhanced motion correction and eye tracking. By different motion and eye movement, there may be misalignment in OCT angio images, so the solutions is real-time eye tracking, detects and compensates for eye movement during the scanning, orthogonal registration and motion correction algorithms, software averaging and registration, post-processing, aligns and averages the multiple scans for improved signals to noise ratio and vessel continuity. It results in sharper, more reliable vascular maps with reduced image distortion and improved reproducibility. Another use in the future for OCT angio is AI and deep learning. Automated segmentation and artifact reduction. Traditional challenges are manual or rule-based segmentation of retinal layers in the OCT angio is prone to errors, especially in diseased eyes with edema, drusions, or structural distortions. Motion and projection artifacts also compromise the image quality. So AI advancement help in deep convolutional neural networks are now trained to automatically delineate the retinal layers
with high precision even in pathological conditions. Another is artifact reduction. By the deep learning algorithms can recognize and suppress motion, shadow, and projection artifacts by learning from large data sets of images. Disease classification and prognosis prediction can also be done. AI-assisted disease recognition, that is deep learning models can classify OCT angio images into normal versus disease categories such as diabetic retinopathy, age-related macular degeneration, retinal vein occlusion, and glaucoma-based microvascular features. Model extract subtle vascular patterns like capillary dropout, foveal avascular zone enlargement, and vessel tortuosity, features often imperceptible to human observers. It also helps in differentiating non-proliferative versus proliferative diabetic retinopathy by analyzing capillary rarefaction and neovascularization, predicting conversion risk from intermediate to neovascular AMD, assessing glaucoma severity using peripapillary microvascular density, and also helps in the prognosis modeling by the help of AI to predict disease progression and treatment outcomes. In this picture, we can see in the first row is the uncorrected OCT angio images of different layers, superficial vascular complex, deep intermediate capillary plexus, deep capillary plexus, outer retina, choriocapillaries, and the cross-sectional images. And after the projection resolved OCT angio artifact, we can see image variations in different layers of the retina. This is also the picture showing before removal of the OCT angio artifact and after removal of the artifact images. Another future use can be AI-guided anti-VEGF response prediction. Not all the patients with choroidal neovascularization respond uniformly to anti-VEGF therapy. So by the AI approach, deep learning models analyze baseline OCT angio and structural OCT features such as choroidal neovascular morphology, vessel density, flow voids, and lesion maturity to predict likely responders versus non-responders before the treatment. And algorithms can quantify choroidal neovascular complexity, loop versus lacy pattern, and correlate with fluid dynamics over the time. Here in this picture, we can see the choroidal neovascular membrane detected in the choriocapillary segmentation of optical OCT angiography. In this picture, we can see the CNVM margins were selected manually, and observer and the device automatically calculate the size of different sizes in two images. One is 1.215, another is 0.708. So we can see the difference in the size. This is another picture showing the perivascular halo, which was evaluated in the choriocapillary segment of the OCT angio, and the color overlay image of the same patient can be seen. So the clinical benefit is it enables personalized treatment planning, potential to reduce unnecessary injections and optimize visual outcomes. Integration with AI-driven monitoring systems could enable automated follow-up. Another use in the future is OCT angio in the teleophthalmology and screening. By the help of portable OCT angio with AI-based analytics, it can be used in teleophthalmology. Cloud-based image sharing for remote diagnosis can be done, and community screening potential is there. And another use is 3D and real-time visualization. So we can do 3D reconstruction of retinal vasculature, real-time OCT angio visualization, and motion tracking, and the potential use in the intraoperative applications can be done. So the future outlook is integration of multimodal imaging, OCT angio, fundus photo, and AI-based analytics can be done by the correlation, and federated learning framework for secure multi-center data sharing can be done, and real-time AI-powered OCT angio image acquisition for on-the-spot decision support in the clinics can also be done. So to conclude, conventional limitations to OCT angio technology such as field of view, flow detection dynamics range, and image artifacts can now be eluded by different advanced models. Can expect instruments to continue to improve as hardware, and image analysis techniques to improve as more powerful machine learning algorithms are introduced. So OCT angio evolving from static image to intelligent analytics. So the future is wide field, quantitative, AI-driven, and functional OCT angiography as a diagnostic, prognostic, and research tools. Thank you. So we come to the end of this presentation part. Now, in the room number 28, there is the demo and hands-on in the Heidelberg OCT angio machine. If anyone is interested, they can visit there and do the demo and hands-on part. And before that, we'd like to request our NVRS President, Dr. Sanem Bajime sir,
to present token of love to our instructors. Thank you. And I would like to invite on the stage our all instructors, Dr. Bipi Sastries, Dr. Subhash Bhatta,
Dr. Somnath Chakraborty, and myself.
कहाँ हुनुहुन्छ तपाईँ अहिले त्यो सोनीको चार्जर कहाँ छ एफएक्सको एउटा ब्याट्री सकिएर भर्खर अर्को ब्याट्री चेन्ज गरेको छ कि ब्याट्री छ कि चार्जर छ हामीसँग
Participants, please kindly collect yours certificates from me. I am Dr. Srinivas Atal. Now, announcement regarding certificates. Instruction course. Kindly collect your instruction course certificates from
Raju Kesi, Mr. Raju Kesi.
Good afternoon, everybody. Now we'll start with the surgical retina session. I welcome you, everyone, for the surgical retina session of Noscon.
So we are delighted to have so many speakers from our country as well as abroad for this session. And
to make it more important, we have Dr. Taradash sir with us. That is our honor to have him here with us.
I'm Dr. Harimaya Gurung. I'm ophthalmologist from Himalaya Eye Hospital. Now, we'd like to begin this session by inviting our chair. Let us all put our hands together to welcome our first chair, Dr. Somnath Chakravarti sir, to the dais. Dr. Somnath Chakravarti sir, he has an experience over 15 years in vitreoretina. He did his MBBS and MS ophthalmology from Banaras Hindu University. He did his fellowship from vitreoretina in Arvind Eye Hospital, Madurai.
And now he is currently working as a consultant at Retina Institute of Bengal, Siliguri, from 2016 till present. He has 19 plus international and national publications. He has done extensive research on brolucizumab, bevacizumab, Ojurdex, and ROP. He has done his advisory boards in Novartis, Abe, Intas, Alcon, Otley, and Zydus. He has a lot of awards like Satya Hajra Award for Community Ophthalmology, Heidelberg Imaging Excellence Award in 2024. So let's welcome our chairperson, Dr. Somnath Chakravarti sir. We are privileged to have him here to lead this session. Thank you, sir. Our next chairperson for this session is Dr. Purushottam Joshi, sir. He is the Our next chairperson is Dr.
Okay, so without any ado, let us start with our first speaker, and he is Dr. Somnath Chakravarti sir himself again with the optic disc pit maculopathy management.
Optic disc pit maculopathy. So optic disc pit is a rare disease. It was first described by Witte in 1882, but it's a potentially vision-threatening congenital anomaly. It occurs equally in men and women with an incidence of, it's quite rare, it's incidence of 1 in 11,000, and it is mostly unilateral. Now, optic disc pit maculopathy, which is the one which we will be majorly focusing on, occurs in 25 to 75% of patients and is characterized by presence of intra and subretinal fluid with RPE changes. It occurs in more than half of the patients of optic disc pit and usually in the second or third decade of life. Now, what causes this maculopathy is very complex and it is not really fully understood. But let me share some of the insights that we have. So the fluid that I was talking about, which presents in the intra and the subretinal space, first is where does this fluid come from? So there are various possible sources which have been suggested, vitreous being the one which is mostly talked about. But there are also reports suggesting that it is probably CSF, or it may be leakage of blood from the optic vessels around the pit, or even it might be from choroid. So how does this fluid enter the retina? So there are two possible pathogenesis which have been suggested. One is that it is vitreous, which pulls on the pit margin and leads to formation of this, or leads to the fluid entering the retina. The second is that there is a pressure gradient across the pit, which leads to formation of maculopathy. The fact is, however, whichever way the fluid enters, or whatever might be the possible source, once the fluid has entered the retina, it causes a crisis-like lesion in the inner retina first, and then as it proceeds, it causes an outer layer macular hole, and then once that outer macular hole occurs, outer retinal hole occurs, it can lead to serous retinal detachment and further loss of vision. So this is how optic disc pit maculopathy proceeds. Now, how do we manage it? So the first option whenever we talk about a disease is it possible that we don't do anything at all? This question is relevant because in 25% of the cases, optic disc pit maculopathy can resolve spontaneously. However, in majority of the patients left untreated, it causes very poor visual outcome. And therefore, once a patient of optic disc pit has developed maculopathy, we need to intervene. So can we try a combination of laser along with gas? Because optic disc pits are often managed by barrage laser. So can we do that same thing for maculopathies? Well, the answer is no, because the success rate of laser plus gas combination for maculopathy is very poor, very less, with frequent recurrences of the maculopathy, and often there is no improvement in visual acuity. So that's the reason why over the years, vitrectomy has emerged as a treatment of choice, and long-term results are promising, with more than half of the patients gaining visual acuity and nearly all showing anatomical success. But we have to keep in mind that this functional recovery is slow as well as the anatomical recovery. So you will probably see patients actually experiencing some difference only after 6 months from the surgery. Now, a role for ILM peeling has also emerged. This is because the studies suggest that if you peel the ILM, it can increase the chances of anatomical success as well as functional recovery, probably because the ILM, which is peeled and often used to cover the pit, acts as a barrier between the pit and the retinal space. But then the question that remains is, how do we peel the ILM? So here is a video where we have shown the traditional way of peeling the ILM. So the surgery for optic disc pit, which you can see clearly here, initiates like all vitrectomy with a central vitrectomy, and then you do a careful PVD induction, which is a very essential step of optic disc pit maculopathy surgery. Once you have successfully induced the PVD, then usually we stain the ILM with BBG. And now here is how we would peel ILM traditionally. That means doing a wide peel across the fovea. So you can see here, I have peeled it across the fovea, trying to create a large flap, which I intend to then stuff into the optic disc pit. And once you have done that, you do a fluid air exchange and the pit stays. But the problem with this traditional peeling of across the fovea is that because the fovea itself is, as I said, the inner sciatic lesions usually cause an outer macular hole. Therefore, the fovea is weak. And while trying to peel across the fovea, you may actually end up damaging the fovea. Now, in patients of myopic tractional maculopathy and other patients with weak phobia, now our concept has come of doing a phobia-sparing ILM, which reduces, studies have shown, the likelihood of foveal damage. So that is why we did a study, which we published last year, to evaluate if we do a foveal-sparing ILM peeling in patients of optic disc pit, and then used that ILM to plug the pit, was there any improvement in the outcomes? So this was a retrospective study of 7 eyes from 7 patients. So I'll just share one case from that series. So this 51-year-old male who presented to us with complaints of poor vision in his left eye since 8 months. You can see the pit with the optic disc pit maculopathy with the retinoschitic lesions. And the plan was to do a vitrectomy, phobia-sparing ILM peel with ILM plugging of the pit and gas injection. So this is the video. Again, the surgery starts with vitrectomy, followed by triamcinolone-assisted PVD, which is a very important part of the surgery, because after all, the vitreous itself is, according to most people, the cause of all these problems. So you have to remove the vitreous nicely from the pit. So once you have done that, once you have induced the PVD, you then stain the ILM. But now you can see I'm not going across the fovea. I'm just trying to peel away from the fovea and trying to create a flap which I can then use to stuff the optic disc pit. So here we are doing a very limited ILM peel and avoiding the fovea. And then once we have filled that ILM or plugged the pit with the ILM flap, we do a fluid air exchange. So this is the patients after 1 month. You can see now the outer macular hole remains, but the schisis is already less. At 3 months, the outer macular hole, or the outer lamellar hole, I should say, that closed. At 6 months, the retina looked even better with further reduction in the schisis, and this is at 1 year when there was no evidence of any schisis left. So on analysis of our 7 patients, we found that 86% of the patients had improvement in vision, significant improvement in vision, with 1 patient maintaining vision. He had no drop, and there was no case where there was a reduction in vision. Anatomically, the central macular thickness started reducing significantly around the 6th month, and all the patients had successful retinal attachment. And there was complete resolution of schisis in nearly 2/3 of the patients. So the base study concluded that vitrectomy with fovea-sparing ILM peeling and ILM plug appears to be a promising surgical approach, with successful macular attachment in 100% of the cases, significant reductions in CLT, resolution of the schisis in 71%, and visual improvement in most cases with minimal complications. So to conclude, management of optic disc pit has evolved significantly over the years, and given the progressive vision loss associated with maculopathy, optic disc pit maculopathy, observation is, or conservative approach is not really adequate. And now the role of vitrectomy is established, and ILM peeling can enhance the success of in your anatomical success, but doing a traditional ILM peeling carries the risk of possible foveal damage. So this concept that now has come, and we have also seen in our study that doing a fovea-sparing ILM peeling and plugging the pit with the ILM appears to be very promising. Thank you.
Thank you, sir, for beautiful videos. You never stop to amaze us with your beautiful presentation and video. Thank you so much, sir. Now, I'd like to invite our next speaker, Dr. Sanjita Sharma. She is the vitreoretinal surgeon from Tilganga Eye Institute of Nepal. She'll be talking about hidden retina, visualization through the scope, not the microscope, peripheral exudative hemorrhagic chorioretinal. Sorry, hidden retina, visualization through the scope, not the microscope. Up to you, Dr. Sanjita. Thank you.
Thank you, Dr. Arimaya. Good afternoon, everyone. And at the first, I would like to thank Noscon for accepting me in the talk here. It's not being projected. Please, someone can. Excuse me. It's not working. Kam गरेन. Today my topic is hidden retina, visualization through the scope, not the microscope. So this is a journey into advanced visualization for ophthalmic surgery. I am Dr. Sanjita Sharma, consultant cataract and vitreoretinal surgeon at Tilganga Institute of Ophthalmology. So today I'll be talking about the unseen, the visual limitations of traditional microscopy. Though we've evolved from 1946 to till date in the conventional microscopic surgery with the advancement in optics and the eyepieces, optical fibers, from starting from loop to binocular microscope to 3D visualization, we still have the unseen visual limitations of traditional microscopy. The standard operating microscopes, while providing superb central and posterior pole views, inherently struggle with the anterior and far peripheral retina associated with challenges in visualizing the ciliary body processes, difficulty assessing the status of the peripheral retina, particularly in phakic eyes, obstructed views in cases of small pupils or corneal opacities, and reliance on indirect techniques that can be cumbersome and restrictive. So we must seek tools that abolish the blind spots, ensuring comprehensive assessment and treatment across the entire intraocular landscape. So this is a picture of myself operating through a conventional microscope where my head posture is bent downwards. I'm operating and looking in a 3D visualization of the eye. Whereas in this picture, this is the setup for an endoscopic surgery where you can see a far ahead screen where the surgery is being projected. I'm being able to use the endoscope light pipe and the vitrectomy cutter from 2 of the ports. So we will be talking about in detail now. So what is the advanced visualization in endoscopy? Endoscope gives us a direct line of sight. The endoscopic system introduces a small, high-resolution probe directly into the eye, providing a wide-angle, illuminated, and magnified view of structures previously obscured. So the high resolution of the optics in the endoscopic vitrectomy is obtained from miniature lens system which delivers detailed high-definition images from within the vitreous cavity, which is now integrated with the illumination of coaxial light source, which brightens the target tissue, minimizing shadowing and maximizing contrast. Then after that, there is a panoramic field of view, which offers unparalleled visualization of the anterior segment, equator, and far peripheral retina. So endoscopic advantages in complex cases is by gaining access to the surgical blind zones. The endoscopy empowers surgeons to address pathologies in the anterior and far peripheral retina with the anteposterior segments with enhanced precision and confidence. Specifically in ciliary body procedures like direct visualization for cyclophotocoagulation, which is endocyclophotocoagulation, and accurate management of ciliary body tumors and dialysis, peripheral retinal breaks, which is the superior detection and treatment of breaks hidden beneath the sclerotomy or behind the lens or iris. In the cases of small pupil or opacities, specifically with endophthalmitis, in cases of vitreous hemorrhage, anti-segment hyphemas with corneal scars, it proves to be superior. So this is one of the cases where we can see the cornea is decompensated with the B-scan supportive retinal detachment and exudates in AC. So I'd like to share a video here of a case done by endoscopic vitrectomy. This is done in our institute, and we can see that though the anterior segment is completely blinding for a surgeon to perform the surgery, once I enter from the endoscope probe, it gives me a perfect view on the screen, which can be illustrated to my fellows and to residents and for the assistants who are with me to understand the case, and also for a doctor to treat a patient in a satisfying way. So here we can see that even though the anterior segment does not provide us a view in some of the cases in vitrectomy, if we can perform the 3D vitrectomy, we can know about the status of the retina, about the optic disc and of the macula, which can also be used as a diagnostic procedure of endoscopic vitrectomy as a diagnostic tool, where we can plan for anterior segment surgeries like PKs and DISECs and DALCs, where if there is a prognosis, good prognosis associated with the optic nerve fiber, only then we deciding and going forward with the anterior segment surgery. So this is the second case where you can see that there is trauma. The view from the anterior segment is obscuring the posterior retina with the normal conventional microscope, where after the, I would like to apologize for not having the video of this case, but you can see after the surgery at the, on follow-up, you can see a very good attached retina after removing the exudates in the vitreous with the 3D vitrectomy. So a new paradigm for the surgical education stands out the endoscopic vitrector, because the endoscopic visualization offers a unique teaching platform, providing trainees with a high fidelity shared view of every surgical maneuver, especially in the often challenging anterior and peripheral structures. There is shared visualization. The full screen, the real-time projection of the internal view allows for simultaneous instructor-trainee learning, enhanced dexterity in training, and complete retinal anatomy. So to conclude, looking beyond the horizon, endoscopic visualization is not merely an accessory. It is a fundamental shift towards comprehensive intraocular surgery. The focus is now on integrating this unseen access into standard protocols, further defining its role in precision and retinal surgery. So key takeaway from my presentation would be endoscopy successfully eliminates the surgical blind zone, offering 360-degree visualization that enhances safety and efficacy, particularly in complex anterior and peripheral retinal pathology. Thank you for your kind attention.
Thank you, Dr. Sanjita, for adding new tips and new horizon for the surgical care. Our next speaker is Dr. Amrit Bastola. He is a consultant ophthalmologist and VR surgeon working at Sri Krishna Netralaya, Bhairava. He'll be talking on peripheral exudative hemorrhagic chorioretinopathy, presenting with vitreous hemorrhage, surgical case series, and literature review. Please welcome Dr. Amrit Bastola. Thank you.
Good afternoon and namaste. I'm Dr. Amit Bastula, visual retina surgeon from Sri Krishna, Nepal. And I would like to talk about my topic is peripheral exudative hemorrhagic choroidal retinopathy, presenting with vitreous hemorrhage, case series and literature review. These are my disclosures. Before going towards the topic, I would like to discuss about my cases. She was, the first patient was 72 years old, presented with us, and the finding was vitreous hemorrhage. And I'm so sorry that I couldn't take the intra fundus photo. And the patient was planned for right eye phaco plus PPB. And after 2 weeks post-op, the fundus photo was taken, and we can see the submacular subretinal bleed. And these are other, we can also see the submacular bleed with also involving the peripheral retina. And next case was 62 years female, both pseudophakic with left eye vitreous hemorrhage. B-scan was not clear, and we planned for left eye pars plana vitrectomy. And we can see in these pictures, we did pars plana vitrectomy and fluid air exchange, and silicone well insertion was also done. And we did retinectomy also to aspirate the bleed. And on 2 weeks post-op, we can see the retina is on, silicone well filled globe, and we can just see the scarring on the retinectomy side. And this was 1 month after a 2 months follow-up. We can see the membrane formation on the retinectomy side, and we planned for left eye silicone well remover and membrane peeling. And our next case was, we can see the right eye media is clear, but in left eye, we can see there is the presence of submacular hemorrhage with dome-shaped elevation lesion resembling like PCV. And we planned for intravitreal anti-VEGF. But the amazing thing that happened was that generally we call the patient for 1 month follow-up, but after 2 weeks follow-up, but this patient came after 1 month, and with this B-scan findings, suggestive of PCV rupture. And we also planned for this patient left eye vitrectomy with intravitreal Avastin. So this is the 1 month post-op picture, suggesting resembling of subretinal bleed involving both the macular as well as peripheral retina. And on 1 month post-op, we can see the submacular subretinal bleed is the size and the location is also decreasing, and there is the formation of scar. After 3 months post-op, there is the macular scar. And our fourth case was 24 years female. She presented to us with a complaint of diminution of vision, and on B-scan, we can say there is the presence of vitreous hemorrhage. And we can see the dome-shaped lesion on OCT resembling like PED also. But we planned for this patient also pars plana vitrectomy plus intravitreal Avastin. In these pictures, we can see that the subretinal bleed is not involving the macula. It's like on a periphery and supratemporal region. And on left eye, 2 weeks follow-up, we can see the size of the bleed is also decreasing. And there is the formation of scar also. And this is the 6 weeks post-op, where the side of bleed is decreased. And this is 4 months post-op with excellent visual acuity on this patient. This is 11 months post-op, where we can see the thickened choroidal vessels, but the bleed was already healed, and we can see the scar or a supratemporal region. On OCT findings, we can see all the outer retinal layers are disrupted. So, why we did this and what is this? So I would like to talk about a few things about PSCR. It's like a rare degenerative chorioretinal disorder with peripheral hemorrhagic and presence of exudative lesions. And it is like often misdiagnosed as intraocular tumors, polypoidal choroidal vasculopathy, and retinal macroaneurysms. And like, because till now there has not been any study about this PSR in Nepal. So like, we also don't have exact data, and we also don't know what is this case, and we sometimes we are misguided or we misdiagnose it. So clinical relevance is like PSR can cause a breakthrough vitreous hemorrhage, obscuring diagnosis and impairing vision. So our purpose was to describe the clinical features and surgical outcomes of vitreous hemorrhage due to peripheral exudative hemorrhagic chorioretinopathy, and to contextualize findings with current literature. So we took 7 eyes. 7 eyes underwent vitrectomy for dense vitreous hemorrhage, 2020-2025. Demographics, intraoperative findings, imaging, and postoperative outcomes were reviewed. So out of this, we have a young patient. I do not like to go much details about this chart, but number 5 patient who was 42 years old, like, and some macular bleed where the macular region were spared. They had a beautiful, excellent recovery after pars plana vitrectomy. So it's a rare degenerative retinal disorder, first described in 1960s. It presents with peripheral subretinal hemorrhage, exudation, and pigment epithelial detachment, and is frequently misdiagnosed as choroidal melanoma or PCV. Let's not go in detail with epidemiology. And the diagnostic tools, we need a multimodal imaging essential, like OCT, fundus fluorescence, ICG, B-scan. And differentiation from tumors and PCG is critical. And we can see on fundus examination, peripheral hemorrhagic and exudative lesions. OCT may show subretinal fluid or pigment epithelial detachment. And ultrasound is very helpful to rule out the mass lesions. So talking about the systemic review highlights, it's based on the updated review by Badoy et al. Clinical spectrum includes peripheral hemorrhagic lesions, lipid exudus, serous or hemorrhagic pigment epithelial detachment, and it's definitely, I already told before, because it's definitely a diagnostic challenge. We are often mistaken with many choroidal tumors and requires multimodal imaging. And management strategies is observation in symptomatic cases and anti-VEGF therapy with macular involvement or neovascularization, laser photocoagulation or cryotherapy in selected cases. So we must not get confused, and we must make our all differential diagnosis, like choroidal melanoma, peripheral retinal vasculitis, retinal macroaneurysm, and polypoidal choroidal vasculopathy. So, talking few things about here, PSCR, choroidal melanoma, and PCV. We all know that what is the appearance of PSCR. I just like to focus on appearance of PSCR. It's like a hemorrhagic PED, lipid exudus with subretinal bleed. Whereas choroidal melanoma, it is a dome-shaped pigmented mass. And with PCV, it's an orange-red polyp. And like in B-scan, we have like there is no any mass, and it is acoustally hollow in PSCR. Whereas in choroidal melanoma, we can see solid mass with low to medium reflectivity. And in PCV, there is no any presence of mass. So, in conclusion, I would like to say that PSCR is an uncommon but important cause of vitreous hemorrhage. While visual prognosis is often poor, surgery is essential for diagnostic clarification and can yield excellent recovery in selected cases. Recognition of its clinical spectrum and overlap with PCV and pachychoroid entities is critical to avoid misdiagnosis and management. Summary, as I've already told, So this case series is the first documented report from Nepal, highlighting the diagnostic and surgical challenges in the Asian cohort. PSR may belong to the pachychoroid spectrum, suggesting shared pathology with PCV and AMD. So proper diagnosis, proper treatment is needed for such patients. Thank you so much.
Thank you, Dr. Amrit, for the beautiful case series with the meticulous post-op follow-up. Now our next speaker is Dr. Subhas Bhatta. He is an consultant ophthalmologist and VR surgeon currently working at Drishti Eye Care System. And he'll be speaking on membrane removal in diabetic retinopathy, surgical strategies for better outcome. The floor is yours, Dr. Subhas.
Thank you, Dr. Harimaya. Thank you, NBRH and NS for providing this opportunity. In this presentation, I will be mainly talking about principles and techniques of membrane removal in diabetic vitrectomy. I have no financial interests. As we all may agree, diabetic vitrectomies are some of the most challenging cases we see in our vitreoretinal practices because of technical challenges and also unpredictable outcomes in many cases. This is one of my patients who presented to me with loss of vision in both eyes, where left eye was already operated elsewhere, and he came for surgery in the right eye. So these are some of the cases that give you sleepless nights. So eye already done and NPL vision, and then the other eye has a counting figure vision, and if you go in and cause the same case scenario leading to the total blindness in the patients. These are difficult cases, but like with modern instrumentations and modern our new skill sets and experience, we can decrease these kinds of incidences, and we also need a bit of luck. So in this presentation, I will be basically talking about principle of diabetic vitrectomy, some common techniques, and approach to some complex cases. So there is an eternal debate. Should we do inside out or outside in? However, I don't see any debate. It depends upon case to case. I generally prefer out to in approach. Because like when we start from periphery, what happens is like you start from less vascular area, and you also sever the connections of the central membrane with the periphery, decreasing the chances of inadvertent breaks at the periphery. And when you go from out to in, what also happens is you isolate the central membrane, and you can see the intricacies of those membranes, how well the pegs are attached, how is the retina underneath it, and you can strategize your plan like how you want to remove that central membrane without causing much damage to the more important area at the last. However, sometimes you can go from inside out also, depending upon if your visualizations, it's sometimes easier to go from inside out because like generally you get to the right primary membrane when you go from inside out. And when you try it from the outside in, sometimes you may not find the primary membrane, and if you get engaged with the secondary membrane, you can have a hell of a time. So, I think it depends upon case to case. The problem with inside out, as I said earlier, is that like sometimes when you engage with these vascular membranes and you have a lot of bleeding at the start of the surgery, you will have a difficult time continuing your case. There are some common terminologies floated all around. Peeling has been a standard technique for a long time. Peeling generally implies removing the membranes by pulling it off. I generally feel that like peeling can be good in common cases, but if you have technically difficult cases, peeling can cause a lot of problems. Especially peeling can be difficult if it's a combined RD cases, the retina is atrophic, you can cause like breaks even with little force on these membranes. So I prefer segmentation and delamination associated with peeling depending upon how the underlying retina looks. So this is a case where I'm doing a simple segmentation of the membrane using a 27 gauge cutter, where I'm just separating the major vascular membrane over a combined RD using a 27 gauge cutter. What the segmentation does is that it isolates the membranes into individual pieces, so that it decreases the traction over the underlying retina. So this is a conformal delamination technique, where this was a conformal delamination technique which was showed in previous video, where your cutter is under the membrane and you cut through it. The other technique is the foldback delamination, where you put the cutter above or on the side of the membrane and the membrane folds back into your cutter. So this is possible with more flappy or like thinner membranes. You can't do the foldback delamination on tough membranes that are adhered tightly to the retinal surfaces. So another big question that comes is like, how much of segmentation or how much of membrane removal is adequate? So this question, I think, can be answered on a case-to-case basis. I would prefer to remove all the membranes on the retina as long as I don't cause iatrogenic breaks. So if I find I'm in a situation where I feel that removing the small bits of membrane can cause increased bleeding, or I can induce iatrogenic breaks, I would like to leave some of the membrane stumps behind by cauterizing them. Sometimes same thing happens with the disc membrane, where when you are coming from outside in technique, you end up with a disc stump at the end. Now the question is whether to remove that disc stump or not. So I would generally like to remove my disc stumps, but sometimes if it can't be removed, or I think it's very difficult to remove, or there is an increased chance of disc bleeding. Sometimes disc bleedings can be a very difficult case scenario to manage, because you can't do cauterization, you can only do a mechanical pressure, increase your IOP for a bit, and sometimes it doesn't work that way also. So in these cases, I like to just leave the bit of a membrane on the disc and cauterize the edges. However, I would also do a ILM peeling at the end to decrease any traction from it coming to the macula. If I remove the disc stump, what I generally do is I ask my assistants to raise the bottle height or IOP before I pull out on that membrane, so that the bleeding doesn't get exaggerated and I don't lose the view. So I just keep the IOP higher for like for 30 seconds to 1 minute, and then lower it to see if the disc is bleeding is still using from the disc. In technically challenging cases, I think like your vitrectomy cutters and peeling may not be adequate. With 27 gauge cutters, I am finding more that we don't need much of scissors, but still in some cases where you are working over atrophic retina, you might need to use scissor delamination. You can use your scissors with a bimanual technique using a chandelier, or as a unimanual technique also. Scissors do help a lot. This is another case of a scissor delamination where I'm working on an atrophic retina without using a chandelier, just with the light pipe and the horizontal curved scissors. Sometimes like they can rescue you in difficult situations where you can delaminate the whole membrane without causing any iatrogenic break to the lifted atrophic retina. Okay, so if the cases are more complex, then I think like chandelier system using a bimanual technique can be helpful. But like as I already said, with 27 gauge cutter systems, I think they are less needed nowadays. So to conclude, in my general workflow, how I approach a diabetic membrane peeling is that I generally go by removing the peripheral vitreous traction, then address the central membrane, but it changes on case-to-case basis. I first gently lift the membranes to assess the adhesion strength before peeling is initiated. So we can just lift the membranes a couple of times to feel how the underlying retina is working, and then decided whether we can proceed with the peeling or go with delamination or segmentation on those areas. And then I go and sever the strong vascular pegs and the tight adhered areas before I remove rest of the membranes. Bleeding edges need to be cauterized as soon as possible, because they hamper your view. And then at the end, I clear the residual membranes with cutters or forceps. Tamponade is chosen based on intraoperative findings, but I like gas tamponade better in my diabetic vitrectomy cases. Thank you very much for listening.
Thank you, Dr. Srivas, for giving nice tips on diabetic vitrectomy, which is, of course, a challenging case. Our next speaker is Dr. Rosija Khanal. She is an consultant ophthalmologist and vitreoretina surgeon working at Sri Krishna Netralaya Eye Hospital at Bhairava. She'll be talking on retinal detachment in eyes with choroidal coloboma, technical hurdles, and surgical insights. Please, Dr. Rosija, the floor is yours.
So, good afternoon, everyone. First of all, I would like to thank Noscon for this opportunity. This is my topic and my disclosures. So we all know that choroidal coloboma-related retinal detachment is not a routine reg RD that we encounter in our practice. It is rare but has complex presentation. It all starts with embryonic fissure closure defect, and it leads to inferior fundus anomaly, meaning that there is poor formation of the retina and the choroid in the inferior fundus. And 40% of these eyes are known to cause retinal detachment, which poses significant surgical and prognostic challenges. Even the pathophysiology of detachment in choroidal coloboma-related RD is different from a routine reg RD, where there is a presence of retinal break, liquefied vitreous, and a posterior vitreous detachment in reg RD. Here in coloboma-related RDs, what happens is the normal inner layers at the edges of the coloboma folds back on itself. It causes a traction on the intercalary membrane. So this traction on the intercalary membrane, which are rudimentary dysplastic retinal tissue, causes tears in the membrane, and it allows the passage of vitreous through the membrane and creating a retinal detachment outside the coloboma. And the abnormal vitreoretinal traction accelerates the detachment. And sometimes the coloboma, sometimes the break can be found outside the coloboma as well. But most of these patients do present early in life because the vitreous anomaly is there, and most of the time the break is in the coloboma. So identifying the communication site is the key surgical goal in managing coloboma-related RDs. So what are the surgical challenges that we face in coloboma RDs is that the tissues is thin and hyperplastic in the colobomatous area. They are fragile. Most of the time, these membranes have connection in the choroid, and manipulation of this membrane could often lead to breaks, unnecessary breaks actually, and sometimes leads to massive bleeding as well, making the further maneuvers difficult. And because of the poor development of the RPE, there is difficulty in identifying retinal breaks, which causes difficulty in giving laser as well, and there is a poor chorioretinal adhesion formation. When there is optic nerve involvement in the colobomas, what happens is the fluid around the optic disc coloboma makes it very difficult for the tamponade effect, and it's even difficult to apply laser because the damage to the papillomacular bundle would be even greater. And these eyes are often small, the maneuvers are difficult, and most of the time the difficulties that I face is the lack of zonules causes frequent difficulty in viewing because at the time of fluid exchange, the air keeps on coming to the anterior chamber, making the surgical view very difficult. And these eye, most of the time, present early in life, and the PVD induction is difficult. So here, the incomplete PVD can lead to redetachment due to persistent traction on the coloboma margin and causing to redetachment and making complications even more difficult to manage when they present late. So the surgical strategies that we need to apply in coloboma RDs is that, so vitrectomy is often combined with scleral buckle. I usually prefer using insert large buckling in these cases. I use triamcinolone acetate, triamcinolone to stain the hyaloid for removing the complete hyaloid. And to identify the communication site, sometimes I do use the dye as well. And intercalary membrane are very delicate. We need to handle these with care because these are the membranes that cause the traction. We need to handle it very carefully. Giving a good barrage is also very important, and do prefer to keep silicone oil for a longer time. So I would like to share a case. This is a very young female. I think she's in her early 20s that we operated very recently. She is one-eyed, and this is the picture pre-op that we'd taken. There is a short video. I think the time allows, so I'll just play it. So at this point of time, I've already finished using the insufflage buckling. I've done a pars plana vitrectomy here. And I've also stained it with triamcinolone dye and checked everything, but we can see that there is a traction still ongoing in the inferotemporal area of the coloboma margin. So there was actually a membrane coming from the coloboma area to the choroid, which when manipulated had led to bleeding. We then did a careful cauterization of the membrane, did dissect the membrane and was able to release the traction, and finally the retina was settled in the end. So we need to check these membranes very carefully, and if we leave these untreated, then definitely it's going to cause more of PVR and the detachment, because she is a one-eyed patient and most of these eyes are very complex to manage because of anomalous vit adhesions around the retina and everything. So we need to give a good gentle laser around the breaks whenever possible, and we need to be careful if it's involving the fovea around the disc, it has to be even milder. So this is towards the end of the case actually. I'm like completed everything, but still want to, sorry. Okay. It's not dragging. So anyhow, so okay, it's not playing well towards the end. I'm not able to drag it. So I'll just skip this thing and I'll just show post-op view. This is post-operatively, this is a post-op view. She is still phakic, and we are able to have a flat retina in the first post-op day itself. We can see the bleed is there from the retinotomy area. And after 5 months, she had developed some amount of cataract. She has the best corrected visual acuity of 6/60. Retina was on and has been planned for phaco and silicone oil removal. So from this, we can see that what I particularly feel is I do a very minimal power of laser because they are very fragile and it causes unnecessary development of breaks, which I do not want to cause. And PFCL could be helped, but I don't use. Sometimes I fear that it might migrate beneath the retina and cause more difficulties in managing that. And don't really be aggressive in peeling over the optic disc area. And now there have also been frequent use of cyanoacrylate glue, amniotic membrane grafts to plug these breaks within the coloboma. So take-home message would be that choroidal coloboma detachments demand anatomical respect. Success depends on preoperative mapping, gentle dissection, and secure edge sealing. So precision in mapping, patience in dissection, and respect for anatomy is very crucial for these cases. So complications and learning points would be that it could be leading to redetachment, oil emulsification, CME, hypotony if there is residual vit, and PVR. So the communication needs to be identified early. So gentle laser, silicone oil for a longer internal tambourite, and patience is the key. Thank you for your kind listening.
Thank you, Dr. Rosija, for giving us surgical tips on choroidal coloboma RD surgery management. Now, next, I would like to call upon Dr. Samir Chapagai for presenting on difficult PVDs. Please welcome Dr. Samir.
Good afternoon, everyone. I'm Dr. Samir Chapagai, currently Vitreoretina Fellow in BPKLCS in Mechi Hospital. So surgical PVD is a surgical step of separating vitreous, posterior-cortical vitreous from retina. So mostly we're using vitreous cutter in aspiration mode, and we have found it particularly difficult to induce PVD in younger patients, diabetics, retinal detachments. So for managing difficult PVDs, things we are following is repeated staining of vitreous with triamcinolone, and instruments apart from cutter, we are using backflow cannula, forceps, or scraping with diamond dusters. And sometimes we also have to stain ILM with brilliant blue or ICZ and ILM peeling. So I'm sharing two videos actually. The first video will demonstrate use of flute needle. This was a case of 45 years old male with traumatic lens dislocation. So we planned for PPV and lens removal. So the problems that we faced were adherent vitreous and sheet of posterior vitreous that is not being grasped by vitrectomy cutter, probably due to very thin remaining posterior vitreous. So we used backflush needle, and which was used to tease the posterior vitreous multiple times. Let's see whether or no. So I hope it's clear. So using the backflush needle to tease from periphery to the from center towards the periphery. So we had to struggle a bit. So staining, and after that slowly we had to tease it a lot of multiple times, being careful not to being careful to avoid any traction or any touch on the macula. So we had to go really near, and at the edge of the detached area in the periphery. So we are doing this. So finally, we had some success in mobilizing the posterior attachments, and we can see we have successfully lifted off the attachment, the posterior cortical vitreous, and after that, after removing it, we went in with cutter and started removing the vitreous. So in next video, this is using forceps in a diabetic patient with TRD. So this was a diabetic patient. We are staining it with a tracker for better visualization of the vitreous. So we started the vitrectomy with a vitrectomy cutter, and because of the attachment around the disc area, it was getting difficult to lift it off with just the use of cutter in aspiration mode. So I've seen removing the peripheral vitreous, and we started, because of that center, we started using forceps to mobilize the membrane and as well as the posterior vitreous from the disc area. We can see some bleeding from the disc area too. So it's not ideal, but usually happens in adherent membranes while attempting to remove adherent membranes. And slowly we could lift it off. Okay, that should be it. So we can also see some regulations component, the water seeping in, and I think this is the point. So right there, the vitreous gets separated from the disc area. So after we were successful in removing the attachments, we went in with vitrectomy cutter and separated the rest of the vitreous, and even removed. And for removing the attachments in other areas, we also had to use vitrectomy forceps. We have to use forceps in this case also. So I don't have any poster pictures of these cases actually. So PVDs during early fellowship periods can be sources of much anxiety for particularly young surgeons. So what we are learning is we are trying to induce PVDs with as much less trauma to the retina without inducing much breaks. So there might be some tricks. So as a beginner, so these were the tricks that we are using here in Mechi. I hope it was helpful. Thank you.
Thank you, Dr. Samir, for your tips for the induction of posterior vitreous detachment. Now our next speaker is Dr. Pratap Karki sir. He'll be talking on retinal detachment tips and tricks. He has trained so many fellows all over Nepal and across the border. So let's hear from the master about the tips and tricks. Welcome, sir.
Thank you, Dr. Harmayam. So, good afternoon, everybody. Towards the last of our presentation today, I'm going to talk about retinal detachment. I don't know the word, how the tricks came from, but this is actually the experience I have learned over the years, sometimes going through very bad times also. So, this is basically on my experience. I will probably be talking a lot about using the word experience because I have learned that your experience really counts, and so we need to build on that. I have no final interest, and this is the basic layout. I'm talking about only reg matters retinal detachment. So when we talk about reg matters retinal detachment, as we all know, the word regma comes from break, but it's not just the break that decides whether this is going to go into detachment. After the break, the next key player is traction. So we need to keep this in mind when we're treating this patient. It's just not enough to just find the break, do a cryo, do a laser. The next thing you need to see, what are the tractional force involved in this causing this retinal detachment, and how we are going to take care of them. Only then we'll land up with a successful surgery. So there are many factors in assessment of the patient. Patient vision having PL or less vision, I'm not too keen to operate. Probably better than that, you still have a chance. Likewise, if the patient is one-eyed, we have to attempt the surgery. Duration, as we know, 1 week, 1 month, the longer it gets, it's worse. Usually after 3 months, I don't see very good results, and 6 months and long, I'm not too keen to operate. Likewise, area of detachment versus the superior, we know inferior RD is slightly more challenging to treat. And total RDs, the more surface area is detached, the more chances of PVR you will have. Likewise, the factors associated with the type of breaks. If you have a hole, we want to think more about doing a buccal surgery, a horseshoe break. More, I would think about doing a PPV, and anything with giant retinal tears and lots of retinal breaks. Please, we can expect a lot of PVR in the post-operative period. PVR grading, as we know, A, B, C, as PVR grading goes up, the prognosis is poor, but don't underestimate a total RD with PVRB. A little bit of surface traction over large surface area will mount up to a PVR also. So a total RD with PVRB, again, think of traction more seriously because you may have a post-surgical failure later on. Likewise, assessment of the pupil. If you see a pupil that is constricted, not dilating with a lot of synegia, these are not very good cases to operate. They probably have RD for a very long time. The lens status of the patient, a phakic patient, I would think more of doing a buccal surgery, and a pseudophakic patient, mostly I would think for vitrectomy, but these are not strict rules. There are other factors to be considered. Correlative detachment is a big problem. These have a lot of PVR in the postoperative period. There are a lot of intraoperative challenges. Early on, we used to give them oral steroid and wait, but now we realize it's better to go in early to do a surgery. That's the only way we can treat them. But the long-term prognosis of RD with CD is not as good as just retinal detachment itself. Likewise, if the patient has vitreous hemorrhage, again, a break in the blood-ocular barrier, there is chances of PVR happening. And always look at the other eye. If the patient had RD in the other eye, what was the type of surgery used? How were the surgeon results? We can always learn from the success and the failure in the other eye. This will really help us. Just don't think that the other surgeon had a failure. Maybe he didn't do something. I can do a better surgery. It's very likely the same result will happen to you. So let's look at the other eye, how the surgeon, if it's done elsewhere, was approached, and we can learn and do better in the other eye also. So looking at the approach, so the surgeon experience, as I told you, is very, very important. I have very little experience with pneumatic retinopexy. Scleral buckling, I would like to choose in a patient who is phakic, is young, has inferior RD, and vitrectomy if the patient already has some PVD, has PVR and complicated cases. And I'm also like combined surgery. Combined surgery dramatically, it increases your surgical time, but it also increases your success rate. So in complex cases, and where you really don't want to fail, this is a very good approach to do this surgery, where you combine vitrectomy and buccal surgery. Gas is a very good agent if your surgery goes well and the patient goes away with a single surgery, but we have to choose our patient well. If the break is superiorly, that's a very good person to use gas intraoperatively. Also, if the patient lives far away, cannot maintain posture, be very careful, because if the detachment happens, this patient should come to your hospital as quickly as possible. And if they live far away, this is a big challenge for us. Silicone oil, obviously, we are using in complicated cases, but in one-eyed patient or patient is living far away, cannot maintain posture, then we need to think about silicone oil also. I have no experience with intra-op PFCL or heavy silicone oil. These are other options we have. So setting goals for the surgery. It helps both patient and the surgeon. Counseling is very, very important because it's a long journey from where the end of the treatment will happen. If you want good outcomes, I also think that it's not just doing good surgery. We also need to choose good cases. You land up with poor outcomes, not because of your own surgery, because you are taking a lot of challenging cases with a lot of poor prognosis, then also you will have poor surgery. So we need to choose our patient well also. And if you want to plan an emergency OT, always don't have an OT full. If you have some spare space, you can always plan for early surgery for the patient that require it on time. So intraoperative challenges, always check the infusion. Many times, especially if the patient has CD or a very bullous RD, the infusion may go into the subretinal space or suprachoroidal space, and sometimes we land up with this problem and realize very late. So make sure you check your infusion. Triamcinolone, obviously, good to stain. If you see more, you can do better surgery. Subretinal fluid aspiration, if you lessen the SRF and use a PFCL to make sure the more SRF accumulation is not there, then you can do much better peripheral vitrectomy. And likewise, what I talked about traction, what are the traction forces involved causing this RD? Do indent peripheral shaving to reduce the traction. If there is a surface membranes, let's peel them to reduce this traction. And if it's still residual traction, a buccal will help you take care of the remaining. Laser, I prefer to do a 360 laser apart from just from the breaks, because I feel if there is a break missing somewhere that I may have missed, gives you an opportunity. Cryo less, but it's because associated with PVR. Likewise, if you're doing fluid exchange, there's a subretinal fluid air migration, then you need to do retinotomy. And again, buccal surgery, if the patient has PVR, I would prefer the buccal and do a phase surgery than doing a primary retinotomy. GIT cases, I prefer to use silicone oil and direct silicone oil exchange. So post-operatively, tamponade, depending on the break, type of break, gas, you can maintain the posture. But in a silicone oil, I always prefer only a prone position. Look out for glaucoma. That's the second thing after the retinal problem that will cause blindness in this patient. Oil removal, communicate with the patient so that they follow up well. Again, buccal extrusion may also happen. So if you are using buccal, ask patient not to vigorously rub their eyes. Sometimes I found that the buccal extrudes just because of too much physical manipulation. And always assess the other eye for risk factors, because sometimes that's the best thing we can do for our patients. So 4 things I will say: prioritize your primary success. RD surgery is challenging. If you get your first surgery right, we have a much better chance. When the surgery fails, the combined surgery, as we all know, is not always good. Value your own experience and have a strategy. You may read things, you may see other things, but also learn from your own experience, and sometimes that is the best thing to do. And think about success and failure. Plan for your success and also plan for your failures. And always communicate with the patient, because it's a long journey for us during this treatment. Thank you.
Thank you, sir, for your enriching, enlightening tips and tricks, as always. With this, we'll come to the end of this session. We have 2 more speakers who have arrived lately. Maybe we'll join their talks after the lunch. So to end this session, I'd like to welcome our chairperson, Dr. Somnath, sir, to hand over the certificate of appreciation to our speakers. And I'd also like to call upon our president, Nepal Vitreoretina Society, sir, Dr. Sanyam, sir, also over the stage to hand over the speakers. The first speaker is Dr. Somnath, sir. Our next speaker is Dr. Sanjita Sharma. Dr. Omri. Dr. Subhas Bhatta, Dr. Rosija Khanal, Dr. Shamir Chapagai, Dr. Pratap Karki, sir. Now we'll take one group photo, then we'll break up for the lunch. Thank you everyone for your patient hearing, and then we'll enjoy your lunch and enjoy the rest of the conference. Thank you. Thank you everyone. Now we'll break for the lunch and we'll start the next session at 2 p.m. sharp. Thank you everybody.
who is Vice President of Nepal Vitreoretina Society, Head of Department of Retina at TIO Institute of Ophthalmology. And another chair is Dr. Sayam Bajimaya sir, who is currently President of Nepal Vitreoretina Society and is a key member and founder of NVRS. And with that, I'll be starting this session and would like to would request Professor Dr. Raba Thapa for this first topic, that is diabetic retinopathy screening at a low resource setting for prevention of blindness. Please ma'am.
Thank you, respected chairs and distinguished participants. Today I'll be dealing about the diabetic retinopathy screening at low resource setting, and I have no conflict of interest. As we know, diabetes is one of the major non-communicable disease and is a major public health problem. As per IDF in 2024, 589 people are living with diabetes, out of which 9.5 million are type 1 diabetes. And the rate will be increased, that is expected to be 853 million by 2045. Not only the prevalence is rising, but the mortality due to diabetes is also very high. We can see the ratio that 3.4 million people died of diabetes in the year 2024. After the African country, in Asian country, there will be rapid rise of diabetes, about 73% increase in the coming years. We can see that in urban areas, there will be very high rapid rise of diabetes as compared to the rural area. This is the graph showing the tendency from 2021 to 2045. What is the scenario in Nepal? In Nepal, diabetes is increasing as an epidemic problem, especially in the urban areas. The national prevalence is 8.5% at the age 20 years and above. However, the rate has been very high when the age increased, like at the age 40 years, the 19% of the people are expected having diabetes in urban areas. So diabetes is increasing with age, and in the urban areas. In one of the study, almost 26% of the people at the age 60 years and above have diabetes in the urban areas. And we know that diabetes is a multi-system affecting disease having many microvascular and macrovascular complications. So microvascular complication is one of the diabetic retinopathy is one of the major complication and very common complication of diabetes. That progresses through various stages of non-proliferative and proliferative diabetic retinopathy and macular edema. So what is the scenario of diabetic retinopathy globally? It is one of the most common complications of diabetes, and 1/3 of the diabetes have diabetic retinopathy, and out of the diabetic retinopathy, 1/3 need prompt treatment, otherwise they will lose vision. As per WHO, it contributed 4.8% of the blindness. More than 80% of the people are in the low middle income countries, out of which complications are preventable. There are many risk factors for diabetic retinopathy. That is why we can control this diabetic retinopathy blindness while tackling these risk factors, like poor glycemic control is one of the very important risk factors. Likewise, the longer the duration, the more the diabetic retinopathy, hypertension, underlying hyperlipidemia, smoking, nephropathy, and pregnancy are taken as a very important risk factors for progression of the diabetic retinopathy and onset of the diabetic retinopathy. In Nepal, many population-based studies have reported the diabetic retinopathy prevalence of 18 to 24%, with vision-threatening diabetic retinopathy of 8 to 10%. However, the awareness is very low in population. However, in the hospital-based setting, half to 2/3 of the people have are aware of diabetic retinopathy, and there is always delay in diagnosis of not only diabetic retinopathy, but also the diagnosis of diabetes. Why it is burden in low resource setting? It is because of the limited access to ophthalmologists. As per the WHO standard, the late presentation is very common, leading to many complications, not only diabetic retinopathy and other complications. The high prevalence of undiagnosed diabetes, as per IDF report in 2024, 43% of the people are still undiagnosed of diabetes. Likewise, lack of awareness and infrastructures. Diabetic retinopathy screening is very important because diabetic retinopathy is often asymptomatic until the advanced stage. Early detection and timely treatment leads to preservation of vision, and as well as reduced healthcare burden and improves the quality of life. That is why the screening is very important for diabetic retinopathy, and based on the diagnosis, the diabetic retinopathy screening should be done within, if the diagnosis done within 30 years, within 5 years, and then yearly. But in our setup, as the diagnosis is very late, upon diagnosis, we have to subject for the screening. Likewise, those diagnosed 31 years and above, at the time of diagnosis, an annual checkup is very important. However, in pregnancy, in each trimester, the patient should subject for retinopathy evaluation, and based on the severity of the diabetic retinopathy, the grading evaluation should be done based on like mild 9 months. Likewise, in PDR and CSM, even after the treatment, every 2 to 3 months, the follow-up is very, very important. Diabetic retinopathy screening can be conducted with various modalities like direct and indirect ophthalmoscopy. It is inexpensive, but it needs training. And other important modality is by using the fundus photography, which is taken as a gold standard. And another is a non-mediatic fundus camera with the disc and macula center. Even in the non-mediatic fundus photography is has been very useful. Likewise, teleophthalmology is another very important aspect with the remote grading by the retina specialist, and AI-based automated detection is an emerging tool that can be very helpful for diabetic retinopathy screening in the future. There are certain examples like in primary eye care centers. Many of the districts in Nepal has primary eye care centers which are led by the allied ophthalmic personnel. So we can task shift with training of the allied ophthalmic personnel for the fundus photography and grading. In our study in the community eye center, we found that there was moderate to substantial agreement for grading macular edema, macular exudates, retinal hemorrhage as compared to the retina specialist. Likewise, in the diabetic physician clinic, we can integrate diabetic retinopathy screening by training to the allied medical personnel like staff nurse or health assistant, other paramedic staffs. In our study, what we found was the training conducted at 3 months and 6 months period, the intra-rater and inter-rater agreement was almost perfect with the retina specialist. So we could utilize this human resource for diabetic retinopathy screening. So this was the study finding from this diabetic retinopathy screening conducted at physician diabetic clinic and community eye centers under our center. We screened 25,000 diabetic patients where mean age was 54 years. The prevalence of diabetes was 19%, and type 1 diabetes, the prevalence was 15%. In type 2, it was 19%, and vision threatening 7.9%, and the duration of diabetes, diabetic food, diabetic neuropathy, and agriculture occupation were the significant risk factor in our screening program. So the workflow at low resource setting could be identify patient with diabetes, the fundus imaging, reading by the specialist, and refer for the needy patient having diabetic retinopathy. The cost innovation for the diabetic retinopathy screening could be using the fundus photography, task shifting as we already discussed, and use of telemedicine network and integration into existing diabetes or NCD clinics. So we also studied the impact of live and cloud-based teleophthalmology system for diagnosis and referral pattern at the community eye center. What we found that with the very good camera having fundus imaging and anterior segment imaging, the prevalence of anterior segment disease was 44% and posterior segment disease was 64%, and diabetic retinopathy prevalence was 20%. So we could detect many other ocular pathologies using these teleophthalmology resources. The policy integration of diabetic retinopathy in comprehensive diabetes management is very important. So with the national guideline on diabetic retinopathy and strategic development in public health system could be the modality for wider coverage. So this is one of the pictures showing the endorsement of National Diabetic Retinopathy Management Guideline in Nepal. The role of AI is very important, and it can be a cost-effective, can triage patient automatically, and it helps in integration with electronic health records and mobile apps. So we can see from the national DR integration screening using AI model from the Singapore National Eye Center with Selina. To conclude, diabetic retinopathy blindness is preventable on timely screening and timely treatment. The low-cost technology make it scalable and feasible. So the task sharing, telemedicine plus AI could be the sustainable model. And the main takeaway is the diabetic retinopathy screening is the key to prevent its blindness. So this is one of the patients who lost screening and presented with the advanced diabetic retinopathy who came on depression, but luckily she could get some vision and we could see her happy life after her depression. Thank you very much.
Thank you so much, ma'am, for addressing the burning issue, as screening surely helps in prevention. And I would also acknowledge ILIA for sponsoring this session and call upon our next speaker, Dr. Sayam Majimaya, for case-based insight of Aptiversipt in the management of wet AMD DME. Thank you.
Thank you. I would like to thank Nepal Ophthalmic Society for letting us have a collaboration with Nepal Retina Society. I have a topic on case-based insights of Aflibercept in the management of wet AMD and DME. The left side picture I took yesterday evening, and this picture is just in front of this Mechi Eye Hospital. And the other side is Mohali Cricket Stadium. So the front side of Mechi Eye Hospital is mini Mohali. So it's a kind of mini cricket. I remember the NOS president, Dr. Purshottam, was a very good batsman when we were in college. So I do have a conflict of interest to share, Bears, who is organizing this session, and my colleague, Dr. Gunjan Prasai, and also my senior colleague, Dr. Anil Kumar Sharma, who has also shared one case in my presentation today. So most of the cases I will discuss only based on Aflibercept. So my first case, she is a 75 years old female patient, non-diabetic and hypertensive. She has a very strong history of wet macular degeneration. Her father, uncle, and her aunt, my father's younger sister, everybody had a wet macular degeneration, getting injections, and she also started having the wet component. And this was just last 1 year back when she came with a drop vision in the left eye, and she diagnosed as a wet macular degeneration, for which initially she had received Lucentis, but from January, when Nepal Drug Administration approved ILIA in Nepal, then I started injecting ILIA from January 2025. So it was loading dose, 3 doses continuously for the left eye, and then followed by treat and extend protocol. So every 6 weekly, I have been injecting her in the left eye, and we follow all the protocols of injecting. I do want my colleagues also understand that injections is also a part of interventions, that we shouldn't take it very lightly. All protocols, norms has to be followed in the operating rooms. And this is the recently when we did a scan, she still have a fibrovascular PED, and she is on continuous extended injections of ILF for her left eye. Now this is the next lady. She's around 78 years lady, and she has already lost her vision in the right eye, and she recently developed. It was 2022 when she developed diminished vision in the left eye. So this was a next case of wet AMD where she had already lost the vision in the right eye when she had a multiple dose of Avastin in the right eye. So this is the left eye when she came. So we had done all the investigations, and she was happy to go for injection Eylea. So we have to counsel the patient, and we have to know the stick adherence of the patients is very, very important. So we injected Eylea. So this is the scans where we can see the fluid is not much, but the RPD, fibroscular PD, and she does have a metamorphose, and also the vision is still is the same 6/12 for last 2 years. So you can see on this is the recent scans of February 2025. Vision, even after getting 8 doses of injections, very marginal improvement, but definitely there was no significant loss of vision. So she's still on the treat and extend protocols every 2 monthly. She's getting injections, and you can figure out whether to inject or whether to continue. So I would definitely, most of my colleagues will keep on injecting 2 milligram Eylea every 2 monthly. So I have a next case of diabetic retinopathy. Okay, she's a 65 years old lady, and she presented back in 3 years back, and she is diabetic from is family history of diabetes and diabetes for more than 10 years, and she had developed loss of vision in the right eye. And at that time, the left eye was super normal. The right eye diagnosed as a central retinal vein occlusion with macular edema. So we had given her multiple injections of anti-VEGF in the right eye, and she underwent, the cataract surgery also. And the macular edema had increased with the cystoid changes, and there was chronicity. We did inject the dexamethasone implant, Ozurdex, and since she had a CRVO for more than a year, then we also did a laser therapy, PRP, and keep on injecting both combination of anti-VEGF and Ozurdex injections in the right eye. So she has a relatively vision of 6/60 in the right eye, but about this was 2023 December when she had a right eye, it's the same. Whereas in the left eye, if you see, it's completely normal. There was no any problem. But she did have a decreased vision because of cataract in the left eye. So I did a cataract surgery in her left eye last year, and we had a very good outcome. But after a month or 2, she developed a mild NPDR with DME. So she was relatively happy with the surgery, but we just followed up, and we see the macular edema increased in her left eye. So we had already counseled her, like right eye already lost her vision because of CRVO. So for the left eye, we're not going to go inject the previously known Inpatient. So we just asked her for Lucentis first, and after that after injecting Lucentis, we switched to aflibercept Eylea. So this was a really important case when after doing cataract surgery, definitely diabetic retinopathy progress and macular edema. So which is the best anti-VEGF, will you go for it? So it's always controversial. So I think it's fairly good enough that the newer drugs should be the first line of treatment, and if the vision is 6/9 or worse, then I think Eylea is the best for the treatment. So you can see the outcome. So injecting just 3 doses of injections of Eylea, she had relatively improved, and this was the last scan I did recently, and she does have some amount of perifoveal cystoid, the spongy changes, and there's macular edema, but she's relatively happy. But still, there's a macular edema, I would inject Eylea for her left eye. So this is the conditions, and you can see the follow-up this November 12th, she had relatively The maintained visual acuity is 6 by 7.5 and intraocular pressure normal. So this is a fundus photo of the right eye where she had a CRVO laser, whereas the left eye was myelin PR, post-cataract surgery, DME, who got Eylea injections. So we can see the comparative study of whether 2 milligram Eylea for 4 weekly or 2 milligram 8 weekly. So this was a landmark study which determines that we inject the treatment extent for both DME and as well as for AMD, 8 weekly 2 milligram Eylea. So the Vivid Vista trials has brought a landmark changes that our practice of converting the patient from the older generations of anti-VEGF to the newer generation. This is the case from Australia. My colleague, Dr. Anil Sharma, here. Like he also practiced a lot of injections Eylea. So he's a fairly 83 years old gentleman and type 2 diabetes, and fairly loss of vision 6.9 in the left eye. So there was a grade 1 ERM and diabetic macular edema with moderate NPDR. So this is also pseudophakic DME. So he has been injecting Eylea for the left eye after multiple doses. There was a reduce in the DME and the vision was relatively 6 by 12, and he is injecting the Eylea every 2 monthly. So the vision with base corrected visual acuity is 6 by 9 in the left eye, and the patient is still following up. This was the scan done after last injections of Eylea. So in the conclusion, what I want to say is that DME and wet AMD, they have undergone several evolutionary steps of management. Anti-VEGF Eylea remains the mainstay treatment for showing a decreased disease progression, but one of the most challenges, it is not readily available in most of the countries like Nepal, and also it's expensive and requires frequent treatments. Due to its multifactorial nature, patients must be educated about the modifier risk factors. And I would like to invite all my colleagues for this joint conference to be coming April 3rd to 4th, 2026. We are combining our Retina Society conference with the Vitreous Retina Society of Bihar next year. So you're all welcome to Kathmandu. Thank you very much.
Thank you so much, sir, for this enlightening talk. Now, I would like to call upon our next speaker, Dr. Vinod Kumar Agrawal, who is a prominent ophthalmic surgeon at RP Center for Ophthalmic Sciences, to talk about anti-VEGF treatment for diabetic macular edema.
Good afternoon. At the outset, I would like to thank Nepal Ophthalmological Society for having me here. So I'll be speaking on anti-VEGFs in the management of diabetic macular edema. Now, as Dr. Raba highlighted, DME is one of the most common causes of moderate visual loss in diabetic retinopathy. And up to 7% of diabetic patients can have diabetic macular edema. We know that anti-VEGFs play a very important role in the pathogenesis, and we also know that some part is played by inflammation. However, the complete pathogenesis still remains intact, and we are yet to discover it completely. Before the anti-VEGFs came, say 2 decades back, we used to follow the definition given by ETDRS, that is CSME. Now, and we always looked for these, criteria when the patient came to us. But subsequent to the introduction of anti-VEGFs, we are no longer following this classification. So what we follow nowadays is OCT-based classification of diabetic macular edema. So what we typically see is whether the center part of the macula is involved or not. And when I say central part, we refer to the central 1 mm ETDRS grade. If that central 1 mm of fovea is affected, then we label it as central involving macular edema. Otherwise, it remains to be a non-central involving macular edema. Now, when it comes to non-center involving macular edema, we may choose to watch it, or we may go for treatment. And in non-center involving macular edema, the treatment of choice remains focal laser. There are other types of OCT classifications of edema which involve, for example, tractional macular edema. So that we will not be talking about, because when it comes to tractional macular edema, be it horizontal or tangential traction or be it anterior-posterior traction, usually the treatment of choice would be surgical. So what I'll be concentrating here is pharmacological therapy of diabetic macular edema, and that is usually done for central involving macular edema. And once anti-VEGFs fail, or there are certain specific scenarios when anti-VEGFs do not work, we can resort to steroids, about which Dr. Chakrabarti would be talking after me. And also nowadays we rarely resort to laser in refractory cases. Now, what to do before we start anti-VEGF therapy in our patients? So I make sure that before the patient is undergoing any kind of ocular investigations in the form of angiography or OCT, I take up the patient through his systemic parameters thoroughly. So of course, good systemic control is required in terms of blood sugars, hypertension control. We must look into the hemoglobin status of the patient. Because many of these patients have associated diabetic kidney disease, so these patients tend to have anemia, and we know that anemia can exacerbate ischemia, thereby worsening diabetic retinopathy and diabetic macular edema. Therefore, we must look into this aspect. Smoking is a very important modifiable factor. Again, we should look at it before we look at the eye of the patient. Other factors like sleep apnea and obesity may also contribute to diabetic macular edema. Now, once we diagnose the patient with diabetic macular edema, we need to find out in all the patients that they do not have proliferative diabetic retinopathy. In today's scenario, many times it happens that we keep on looking at OCT, edema, no edema, but we forget about another aspect of the disease, and that is the proliferation component of the disease. So we must look at the periphery of the retina, rule out any neovascularization if present, and in fact, in my scenario, I always do either a wide field OCTA or a wide field angiography to rule out neovascularization at the baseline, and I think it is good from medical legal aspects as well. So once I have gone through the systemic parameters of the patient and staging of the DR, next is ocular assessment, which of course would include clinical photographs, OCT or fluorescein angiography, and of course OCT forms the backbone of managing all our patients with diabetic macular edema. So when to start with anti-VEGFs? Now typically once you have a central involving DME where central subfield thickness is more than 300 microns and visual acuity best corrected is less than 6/12, we typically start patients with anti-VEGF therapy. However, if the patient is symptomatic and has more demanding visual requirements, anti-VEGF therapy can be started even when the vision is better than 6/12, especially if the patient is symptomatic. Now, I always, in fact, the literature also suggests that one should resort to early treatment, especially if the vision has been lost in the fellow eye due to diabetic retinopathy. Now, protocol V has suggested clearly that once you have a vision which is better than 6/12, provided the patient can follow up and subsequently take a regular therapy, you can wait and watch in these patients, and once the visual acuity worsens equal to or below 6/12, they can be started on anti-VEGF therapy. So in nutshell, if vision is better than 6/12 and if patient can follow up regularly and a patient does not have any exact requirement of vision, we can wait in these patients. But what is more important in today's scenarios to learn when not to start anti-VEGFs. Okay, so when you have a patient with recent thromboembolic phenomena in terms of stroke and myocardial infection, patient with pregnant patients, many a times we come across patients who are female patients who are pregnant, they have diabetic retinopathy, so anti-VEGFs are absolutely contraindicated. And in fact, if you see most of the global trials, even in post-menopausal patients, they always do a urine pregnancy test before enrolling the patient into their trials. And we always rule out the local or systemic source of infection before we give our patients anti-VEGF therapy. If you have concurrent fibrovascular proliferation in the eye, please do not inject these patients, because this can lead to a crunch phenomena where the patients can land up with a tractional retinal detachment or subsequently a combined retinal detachment. Of course, in today's scenario, uncontrolled systemic status is not an absolute contraindication for anti-VEGF therapy, but in my practice, I make sure that I impress on the patient that you need to control your diabetes and other systemic parameters before anti-VEGF therapy is started. I do not hesitate to call them again after 3 to 4 weeks period. See that the parameters are in the declining trend or improving trend, and then only I start anti-VEGF therapy. However, if it should be said that if there is emergency, one should not hesitate in giving anti-VEGF, even if the systemic parameters are not well controlled. Now, of late, there are several reports about anti-VEGFs worsening the early nephropathy, which is there in many of our diabetic patients. So we must take care that when a patient with early nephropathy comes and we are starting on diabetic anti-VEGF therapy, we must have a word with them, and we must have a word with the treating nephrologist as to if we can start anti-VEGF therapy, because there are many reports, and I think all of us have had patients whereby we started anti-VEGF therapy, biosimilars as well, ranibizumab or aflibercept, which I think has been recently introduced in Nepal. Now, I think the most important consideration in a country like ours and yours is cost and affordability of the patient, and of course we need to take the patient into confidence as to that this condition would take multiple injections and not just the one injection which will cure the patient. So we need to tell the patient that in first year you will require so many injections and subsequent injections also in second and third year, and we should not just concentrate on the fact that you need only 3 injections, 3 monthlies, and after that you will not be requiring, because patient has to tackle to the other part, other complications of diabetes also, and other systems that are also affected. So we need to take into account all of these parameters before we start anti-VEGF therapy and choose a particular anti-VEGF. Safety, I think, is the biggest concern for me in today's scenario, and all of you know that many people all over the world have stopped using Avastin for the fear of infection. But for that matter, we are one of the few centers, we are still using Avastin, and it gives almost equal results to ranibizumab at least, and I think it's better than not giving any anti-VEGF therapy. It's better to start with Avastin, and this works reasonably well. And of course, if we talk about efficacy amongst these 3, aflibercept has the highest efficacy, and we'll come to that a little later. And as I said, we need to thoroughly discuss with the patient about various parameters which we need to look into. Now, as to which of these 3 is the best, the most robust evidence till date has been given by Protocol T. So I will take you through Protocol T very briefly. Now, this is the chart. If you can see graph, basically 3 anti-VEGFs were directly compared: bevacizumab, ranibizumab, and aflibercept. And what they found out that at year 1, at the end of year 1, aflibercept gave the highest number of letter gain as compared to ranibizumab and bevacizumab. But also the BCVA which was there, it continued to improve till year 2. The CMT also did behave in the similar manner, with aflibercept being the most drying agent. So if I was to put in a nutshell, a Protocol T concluded that when you have vision less than 6/12, or you can say in other scenario, if you talk about 20/50 or worse, then aflibercept is the agent of choice. But if the vision is better than 20/40 or 6/12, then by and large, there was no difference between all these three anti-VEGFs. So once you have a patient which can afford, then second thing we look at is how is the visual acuity. So if the visual acuity is worse, we probably would choose for aflibercept if the patient can afford for. Now I'll very briefly talk about this particular study which we did in India. It was a phase 4 study of aflibercept. Basically, in India, DGCI, the Drug Controller General of India, granted permission to aflibercept on the basis that they will conduct a post-marketing survey, or what you call as phase 4 trial. So I was one of the PIs at one of the centers, and this is how basically the study design looked like. We recruited patients and then gave them 5 monthly dosages, and subsequently 1 injection every 2 months. So this was the typical treatment plan of these patients. And what we looked at as primary endpoint at week 52, that is 1 year, was frequency of ocular and non-ocular treatment related side effects or adverse effects. Now remember here, efficacy was not the endpoint because efficacy is already been determined in phase 3 trial. So what we all wanted to look was if there were any serious adverse effects associated with aflibercept use in our set of population. So typically it was a very standard, inclusion criteria where patients with type 1 or type 2 diabetes more than 18 years of age with central CMT more than 300 microns and visual acuity worse than 20/50 were included. And there was standard exclusion criteria as is there in all DME trials. And this was the baseline data. If you see, we had total of around 100 patients which were there, and out of which around predominantly were naive patients, which were around 85%, and 15 were pre-treated patients where other anti-VEGFs had failed. By and large, most of these patients were similar. And when we looked at the results, we were very heartened to see that mean injection over 12-month of period were around 8.2 in naive patients and 7.7 in the pre-treated patients with average of 8.1 injections. And we had very good clinically meaningful vision gains in patients with diabetic macular edema. Now, when we compared these number of gain of letters with existing trials in terms of VIVID and also protocol T, by and large our results were similar to the trials which were already existing. We also looked at the number of eyes that gained cases of intraocular inflammation. However, there were some 1 or 2 patients did have thromboembolic phenomena over the period of follow-up. And these were the total number of injections we gave in the study, 814, and overall we found it to be very safe. So, so just wanted to give you highlight that even in Indian subset of patient, aflibercept seemed to work similar to what has been shown in global trials. So I'll end the aflibercept story here and we'll go little bit into the current generation anti-VEGFs. So since they are not available here, so I'll be talking about them very briefly. So 2 anti-VEGF drugs which are now available in India. Brolucizumab has been there with us for around 3-4 years. And I think Novartis people should thank us because Indians actually revived brolucizumab because US kind of they have shut down using brolucizumab. But in our set of patients, though IOI occurred, but the cases were limited, and the brolucizumab drug is quite effective, very, very effective. The only caveat is that once in a while we do come across very severe intraocular inflammation leading to occlusive vasculitis, and I think several of us have lost, you can say 1 in 1,000 eyes, that is the rough incidence we have seen in our population. But the drug otherwise has very good potency and durability is also very good with this drug. Faricimab has been recently launched into Indian market. I think a year back or so we had it. Again, the main data came from Yosemite and Rhine trials. Whatever experience we have till now, it gives a good durability in diabetic macular edema. The added advantage, though our experience is short-lived, but from trials it comes that it decreases the chances of epiretinal membrane and resolves the hard exudates more effectively. But as I said, our experience is still limited in time. So I think all of you are experts. I will not go into how to give anti-VEGF. One thing was previously highlighted by Dr. Sanyam, that every procedure should be taken meticulously, like full ocular procedure and full sterile protocol should be used. Dosing regimen, again, depending on the surgeon choice and patient's condition, you can use either fixed monthly. Most of people all over the developing world use PRN. I personally like to use treat and extend. So we give loading dose till edema resolves, and once it resolves, then most physicians stop or shift to PRN. But if edema reoccurs, then one has to start on treat and extend. And usually if you treat the diabetic macular edema well in the first year, then the requirement of anti-VEGF injections would be lesser in the subsequent years. So this is the million-dollar question. You have started the patient on anti-VEGF therapy, and now when to stop the anti-VEGF therapy? This is a real difficult question. Simple answer is either you are tired, you can stop, or when the patient is tired, you can stop the therapy. But that is on a very simplistic basis, and that is actually how you stop therapy in most of our patients. More scientifically speaking, when there is no further improvement, vision is nearly normal, CMT is nearly normal, you can stop the anti-VEGF therapy. When you have reasonable vision with some thickening, you can stop the anti-VEGF therapy, or if you have complications of anti-VEGF therapy, then you can stop. So if there is no response, we can have to rule out traction. You can try switching the molecules. Steroids, Chakravarti will be talking about. And of course, if they are leaking microorganisms, we can laser these. And some people even resort to targeted laser retinal photocoagulation, which sounds logical but has not given results in literature. Again, look at the systemic status. So very commonly it has happened with us that patient has hyperviscosity state, a nephropathy which patient has developed, then these can lead to worsening of diabetic macular edema. Very important is glitazones. Look at patient systemic therapy. Patients who are on glitazones keep on recurring, having diabetic macular edema recurrences, and one need to take them off glitazones for effective relief. And of course, we need to rule out PDR at subsequent stages as well. In general, if the patient has good baseline visual acuity, he will do well, but these are certain markers which suggest that patient is not likely to do well. Some of them include inner retinal disorganization and outer retinal disorganization. Usually intraretinal fluid is a poor prognostic factor. So to conclude, anti-VEGFs have become the gold standard of center involving DME. A careful planning and execution is required when giving and starting these patients on diabetic macular edema, therapy for diabetic macular edema. Ultimate aim is to minimize cost and visits of the patient, and please do not forget to rule out underlying PDR and other systemic effects of diabetes mellitus. Thank you very much.
Thank you so much, sir, for this very informative talk. Now, I would like to call upon Dr. Somnath Chakrabarti, who is a renowned vitreoretinal surgeon currently working at Regional Institute of Siliguri, to deliver his talk on diabetic macular edema when anti-VEGF is not enough, role of intravitreal steroids in DME. Please, sir, thank you.
Good afternoon. So we have had some wonderful talk on the role of anti-VEGF in management of center involving DME. So over the next few minutes, I'll try to answer this question. That is there any justification of initiating therapy of center involving DME with steroids? Now, why is this question relevant? If you look at all the guidelines, the European, American, or even the Indian guidelines, which are all based on randomized controlled trials, they are more or less unanimous that in most cases, you initiate therapy with anti-VEGFs and you can consider DEX implant as a second-line therapy if there is no or poor response to at least 3 to 6 anti-VEGF injections. And DEX implants as a first-line therapy are only restricted to patients who are pseudophakic, or patients who are about to undergo cataract surgery, or patients who had a recent history of a brain stroke or a heart attack. But then, is there any other justification in going beyond these two groups of patients? So let me share with you some of them. So if first and most important thing is when we look at guidelines, as I said, they're all based on RCTs. But if we analyze those RCTs, which were mostly conducted over 3 to 5 years, in spite of frequent anti-VEGF, many of the patients either did not respond or respond suboptimally. So if we look at those major anti-VEGF trials, we see that 40% of the DME patients had a suboptimal response, and 30% actually did not respond even after 3 to 5 years of continuous anti-VEGF therapy. So if there is a way to pick up those likely non-responders early, then we can actually initiate therapy with steroids in these patients. And today we have that option, because today we have some OCT biomarkers which are related to inflammation. And if you see those biomarkers in your patient, you can consider initiating therapy with steroids. 3 such prominent biomarkers are presence of severe intraretinal cyst, subfoveal neuroretinal detachment, and presence of hyperreflective retinal intraretinal dots, or HRIDs. So hyperreflective intraretinal dots, let me just discuss this a bit, because the other two, severe intraretinal cyst and subfoveal detachments, probably are very obvious. So this is hyperreflective intraretinal dots are not hard exudate clumps, because here are the two images. The top image actually shows some discrete hyperreflective dots which can be seen all across the retina, both in the inner retina as well as outer retina. This is supposed to be actually activated microglia and a sign of intraocular or intraretinal inflammation. So these are what we suggest, that if it is present in large number, that is more than 20, you should consider intravitreal steroids as a treatment of choice. On the lower image, we see what we call hard exudate plaques. These are usually clumps of protein or lipoprotein or cholesterol plaques, and these are irregular, and these are mostly in the outer retina. So let me show you one such case. Now this patient had bilateral DME, diabetic, hypertensive. You can see subfoveal neuroretinal detachment with a lot of hyperreflective intraretinal dots. So what we decided was to treat one of the eye with a DEX implant and the fellow eye with a brolucizumab, which, as Sir has said, is a newer generation anti-VEGF with a long duration of action. So we thought that because it is a durable anti-VEGF, probably it should give a good competition to DEX implant. So a month later, you can see significant reduction in DME, a significant reduction in the SRF in both eyes. But by 2 months, there was a difference. The right eye, which was treated with DEX implant, was still dry, but in the left eye, there was already an early recurrence. So we repeated the intravitreal brolucizumab, and in India, most of us treat brolucizumab or administer brolucizumab not as a loading dose, but in a PRN manner. So once we did that, again 2 months later, that means 4 months from the baseline, the right eye was still dry, but look at the left eye, it had still again breakthrough DME, and obviously systemic parameters couldn't have been playing a role because these are 2 eyes of the same patient. So at this stage, the patient opted to switch to DEX implant, and we gave the same. So this is at 6 months. Both the eyes are now looking stable, but in the left eye, there was still some heat in the CMT map superior to fovea, so we decided to do a focal laser. And a year later, you can see both the eyes are now having dry macula, but the visual outcome was was poorer in the left eye, which has around 6/18 vision, and this probably was because of the delayed resolution of DME. So last year, we published this study in Clinical Ophthalmology where we compared 20 patients, or 40 eyes rather, I should say, each, where we did a comparison of brolucizumab in one eye and DEX implant in the other eye on PRN basis. 11 of these patients had a refractory DME and 9 treatment-naive DME. And our finding was that the BCVA outcome was significantly better in the DEX implant eye compared to the brolucizumab eye.
And this difference was primarily because of the difference in the visual outcome in the refractory DME patients. And more importantly, what we found was in the DEX implant eye, the visual recovery was fast and sustained, but in the brolucizumab arm, it was not sustained. In the central macular change or anatomical gain, again, the DEX implant did better than brolucizumab. The important finding was that the DEX implant dried the retina fast, and then that drying effect was maintained. But in brolucizumab arm, there was recurrence, as I showed. Now, repeat injections, this is important because all of us, we know in the real world, we want to reduce the patient's treatment burden. The number of injections that was required in that 6-month follow-up period was much less with DEX implant, roughly 1 to 2, but with brolucizumab, it was 2 to 3, and half of the patients, or more than half of the patients on DEX implant, actually we could cover the 6 months with a single injection. Because of this less frequency of breakthrough DME, the amount of time we had to do a supplemental focal laser was also half with DEX implant compared to brolucizumab. So, if you have a patient of DME with OCT biomarkers suggestive of inflammation, based on our experience, we would love to suggest that you can consider DEX implant to start therapy with. Another justification is that if you look at those RCTs, they did not include all types of DME. So all DME phenotypes were not part of the RCTs. For example, a DME with hard exudate. You don't have any RCT trial for that. Studies do suggest that both anti-VEGF and DEX implant can reduce the hard exudate, but again, the resolution of hard exudate is faster with steroid than anti-VEGF. Second, post-vitrectomy eye. So we know that post-vitrectomy eye, the drug's half-life is reduced as far as anti-VEGF is concerned. But the recent VIT-DEX study shows that for DEX implant, the half-life is unaffected, whether the eye is vitrectomized or not. And then this particular phenotype, which is very common, that is a patient you are about to operate for cataract who also has DME. So this is not uncommon at all. A quarter of the diabetic patients who are about to undergo cataract surgery, they have DME, and we know that if we don't do anything about this DME, it will either worsen, or even if the DME was previously treated and had resolved, it is very likely to recur. And the primary driver behind this is the post-cataract inflammation. Because inflammation is the reason, therefore it makes sense that if we treat such patients with steroid, and between the two choices we have, IVTA and DEX implant, the DEX implant appears has the more potential because it has higher anti-inflammatory action, plus it has a sustained action of 4 to 6 months compared to IVTA. So here is one example of such a case. This patient, you can see the hazy media. So he had NS grade 2 cataract with center involving DME. So we gave a DEX implant followed by cataract surgery. So in my clinic, I do only retina. My colleague, Dr. Ganguly, does the phaco. So that was done around 2 weeks later after the injection. This is 2 months from the injection. You can see after cataract, the media has cleared up, vision has improved, and the retina is stable. But at 6 months, we had a recurrence of the edema when we repeated the DEX implant. This is almost a year later. You can see the retina is doing well and good visual outcome. So last year in January, we published this study where we had 20 cases of treatment-naive DME with cataract, whom we treated like this with DEX implant and followed by phaco. All the patients had significant visual acuity gain, and the central macular thickness change was sustained through the 6 months period. But most importantly, 3/4 of the patient, 15 out of the 20 cases, did not require a repeat injection, which again reduces the treatment burden for the patient. The 5 patients who actually required a repeat injection, majority of them were cases with severe NPDR or PDR in the background. So if you have any of these DME phenotypes, you are free to decide on your own because the RCT-based guidelines simply can't guide you because the RCT never included patients of DME with hard exudate, post-PPV DME or DME with cataract. The third justification, and this probably makes relevance, is that if you actually look in the real world, the anti-VEGFs do not seem to perform as well as they did in RCTs. So if you see in RCTs, we expect that anti-VEGFs, after 1 year use of anti-VEGFs, there should be around 8 to 12 letters gain, but the average gain in real world is around only 4 to 5 letters. But on the other hand, for DEX implant, the real world performance actually they're quite similar to the RCT gains that have been suggested. Now, the reason for this is, as has come up so beautifully in the cases presented by Dr. Sanyam and Vinod sir's presentation, that anti-VEGFs require repeated frequent injections and follow-up. And even if we see at the Indian experience, for this study by Dr. Aditya Kelkar from NIO Pune, that half of our patients actually never ended up completing the 3 loading dose. Nearly half of Indian patients are actually not coming back for repeat injection after a single dose in the real world, and 80% receive 3 or fewer injections, whereas we know that in the first year, if you are on anti-VEGF, you require 7 to 8 injections. The reason, 1, lack of insurance coverage, 2, difficulty in accessing retina services, and also lack of social support with no one to bring the patient home. So if you have an option to reduce the treatment burden, that might improve the compliance as well as the final outcome. So we recently did this study of retrospectively analyzing the outcome of our patients whom we had treated treatment naive as well as recalcitrant DME with DEX implant. Now this study has not yet been published, it's under review. But in this study, we had 102 eyes, 30 naive and 72 recalcitrant patients treated only with DEX implant. And what we found was both recalcitrant as well as in the treatment naive cases, there was significant improvement in both functional as well as anatomical parameters. But the important thing was, over a period of 1 year, the mean number of injections where implants required were 1 to 2, 1.83. And in the treatment naive group, actually the number of implants required were even less. And this is exactly what has been seen in previous other real world studies too. So if you have a patient who is unlikely to keep coming back for follow-ups or may not be able to afford your expensive injections because of lack of insurance, DEX implant may come in handy. But the final reason that every time keeps us, holds us back from using DEX implant aggressively is the fear of side effects. And there are basically 2. One is cataract. But the funny thing is, if we really look back at the real world studies, we see that the incidence of cataract post-DEX implant is not that high, and mostly they develop in the second year, and actually a lot of them do not require surgery. But then if you actually think, no one actually refuses a steroid out of the fear of cataract, because we have very wonderful cataract surgeons around us. It is the fear of an increase in IOP or secondary glaucoma that probably makes us hesitant in using steroid. But here too, if we look at the DME related patients, the risk of IOP elevation is much less. And in 97% of the cases, this IOP elevation is transient and can be easily managed with drops. So in the TREAT DME study, what we found was at the end of 12 months, only 25% of the cases of those 102 eyes actually had significant cataract, and only 10% of the eyes had a transient IOP elevation, each of whom could be easily managed with topical drops. So if the fear of adverse reaction is holding you back from using steroids more often early in your patients of DME, I think you can consider them, because the fear, most of the time these adverse reactions are not so common and are manageable. So if you ask me, I think that not only, as the guidelines suggest, not only should we consider early use of steroids in pseudophakics or patients having cataract with DME, or patients with recent history of CVA or acute MI, but even in patients of DME with inflammatory OCT biomarkers, or DME in patients like post-PPV DME, or DME with hard exudates, you can consider starting treatment with DEX implant. And if you have a patient who might not be coming back again and again for frequent repeat injections, you can consider DEX implant. Thank you so much.
Thank you so much, sir, for this insightful talk. Now, I would like to call upon our speakers from the previous session, Dr. Abhishek Kanand, to deliver his talk upon basic and steps of pediatric retinal surgeries.
Hello, I am Dr. Abhishek Anand. I am additional professor at RIO, Regional Institute of Ophthalmology, IGMS, Patna. I was supposed to deliver in the previous session, but my train got extremely late. And thank you, Dr. Pratap, and all of the NOS team for accommodating me. Can I have the slides? Okay, thank you. So my talk is basically trying to bridge. There are a lot of, I can see retina aspirants, my seniors and my colleagues, and we all know that pediatric retina services are somewhere lacking in whole of India, especially in this part, including the Bihar and the Nepal. My talk will be focusing on how to transition from this to the pediatric retina surgery so that we can be able to deliver the pediatric retina services better. So we all have to understand that pediatric eyes are not small adult eyes. They are basic anatomical difference between a pediatric eye, and that we have to take into consideration when we are doing the surgery. It starts very basic when you are applying your speculum because of the narrow palpebral speculum. So you need to have a specialized speculum so that you need an adequate exposure. The small orbit needs to be considered, especially while you are doing buckling. Then we have to understand there is a lens-globe ratio mismatch, and this is very important when we are trying to crisscross the acronym. Like in adult eyes, we can easily cross the midline. We don't need to do that because there is a high risk of touching the lens. Axial eye length has to be considered when at birth. It's 16.8 to 17.7, almost 70% size of the adult eyes, and that needs to be taken consideration, especially when you are applying the trocars and the cannula, and as well because most of your surgical instrumentation is maxed for the adult eyes and not at the pediatric eyes. There are specialized instrumentation which are present. Now, the most important thing is the sclera is thin at birth, and this leads to risk of intraoperative cannular dislodgement. So, sutured infusion cannula, there is a less chance that you will have an adequate valve effect if you are entering through the trocar, even with the 25 gauge. That's just not only with the 23 gauge. So, always make a meticulous closure. The cryo will come very fast, so you stop heavy cryo. Even in 1 second or 2 seconds, you'll have a good cryo effect. And suturing and dissection during scale buckling. We all know regarding the various algorithm that has been regarding where to enter at the pars plana. In premature infants, you start, I generally stay between 0.5 to 1 mm from the limbus. And whenever you are doing a scale buckling, we have to be very carefully handle the extraocular because there are high risk chances of avulsion. Look at the size of the difference in the extraocular muscles. I am doing a scale buckling in a case of ROP, stage 4A, and see how thin and flimsy. If I'm trying to be very heavy, it might come out very. If you are doing for a sutureless scale groove, you have to be very careful because the scale is almost 1/2 of the thickness of the adult size, and if you are trying to make the groove, you might enter the choroid very easily. Another very important aspect is the vitreoretinal interface, which is very adherent, and we have to stain and stain and stain. Even you can go for 2 times, 3 times stain until you are confident that you have completely removed the cortical vitreous. Use DDMS, Venous loop, and island forceps. For me, DDMS works the best. Venous is very good, but then the cost factor doesn't match me. DDMS we can use for 10, 15, 20 cases, and it just does very good. Now look at this is a case of a 10-year-old female. She has been post-traumatic RD. It appears that there is no vitreous present. I had to do resort. I could have put the PFCL first, but I was not seeing any break. So I did a small drainage retinotomy. I decreased the amount of the bullous fluid. I go again for staining the vitreous, and look at the very thin and flimsy vitreous that is present. And I am using the DDMS scraper to create annular detachment around the disc, and then I use the forceps to extend the dissection towards anteriorly. Once I have done that, use the forceps again to dissect, to pull it anteriorly, and then what is the typical is that you give another third hand that you use the PFCL to stabilize the posterior pole, and then you can mix and match. You can use the forceps or you can use the cutter to extend it peripherally and go as extensively anteriorly as possible, and the break was present just near the entry side. Now another very important point is that the intraoperative pressure control during diabetic vitrectomy, and you have to vary because most of us have the gravity fed system. You can have an active fed system also, but these children have a very low mean arterial pressure, so their chances of, now this is a case of a bleb ROP I am operating. Now why I am seeing this, showing you, because you can see, if you see very closely, the whole of the bleb is red when I have decreased it at the growing. Now, as soon as I increase the height of the bottle, you again see the whole of it is blanched. So how low the mean arterial pressure of the children is, and that can cause an intra-iatrogenic CRO. And another is regarding the draping, GA pipes. When most of the guys, when you are doing is because of you're doing in general anesthesia, and because the pipes of the general anesthesia are emanating from the mouth, so when you're using the non-contact system, they interfere with the movement. So you have to be very careful, look at it, talk with your anesthetist, how can you place the pipe more comfortably. And also you can use the smaller lens. Another very important trick is that you can use if you're using the recite system, you can use the green part of the recite system because the focal point is very further away from the eye, making the lens bump easier to avoid. Through this comes with in limitation of the field of view also. You have a specialized ocular pediatric lens vitrectomy system also, like the Lander system also. We have pediatric instrumentation system also. And then one of the very important was the Babu et al., which devised a simple method of spacing this. I think I'm using this because I have access to only adult-sized trocar cannula system. What I find it more advantageous is that when if you put a spacer of 240 band between it, it acts as a something on which the trocar cannula rests, and it doesn't allow it to flip, so you avoid the tilting, especially if you are going for a lens sparing vitrectomy. So this acts as a platform on which it rests. And closure of switch. Another is the pediatric instrumentation, as I have emphasized in the past also, that you need to be very meticulously closure. We have been trying this. We have done we are in the process of publishing this is by using the fibrin glue for peritomy closure for pediatric eyes. Because if you put a suture, like if you want to try to close the peritomy, the children are very, very aggressive and they tend to rub their eyes, and it gets beautiful closure. You can use the fibrin glue to achieve 100% closure and also achieve a watertight seal also. Another important is the informed consent regarding if you are going for the patients. Informed consent on many occasions, the findings on examination under anesthesia can alter the surgical plan. So before you go inside the eye, do see again, and if you find any differences, then you need to go back, talk to the parents if you are changing, if there is any change of. Avoid any pressure and examine both eyes. This is very important because many pediatric pathologies are bilateral in nature, and fellow eye can provide important diagnostic clues. Another thing is the examine family members. We don't always have, because you are practicing in different scenarios, when examining a family member itself can be a very effective genetic testing. But if you have access to ultrafiled field FFA, look at this eye. This eye appears to be completely normal. When we look at the periphery, it's a case of FEVR with complete, we have a new aspiration. The examination under anesthesia is a great supplement to complete clinical examination. This is a case of ROP. We wanted to know where this is the appropriate site of, before we entering, we wanted to determine what is the actual site of entry, and then we do this. Another is that we have to look for pre-placed anchor suture, use fresh ball cannula. Generally, we tend to reuse our system, so use of fresh ball cannula is very important. Use infusion characters with lock mechanisms to prevent slippage. I will just rush through my cases. Another is that in case of stage 5 ROPs, you need to do is that you, rather than entering from this, you can go for a limbal-based approach, and you can have a beautiful visualization itself once you get comfortable. So in this, I am visualizing through the recite system, but I am entering at the limbus level and not from the pars plana, because I want to avoid any iatrogenic. And PP in pediatric TRDs. Another is we can also go for biomanual dissection whenever it's necessary. This is a case of FEVR, it's a case of PFV with ROP also. So we need to sometimes resort to extreme measures also, because there is a central pucker which is holding up and tenting up the whole of the retina. So we can go for biomanual dissection also, and just release the central pucker, and then we can achieve a good anatomical also. And just to close this slide, PV versus scale buckling, especially in rheumatogenic RD, always are on the side of the scale buckling. It has been emphasized again and again, and I think I follow the same. Even if you're on the gray zone area, when you feel that the PPV might be, still I would give a chance with a scale buckling. So I'm running through the cases, and thank you. We also have to remember that many times we have multiple cases with syndromic features. Multiple things might coexist. This is a case of aniridia with FEVR sort of configuration. When we entered, this was a one-eyed patient. So if you look at the temporal retina, appears to be a FEVR sort of configuration with aniridia. So we have to do scale buckling also along with the silicone oil retention sutures that we needed to do. So that's just to emphasize that many times these children can present with multiple coexisting pathologies, also like axial field recoil syndrome presenting with a GRT. So to take away, bilateral eye examination, examination under anesthesia, examination of family members, ultrasound and ultra-wide field imaging go in a long way of managing pediatric retinal disorders, give parents realistic visual expectation, risk of anesthesia and long-term rehabilitation with a pediatric ophthalmologist. This is very important because amblyopia is a major concern. Tame the temptation to jump in pediatric RRDs. If buck level, do give a shot. Meticulous removal of cortical vitreous is important in RRDs. Pediatric TRDs relieve the traction force and have faith on the RPE pump, and always look out for any issue in young eyes to because retinoblastoma is a great mimicker. So, and always this is the dictum, less is more in pediatric VR surgery. Thank you for hearing me out.
Thank you so much, sir, for this insightful talk. Now I would like to call upon our next speaker, Dr. Avanish Deshmukh, who is a consultant, vitreoretinal consultant at Mahavir Netralaya, Patna. And sir, we will be talking about early vitrectomy versus intravitreal antibiotics for treatment naive endophthalmitis.
Good afternoon, everyone. I would like to thank Nepal Ophthalmic Society for giving me the opportunity to present this on this topic, which is a nightmare for the anterior segment surgeons, and it gives a lot of headache to everyone. So, first, just talking about a little bit about the background about it. Post-operative endophthalmitis is a very severe condition, and which can lead to an irreversible decrease in vision, and can even lead to phthisis and can lead to evisceration. So the endophthalmitis vitrectomy EVS study was a pivotal study in this topic, and since decades this was it is the standard treatment for every vitrectomy endophthalmitis. So in this study, it was stated that plasmana vitrectomy was beneficial for patients with BCVA of PL or less, and the intravitreal antibiotics alone should be more effective for patients with better best BCVAs. However, since EVS was conducted several decades ago, before the advancement in the vitrectomy techniques, including 23 gauge, the modern 23 gauge, 25 gauge instrumentations, the increased cut rates, and the improvement in the surgical tools, vitreous cutters, and wide-angle viewing system, the EVS recommendation seems to be a little mundane, and we are questioning increasingly on its effectiveness. So while it has significantly influenced the management of endophthalmitis for decades, emerging evidence has demonstrated benefits of PPV. In light of these controversies, the current randomized clinical trial aims to provide further evidence on the role of early vitrectomy in the management of PS endophthalmitis compared to intravitreal antibiotic. So in this, 20 cases who underwent cataract surgeries were selected, and they were divided into two groups. I made a random selection. Group 1, where visual acuity was hand movement or less. They had extensive AC reaction, hyperpine, a significant hyperpine, fibrillary membrane, pupillary, and there was dense vitritis on B scan. And in all these cases, immediate vitrectomy with silicone oil insertion and intravitreal antibiotics with steroids were given. Next group, the visual acuity, which were better than hand movement, CF or even better. Reaction was around 4+. There was no or streak hyperpine, and there was mild anterior vitritis in the ultrasound. In these cases, vancomycin, ceftazidime, and dexamethasone was given. 23 gauge conservative approach was adopted for the vitrectomy. Attempts were made to detach the posterior hyaloid wherever it was feasible, and the vitreous base was shaved, and vitreous sample was corrected, and the end of vitrectomy, fluid exchange, silicone oil insertion, and intravitreal injections of antibiotic and dexamethasone was done. 4 to 8 weeks after the surgery, initial surgery, silicone oil removal was done. For the second group, intravitreal antibiotics alone was given. The tap and inject technique was performed, and vitreous samples were collected, and antibiotics, vancomycin, ceftazidime, dexamethasone was implanted. So the second group of patient, unfortunately, due to the non-improvement, I immediately changed the modality into vitrectomy, and a second dose of intravitreal antibiotics with silicone oil was inserted 1 to 2 days post the first dose of injection, as the condition did not improve. Visual acuity was measured on the day of presentation and on around 3 months of the presentation. So the results in the group 1, where the immediate vitrectomy was done, a total number of 9 patients were there, and the vision was hand movement or less. So 44.4% of the patients had a BCVA of better than 618, and a couple of them had even had a visual acuity of 6.6. And one patient had a vision of 612 and one patient had 618. 2 of the patients had a final BCVA of 660 after the silicone oil removal, and 3 patients, the vision was CFCF of less or less. 2 of the patients unfortunately had to be converted. They had a retinal detachment post the vitrectomy under oil, and for which one of them was, the surgery was done and a C3F8 was inserted around 1.5 months after the initial surgery when the inflammation subsided. Fortunately, on all the patients, the inflammation subsided and none of the patient ended into phthisis or needed a evisceration. And most of them had, nearly all of them had a good vision, somewhat good vision. And some had an excellent vision, 6.6 vision. In the second group, total number of patients, around 5 patients had to be converted to vitrectomy a couple of days, 1 to 2 days post the injection. As the condition deteriorated, the reaction increased, the anterior vitreous, in the B scan, the vitritis also increased. So, and around 6 patients improved with injections also, injection only. Among them, 3 patients had a vision of 6.6, ended up with a full vision. 2 patients had around 636 and 3 patients ended up with 660 vision. 3 patients who in the patients in which the vitrectomy was attempted, 1 patient ended up with a CFCF vision or less, and 1 patient unfortunately ended in phthisis. So coming to the discussion part, it was observed that in the group 1, a vitrectomy group, 44% patients recovered a visual acuity of better than 618, and on the other hand, the second group, only 27% patients were in this category. And group 1 also had to, there was no second intervention needed in the first group, while 45% of patients in group 2 we had to do a second vitrectomy and repeat intravitreal antibiotics were given. So this is a food of thought that if we would have done a vitrectomy initial, could the vision be a 6.6 outcome or a 6.12 outcome rather than a 6.36 outcome? So with early and aggressive treatment, vitrectomy and injection included, 14 out of 20 patients were able to recover a very good vision, and even 25% of 5 patients recovered full 6.6 vision. So on concluding, the vitrectomy study was a landmark study in 1995, but it no longer aligns to the current surgical capabilities because since there is advance in the vitrectomy technology, and including the normal 25-27 gauge instrumentation, higher cutting rates, better machines, better fluidics, better peripheral shaving, better visualization, and wide angle visualization and panoramic view. So our findings suggest that both significant vision improvement was improvement over time. Both had a very good vision outcome, but the vitrectomy with intravitreal provided superior outcomes and lower retreatment rates. So, coming to the bottom line, a thorough clinical evaluation is vital to get a good vital visual outcome and save the eye in the post-op endophthalmitis. This study suggests that cases with findings of severe AC reaction, poor vision, hypopyon of 2 to 3 mm, hazy cornea, dense fibrin membrane, B-scan of vitritis, dense vitritis, immediate vitrectomy with silicone insertion, intravitreal antibiotics and steroids should be done. And cases where there is mild to severe reaction, a 6 CFCF or better vision, cornea is clear, minimal fibrin, intravitreal injection should be attempted, but as soon as we observe the deterioration in the vision, vitrectomy should be attempted with silicone oil insertion, and intravitreal antibiotics and steroids should be performed. I'd like to thank everyone.
Thank you so much, sir, for this wonderful talk. Now, with the request, with permission of our distinguished chairs, I would like to request Dr. T.P. Das, sir, to felicitate the speakers of this session. I would request Professor Dr. Rava Thapa ma'am to collect the token of love. A big round of applause for Dr. Rava Thapa, please. Now I will request Dr. Sanyam Bajimaya, sir, to collect the token of love. Dr. Vinod Kumar Agrawal, sir. Now I would request Dr. Somnath Chakravarti, sir, to receive his token of love. Now I would request Dr. Abhishek Anand to come to the stage and receive the token of love. Abhishek Anand. Dr. Abhishek, Dr. Avanish Deshmukh, please.
गिरेगा तो नहीं ना ये निकाल दो इसको गिर जाएगा ये डबल टिप सर
पूर्वी नेपाललाई स्वास्थ्यको माध्यमबाट चिनाउँदै अन्तर्राष्ट्रिय स्तरको सेवा दिन सफल संस्थाको नाम हो मेची आँखा अस्पताल। 28 वर्षदेखि यो अस्पतालले आँखा सम्बन्धी सम्पूर्ण रोगहरूको उपचार सस्तो र भरपर्दो गरेको कारण यहाँ उपचार गरेको भिड लाग्ने गर्दछ।
यो अस्पतालमा बिरामी आकर्षित हुनुको कारण क्वालिटी हो, गुणस्तरीय सेवा पाउनुहुन्छ बिरामीहरूले र त्यो पनि एकदम एफोर्डेबल प्राइस हो, सुपथ मूल्यमा भनौँ न, एफोर्डेबल प्राइसमा कुनै इकोनोमिक बर्डन नहुने मुख्य कारण बिरामी आकर्षित हुनुको कारण यही नै हो। र यसको साथसाथै हामीले यहाँ गरिब गुरुवाहरू जोसँग पैसा छैनन् उनीहरू चाहिँ हाम्रो अस्पतालमा हुने सुविधा आर्थिक अभावको कारणले चाहिँ नलिई जाँदैनन्। हामीहरू उहाँहरूलाई हाम्रो कहाँ सुविधा उपलब्ध छ भने बसाएर खुवाएर जाने भाडा पनि दिएर पठाउँछौँ र यसरी हामी मानव सेवामा तल्लिन्छौँ र हामीले क्वालिटीलाई विशेष महत्त्व दिएका छौँ। त्यसरी पनि बिरामीहरू आउने हो।
नेपाल लगायत छिमेकी राष्ट्र भारत, बङ्गलादेश, भुटान, बर्मा सम्मका बिमारी यो अस्पतालमा आउने गर्दछन्। यो अस्पताल झापाको बिर्ता मोड 3 सैनिक मोडमा अवस्थित छ। काँकडभिट्टाबाट 17 किलोमिटर, चन्द्रगढी विमानस्थलबाट 10 किलोमिटर र पूर्व पश्चिम राजमार्ग अन्तर्गत पर्ने बिर्ता मोडको मुक्ति चोकबाट 3 किलोमिटर दक्षिणमा आफ्नै स्वामित्वमा रहेको यो अस्पताल 4 बिघा क्षेत्रफलमा फैलिएको छ। आकर्षक र सुविधा सम्पन्न भवनभित्र आँखा सम्बन्धी लगभग सम्पूर्ण उपचार हुन्छन्। वरिष्ठ डाक्टर पुरुषोत्तम जोशीको नेतृत्वमा 16 जना विशेषज्ञ डाक्टरहरूले सेवा प्रदान गरिरहेका छन्। रेटिना, कर्निया, अकुलोप्लास्टी, पेडियाट्रिक, जलबिन्दु, मोतियाबिन्दु, ल्यासिक लेजर लगायत विभिन्न किसिमका नेत्र रोगहरूको उपचार स्पेशलिस्ट डाक्टरहरू लगायत 250 जना हेल्थ वर्करहरूले गर्ने गर्दछन्। दैनिक बिहान 8 बजेदेखि टिकट वितरण सुरु भई 9 बजेदेखि ओपिडी र अपरेसन बेलुका 6 बजेसम्म हुने समय निर्धारण गरिएको छ। शनिबार समेत 12 बजेसम्म अस्पताल चालु रहने तथा इमर्जेन्सी 24 घण्टा खुल्ला रहने गरेको छ। अस्पतालमा उपचारका लागि अत्याधुनिक उपकरण, अपरेसन कक्ष, जाँच कक्ष, ल्याब, चस्मा बनाउने ठाउँ, औषधि स्टोर, बिरामी बेड, कार्यालय, विश्राम स्थल, पार्किङ, बगैँचा आदिको राम्रो व्यवस्था गरिएको छ। अझै यसलाई उच्च स्तरीय बनाउनको लागि अस्पतालका वर्तमान अध्यक्ष जलकुमार गुरुङ कुनै कन्जुस चाहिँ नगरी लाग्ने बताउँछन्।
नेपाललाई राम्रो हुँदो रहेछ, नेपाललाई राम्रो गर्न सक्छ भन्ने वातावरण चाहिँ हामीले बनाउनु लागिराखेका छौँ। मेची आँखा अस्पतालले अहिले भनौँ न एक किसिमको पूर्वमा यो किसिमको वातावरण बनाइराखेको छ। यसलाई गर्नका निमित्त यो आँखा अस्पताललाई भनौँ न राम्रो गर्न निमित्त यहाँसम्म ल्याउनको लागि हाम्रो अग्रजहरूको ठुलो भूमिका छ। किनभने कुनै चिज कुनै बेस नभइकन माथि बढ्न सक्दैन के विजयजी। त्यस कारणबाट यो जुन मेची आँखा अस्पताल होल्यान्ड भनौँ डचले ठुलो सहयोगमा बनाइदिनु भयो। हामीले चाहिँ यसलाई चाहिँ भनौँ न बिस्तारै बिस्तारै स्तर उन्नति गर्दा अगाडि बढेर यो अवस्थामा आइराख्दाखेरि अलिकति आश लाग्दो भनौँ न सबै क्षेत्रलाई भनौँ न वर्गलाई सबै चाहिँ उसहरूलाई आश लाग्दो चाहिँ भनौँ न उहरू आइपुगेको छ। तर हामीले मेची आँखा अस्पतालमा जे गरिराखेका छौँ अत्यन्त योजनाअनुसार योजना बनाएर जुन कार्यक्रम बनाएर चाहिँ हामी चाहिँ अगाडि बढिराखेका छौँ। र अहिलेसम्म यो शब्द आउँदाखेरि अब हामीले भनौँ न यो मेची आँखा अस्पताललाई जुन उपचार गर्ने मात्रै होइन अन्य चाहिँ भनौँ न उसमा पनि जाने भनेर अहिले हामी अब यहाँ भनौँ न आँखाको डक्टरहरू हामीले यहीँ नै चाहिँ अध्ययन गराउने पनि अब हामीले एग्रिमेन्ट गरिसकेका छौँ। आँखा अस्पतालका शाखाहरू भद्रपुरदेखि लगेर बनानी भनौँ न दमक पाँचथर यो रवितिर भनौँ यता यो झापाको चाहिँ विशेष सबै प्राय नगरपालिकामा हामीले भनौँ न त्यो उपचार केन्द्रहरू पनि स्थापना गरेका छौँ। त्यसलाई पनि अहिले हामी स्तर उन्नति गर्न खोजिराखेका छौँ र त्यसलाई पनि अब हामी यहीँ बसेर भनौँ न यहाँबाट नै सबैलाई चाहिँ त्यसलाई होल्ड गर्न सक्ने सबैजना निर्देशना दिन सक्ने एक किसिमको अहिले चाहिँ उसहरू आएको रहेछ। त्यो पनि बनाउन लागिराखेका छौँ। यसो गतिविधिहरू चाहिँ सुरुदेखि के भइराखेको थियो भन्ने कुरो छ। तर अहिले आएर सबै चाहिँ भनौँ न हाम्रो चाहिँ दाजुभाइ दिदीबहिनी अथवा अन्य उसको पनि चाहिँ एउटा चाहिँ भनौँ मेची आँखा अस्पताल राम्रो गर्दा चाहिँ सकिँदो रहेछ है होइन। किनभने अरूलाई प्रभाव बनाउन सकिँदो रहेछ, अरू देश विदेशका मान्छेहरूलाई पनि विश्वास दिलाउन सक्दो रहेछ है भन्ने चाहिँ अलिकति केही न केही चाहिँ झलक देखिएको छ नि। यो वर्षदेखि पूर्ण चाहिँ एयर कन्डिसन होला। किनभने गर्मीमा तपाईँको चाहिँ पुरा चाहिँ गरिब दुखीहरू आउँछ, उनीहरूलाई एकदम गाह्रो भएको हुनाले अहिले हामीले टोटल्ली तपाईँको यो चाहिँ हस्पिटललाई चाहिँ एयर कन्डिसन वाला बनाउँदैछौँ। त्यति मात्रै होइन, जति पनि अहिले हामीले 200वटा हाम्रो फ्री बेड 200वटा बेडमा चाहिँ हामी पैसा लिँदैन, फ्री।
पूर्वी नेपाललाई स्वास्थ्यको माध्यमबाट
Yeah, sure, sir. Namaste and good evening, respected seniors, distinguished guests, and dear colleagues. What an honor it is to be gathered here today, surrounded by some of the finest minds in ophthalmology, united by a shared purpose to learn, to grow, and to carry forward the vision of excellence in eye care. The ambience in this hall reflects the essence of Noscon 2025, a platform where experience meets enthusiasm and knowledge transforms into inspiration. And this plenary session is one of the most awaited highlights of the conference, an evening that brings together pioneers who have redefined the way we see ophthalmology, both literally and philosophically. It's a privilege as young ophthalmologists representing the new generation to be standing here today, hosting this remarkable section alongside such eminent figures. So without further delay, ladies and gentlemen, let's officially begin the plenary session of Noscon 2025. We have an international leader whose name resonates with excellence in vitreoretinal surgery and diabetic retinopathy research. He has served as a regional chair of the IABP Southeast Asia, president of the Asia Pacific Vitreoretinal Society, and editor-in-chief of the Indian Journal of Ophthalmology. He is a recipient of the Padma Shri, an author, a mentor, and a poet, a man who sees beyond the retina into the human soul. Ladies and gentlemen, please welcome Professor T.P. Das, sir, an inspiration in both science and spirit. So the stage is yours.
They got to put a sticker here. Just stick it. They can put it down. Do you need pointer? No. Not come there yet. Okay, thank you very much for the kind introduction and the invitation for this place. I will talk about this place a little later. Let me begin with introducing this excellent example of academics to policy planning, Professor Madan Prasad Upadhyay, the academician of the Ministry of Health, Family Welfare and Trivandrum University, administrator to BP Koirala Institute of Medicine, public health specialist at WHO CRO in New Delhi, and finally important policy maker in corneal ulcer in agricultural community and vitamin deficiency in Nepal children. What is important to this talk is that the description of SAPO. SAPO is a severe unilateral inflammation of the anterior and posterior segment of the eye, usually in children or early adolescents, in specific seasons of the month, usually autumn, and happens every alternate year in Nepal since 1975. Earlier described as seasonal endophthalmitis, Professor Upadhyay described it as, named it as a SAPU. We are the first one to describe SAPU beyond Nepal in Bhutan in 2022, described in a young child, a series of cases with a young child with endophthalmitis-like picture and a B scan suggestive endophthalmitis, treated with a vitrectomy silicone oil, and he did ultimately well. Today, when we celebrate the 50 years of SAPU, with a publication coming from Professor Joshi and his colleagues, unfolding the mechanism of SAPU, it's very important that this year I'm personally here. I talk about similar endophthalmitis, but not SAPU, but endophthalmitis that happens in the eye, in the human eye. After cataract surgery, it is a randomized clinical trial called endophthalmitis management study, a new paradigm for establishing new kind of a therapy for endophthalmitis. This is my financial disclosure, but nothing is connected to this particular presentation. Endophthalmitis management study, EMS, is a multicentric clinical trial registered under Clinical Trial Register of India in 2019. It divides randomized endophthalmitis by a clinical signs, symptoms, not by the presenting vision, and something we call the inflammatory score, which we'll describe a little later. Once randomized to receive either a vitrectomy or an injection based on the inflammation score, are randomized to receive an intravitreal injection of septagenic vancomycin as prescribed by the EVS, or vancomycin and a new combination of drug of colistin or imipenem. If found microscopically or culture positive for fungi, then treatment changes. This is how we measure inflammation score. We published in 1999 another randomized clinical trial of dexamethasone treatment trial where we examined the presenting features of cornea, anterior chamber, iris, and vitreous in a scale of 0 to 4. Each tissue has got two important segments, example cornea, transparency, and abscess. And if that doesn't allow further progression, then we have got something to add at the below, that you add something like a 20, 15, 10, or 5. By the inflammation score, we divide the endophthalmitis, post-cataract endophthalmitis, into three varieties of either is mild, where the inflammation score is less than 10, or moderate, inflammation score 11 to 19, and severe one is beyond 20, as being shown in this particular slide presentation. We also validated the inflammation score by looking at the picture of the slit lamp photograph, and we find that it is very confirmatory, and also found that those who have got higher inflammation score usually by the bad bug organism. In this particular situation, it was Pseudomonas aeruginosa. These were the study drugs for the EMS. All are standard drugs like EVS was, but then inclusion of imipenem or colistin for gram-negative bacilli. We always injected intravitreal dexamethasone by a previous publication in 1999. We also give oral ciprofloxacin 750 milligram twice a day, in contrast to the recommendation of the endophthalmitis vitrectomy study. If found to be fungus positive, then we included amphotericin B or voriconazole randomized to them. Topical gentamicin 5% and oral itraconazole 100 milligram twice a day for several weeks. Patients are recruited from 3 adjoining states of India, Telangana, Andhra Pradesh, and Orissa. It was from 4 tertiary centers and 20 secondary centers at that point of time. There were 432 patients, 21 excluded. Ultimately, we got 411 patients. All of them had reduced vision or a hypopion, but majority of them most of them had a pain, redness, lid edema, etc. B-scan was done for 99% of patients, where retinal detachment was found in only 1.7% of patients. Disc was not visible in majority of the patients, as being shown here. And this was the final outcome of treatment, randomized treatment, that inflammation score reduced from 14.4 at the moderate endophthalmitis to less than 2, which is mild and recovering. Similarly, logMAR vision or the external vision improved from hand motion to at least 2400. The final outcome is that At least 1/4 of the patients after treatment had a good vision, that means 20/40 or more. Half of them had an navigational vision. 2/3 of them had ambulatory vision, but 10% of them could not see well. They become either blind or phthisis. In our cohort of 411 patients, there were 43% gram-positive cocci and gram-negative bacilli, 41%. Reason is that we are being a referral center, being referred most probably all the kinds of bad cases. Fungi in our case were 12%, and then, but when I did all the patients received actually a next-gen sequencing and a Sanger sequencing. When you put the gram-negative bacilli or the fungi for the NGS, then you found that those negative for culture negative are actually not culture negative, or actually were either mixed infection like polymicrobial infection or a mostly gram-positive cocci, gram-negative bacilli. In a fungal NGS, most of them were Aspergillus plebis. MDR, multi-drug resistant anaphylactic, was very high in this cohort of nearly 40% were MDR, and most of them belong to gram-negative bacilli. This was our culturable bacteria susceptibility report. Septaginine was not as sensitive, cefazolin is sensitive vancomycin for gram-positive cocci. Vancomycin, cefazolin was good and better than gentamicin or moxifloxacin, and gram-negative bacilli, colistin are better than aminoglycosides or septaginine or imipenem. What is interesting to see is that the organisms which were resistant to colistin, example here 12.5%, were all susceptible to septaginine, and those septaginine are susceptible to colistin, which means that a combination of septaginine and colistin might be better than septaginine alone. Colistin is a polymyxin antibiotic. It's a bactericidal in action. It acts against mostly on the gram-negative bacilli and inhibits cell wall synthesis. The dose, human dose, is 1,000 international units in 0.1 ml. This is how you prepare from a million dose vial, you prepare the colistin 1,000 international unit by this method. I'm not talking about septa vancomycin because it is standardly described in literature, but this is something new. By the side of the anastomotic vitrectomy study, we also did something else. From the data available from there and the data from the L.V. Prasad Eye Institute, we also designed something called IMA. IMA stands for Endophthalmitis Infectivity Measurement Algorithm. By that, looking at the eye on a slit lamp, can you possibly say infective or non-infective, given the fact that many might be culture negative, and the fact that you may not be doing Sanger NGS all the time because it's expensive. We found that if the cornea is relatively clear compared to here, if they have got a hypopion and reduced vision, then infective, otherwise it's not, even though there is little hypopion and vision is good. If the cornea is bad already, either an abscess, high degree abscess, or the association of hypopion, then invariably this will be positive, this will be infective. When you say infective, non-infective, I'm talking microbiology, microbiome infective, example culture, Sanger's and NGS, not the culture. And this side, the cornea is clear enough, then we'll have mild. These patients might actually benefit from just injection, no vitrectomy required, but these eyes, which are moderate or severe, require certainly vitrectomy and intravitreal injections. The sensitivity and susceptibility of IMI is very high. Accuracy is 77.14% for entire group, 82% for the culture positive, and 74% for the PCR or NGS positive. Right now, developing a algorithm tool or AI tool with the collaboration with the IIT Madras, where possibly when you take a picture of a slit lamp, or maybe someday later with your smartphone, it can give you an idea, almost some accuracy about the micropositive or negative, so that you can treat properly, because most places may not have microbiology facility, and the people in the periphery of India or Nepal somewhere, they cannot treat properly. In the summary, inflammation is important, major component of infection of endophthalmitis. Objective inflammation scoring is important. not ignoring presenting visual acuity. Decision for vitrectomy based on inflammation is superior than based on the presenting vision. Vancomycin continues to be good for gram-positive cocci, but colistin we find in India is superior to ceftazidime or imipenem or piperacillin tazobactam. Multi-drug resistance in India, at least, is not uncommon, and molecular and conventional microbiology work up together will be better than conventional microbiology alone. Treatment decision after this EMS study is not much different than the EVS study, except that you treat by inflammation score, not by the presenting vision. And that you treat by inflammation score less than 10, your intravenous injection might work. Inflammation score more than 10, vitrectomy required, but we suggest that instead of ceftazidime in India, we have changed to vancomycin and colistin treatment. If you look at the CDC data, both vancomycin and colistin are the so-called last drug treatment. It says that you are not supposed to use either vancomycin or colistin for empirical treatment, but in endophthalmitis, because there is a severe infection, inflammation, we consider giving this kind of drug for the eye. And what is the treatment actually? For vancomycin is only 1 to 2,000th of the for a systemic dose, and 1/9,000th of colistin systemic therapy. The half-life for vanco and or colistin is so short that even if you give intravitreal injections, it's not going to harm the patient systematically. So to consider that it will harm systemically is not very correct. But the good part is this. Today, when we see a patient with inflammation score less than 9, we say that half of the time we require only injection, half of the time we require additional treatment, and maybe 90% of the time require one more injection, and your outcome will be good. Do counseling with the patient. When you say patient of moderate infection with a 10 to 19 of inflammation score, we say that half of the time we require a vitrectomy and half of the time require a vitrectomy with another vitrectomy, and that your outcome might be 40% good. But when they're more severe, like more than 20 inflammation score, we certainly say while you are giving vitrectomy and intravitreal injections, probably we will not able to save much of the eye, because in our study said that only 4% will benefit from this. I had a talk in the last session about the EVS. And before 1970, before the era of Ghulam Payman and Robert McKimmor, it was always systemic therapy. Ghulam Payman, intravitreal therapy, McKimmor's vitrectomy changed the entire scenario to do a vitrectomy and antibiotic injection. 19 years later, after vitrectomy introduced, Bernie Draft from Pittsburgh questioned the idea, should you do vitrectomy all the time? Should you inject the systemic antibiotics all the time? That if he suggested that vitrectomy needed only for presenting vision less than hand motions, and systemic therapy not required. We took 35 years to question that suggestion again, and we say that most probably your vitrectomy and antibiotic injections and entire therapy must change now. We had a large group of clinicians, of data scientists, of microbiologists, and engineers to work on the whole core group. This morning, with the help of Professor Joshi, I went to my roots. 1983, I started my life here. This was my first job. When I finished my vitreoretinal fellowship in 1982 December, I was very sure that I will not work in retina for at least 1 year. I want to stay away from retina for a year so I will love retina again and again. This is where I started. I was WHO faculty, and when I landed in Kathmandu, and Nicole Gracie asked me whether I want to work in Kathmandu, just build Nepal hospital under care of Professor Ram Pokhrel, or you want to go to a distant place. I don't know why. I said distant place. This was the place given to me. I didn't choose the place, but I said distant place. I was posted here in Bhadrapur for a while. From this to a transforming hospital, and to that a big giant leaping hospital is a tremendous improvement. So when I come back to my roots, I had my pilgrimage this morning. So when Purushottam Joshi asked me to come here, I had agreed that I must come to this place after 42 years, 1983 and 2025. So thank you very much, Nepal Ophthalmic Society, and particularly Professor Joshi to bringing me here. Thank you so much. Okay, I can take it over. Thank you.
Thank you, sir, for that thought-provoking and heartfelt address. Your vision for eye care innovation, blended with compassion, truly resonates with every one of us. To begin the next, we have a living legend whose name itself shines brighter than any introduction we could offer. The man who gave light to millions, the god of sight, the visionary who developed the world-renowned Nepal method, sutureless small incision cataract surgery, making high-quality eye care accessible to all. The founder of Tilangal of Institute of Ophthalmology, a recipient of the Raman Magsaysay Award, the Order of Australia, the Padma Shri, and many more. We are truly honored to welcome Dr. Sandikrit sir, a name synonymous with compassion, innovation, and global impact. Please welcome Professor Dr. Sandikrit sir to the podium.
Very good evening and namaste to everybody. First of all, I'd like to congratulate Mechi Eye Hospital, Dr. Puru, the chairman of the hospital, and Foundation Eye Care. I think they are going to celebrate their 27th year tomorrow, so congratulations and thank you for having us here. Now today, I would like to talk and give you a bit of a storytelling about eye care in Nepal, mostly on my own personal experience and from the time that I started. And this is going to be very, very personal. If you look at the 5 decades of eye care in Nepal, the decade 1980 to 1990, you can see that we focused on the National Blindness Survey and infrastructure and human resources training. And I'm very lucky I was part of the National Blindness Survey as a very young medical officer and visited more than 15 sites all over Nepal as part of the blindness survey. The second decade is from 1991 to 2000, where we further looked into quality service and technology besides the two. Then, in the next decade, we started looking at the service coverage, which is very important, sustainability, technology, in addition to what we were looking for. And 2011 to 2020, you can see that we all started getting up into the needs of subspecialty services and trainings, of course. Research and documentation, monitoring and evaluation, sustainability and management was very important as the process came on. And then breaking barriers. And finally, in the last decade, the subspecialty continued, innovation and technology, scaling up the services, and breaking boundaries. We started moving out of Nepal, and sustainability, research, of course. Yeah. Now the 1980-81 survey, which was conducted, is still considered as one of the best national survey ever done anywhere. Very scientific, and according to that survey, the blindness prevalence was about 0.84, and almost 80% of the blindness was found to be avoidable, either curative or preventable. And cataract and sequelae consisted of 83.6% of the avoidable blindness. And when I said sequelae, it's the complications after surgery. Trachoma was very prevalent. You can see the blindness because of trachoma was about 6.5%. And again, the distribution of blindness was very interesting. It showed that the western Tarai of Nepal was endemic in trachoma. And then Madhya Pradesh had very high prevalence of cataract and high prevalence following cataract surgery. At that time, the population of Nepal was about 15 million when the survey was conducted in 1980-81. Now, this is how we used to do surgery. Intracapsular extraction, 180-degree Griffiths knife section, removal of the lens with either cryo, forceps, or tumble, or erisific. And I personally feel that I have very strong legs and back because of standing like that for many hours. And you can see how the surgery was with very little precision. And the sutures that were used were 8/0 virgin silk. And many a times we used to see very inflamed conjunctiva because of the knots of these sutures. And then, of course, the FAK glasses. And then Nepal moved into the era of stand-alone eye hospital. And Nepal Eye Hospital, which is parent hospital to most of us, was the first eye hospital in Nepal. And the concept of the eye hospital was basically autonomous and looks mostly into cataract surgery and refractive error. And it is community-based. There's a pricing tier and cost recovery, sustainability concept, quality assurance, and good governance. And the idea was to stay outside the government. Now, at that time, the barriers that we faced were because of the lack of human resources, infrastructure, consumables and equipments. And most of the equipments were very expensive, and training and research. And this is some kind of microscope that we used to use, modify the laboratory microscope, and then use in the field with a side light, and rotate the eyeball to see whether we can see any ray reflex for the remaining cortex to be removed. And these are portable microscopes that we later moved on to. Anyway, our mission at that time was an initiative to provide sufficient in terms of numbers in terms of quality, good quality, quality was always our main mantra, and sustainability, modern eye care in the community. And so we went on to adapt the surgical techniques and make sure that it is simplified enough and test it. And once standard operating procedures were produced, it was used for global training. The small incision surgery and cataract surgery, the surgical technique was standardized, gave extremely good results. We wrote SOPs, and training started here and also globally. This is just a picture gallery of a small incision cataract surgery. And then we had to prove to the world that small incision cataract surgery is safe and good results, and it can produce good long-term results. So we had to do a clinical trial here in Nepal. And this was a clinical trial done with Dr. David Chang, and we found that consistently over 1 year, the visual results, visual outcomes were comparable between the two techniques. And this was later published in the Cataract and Refractive Surgery Journal. So, now, of course, cataract surgery is very straightforward, predictable, quality assured. But in community, when we talk about community cataract surgery, it's still a challenge. These type of cataracts that you come across, complex cataracts with capsular changes, nucleus, jonules, pseudoexfoliations, corneal scars, many other things that you come across. So the thing that we were best in Nepal was to address the whole cycle of cataract surgical delivery. This is where Nepal really excelled for quality assurance, team building, station-wise, screening and diagnosis, governance, and partnership. All these components were addressed to look into the community cataract surgery. And this is often now scaled up in other countries, many other countries where they have benefited when we talk about the cataract surgical delivery in a more comprehensive way. This is just a box to indicate the human resources in Nepal. In 1998, we were 55. I think we are about 540. Where the presidents are? About 540? Yeah. So optometrists, you can see that the numbers very good. Ophthalmic assistant, the numbers very good. But we have started addressing another important manpower, which is biomedical engineer. The causes of blindness in 1980-81 and causes of blindness now are quite different. The prevalence of blindness since 2011 has come down from 0.84 to 0.35%, almost less than half. Nepal stands out as one of the few countries to be able to do this. And we were, in 2000, we were addressing all cataract patients with IOLs, which stood out against many of the surgical ways that our neighboring countries were doing it. So we were much ahead in providing all intraocular lenses. The residency program, I must say that the Institute of Medicine under Professor Madan Upadhyay had pioneered. Now, of course, Kathmandu University and National Academy of Medical Sciences and many other institutions provide residency program. iBank and IOL manufacture from Tilganga Institute of Ophthalmology. Trachoma was eradicated with the effort of NNJS, which is a great thing that we don't have trachoma now. And if you look at the cataract surgical rate from 1995 to the last data that I got was 2019, was almost 8 times or more than 8 times. And now, of course, we're talking about using phaco in the community. And we're discussing about the cost of the machines and consumables, and they're all coming down. Intensive standardized training programs, backup VR team, user-friendly machines, large target group, selection of cases, ways to lower the consumable costs. Yeah. Now, this is one PowerPoint that I really wanted to emphasize. Some of the unique things it was a national initiative. I must say it was a national initiative. It was based on a scientific survey of 1980-81, and there was tremendous collaboration between large stakeholders. And it was professional. This is a nice way of saying apolitical, but it was professional. Team structure, quality assurance and sustainability. Each ophthalmologist, when they wanted to set up an eye center, they will think about quality assurance and sustainability already now. And I think it's important now that we talk about public, private, and public and private partnerships. I think we have to move into that direction. This morning, when I was coming to Japa, I was visiting the Golcha Eye Hospital, and I was told by one of the Golcha families that the Golcha Eye Hospital was one of the first eye hospitals outside Kathmandu. And after Golcha, Lahan came up. He said that Mr. Ramlal Golcha, 40 years ago, when he developed cataract, he traveled all the way to Calcutta to get his cataracts done. So when he was coming back, he started thinking, why not we can have cataract surgery in Nepal? So this was, when he came back, he established the hospital to make sure that others get cataract surgery. Now, of course, of all these years, we have been having reverse exodus of patients from the other side of the border. And this is because of all the hard work that everybody has put together. Now, today, I'd like to talk about phaco and SICS. Nepal is one of the few countries in the world where many surgeons have both very good expertise on SICS and phaco. And there's a great need globally. I thought, why not we call this type of surgeons as hybrid surgeons? So, let's start calling it hybrid surgeons. I think a lot of people will start calling it hybrid surgeons now. And now I really like to recognize the contributions of Dr. Pokhrel, Dr. Nicole Grasset. Many of you may not know Dr. Nicole Grasset. Dr. Nicole Grasset was a French epidemiologist and public health personnel who eradicated the last case of smallpox from India. And after she finished her work there, she came to Nepal to help with the blindness program. And she was really behind the survey. She also helped to put together a lot of the NGOs together from many other countries to come and work in Nepal. And I definitely have very fond memories about this lady. And she, later on, she came with her dog all the way from Switzerland to have her cataracts done in Nepal. Such was the faith she had for Nepal. And many more of my seniors, my contemporaries, and all these young people that I hear, each of you have put in some effort to make this program of what we have now, what we can boast around the world. And it has been, it is still going to be a collective effort from everybody. So let's all walk together. Thank you very much.
Thank you, sir, for reminding us that innovation without empathy has no meaning, and that true service lies in touching lives. Your words and your work continue to inspire generations of ophthalmologists. Moving on now, we have with us a dynamic leader, an academician whose work in glaucoma and community eye health has brought Nepal into the global spotlight. Yes, indeed. He has served as the president of the Nepal Ophthalmic Society, president of the Glaucoma Society of Nepal, is also the president of the Ek Paila Foundation, a brilliant clinician, a visionary researcher, and a mentor to many, a rock star to me. Ladies and gentlemen, please join us in welcoming Professor Dr. Suman Thapa.
Good evening. Good evening to all. I'd like to thank the president of the Nepal Ophthalmic Society, Dr. Purushottam, and his brilliant team for this opportunity for me to come and speak to you about some of the work that I'm doing in terms of cataract surgery. But before that, Purushottam, he said, why don't you talk about your journey from the beginning as a cataract surgeon? So I'd like to share you the more interesting part than the other part that is to follow. So I have no financial interest, although the lenses that I use as premium IOLs are all Alcon. So my journey as an extra or as a hybrid surgeon, as Dr. Ruit has said, is I would like to share that. In 1999, I joined Tilganga Institute of Ophthalmology. There's a very nice story here, is that I'm not very comfortable wearing a suit and a tie, and my application had gone through to Tilganga, and Dr. Ruit had said, I want to meet this guy, So I was in a double mind, whether to wear a tie and go, or whether just to wear a shirt and a pant and just to go casually. So I said, I'll just wear a shirt and a pant. I was feeling pretty bold. And when I went there, Dr. Ruit was in his OT dress, and he made me sit on the grass patch in Tilganga, and he took my interview, and I was like totally out of words, and I said, I just really like this guy, and I really want to work in this institute. So that was my first connection with Dr. Ruit. So I joined Tilganga in 1999. I learned extra capsular cataract surgery with interrupted sutures, continuous sutures, and most of the learning was in the camps and in the OR. And my hands-on teacher was Dr. Rita Guru. And then in year 2000, I guess there was a lot of complications happening, so Dr. Ruit said that you have to go and train with Dr. Henning in Lahan. So that's a photo of my one-year training in Lahan. And that's when Dr. Henning, he welcomed me with a set of blades and a stone. And the first thing he taught me was, Suman, learn how to sharpen your instruments because you got to reuse them. So after every OT, I'd go back to my room, I'd resharpen the instruments, hand it over for sterilization, and work the next day. I watched videos of Dr. Ruit. Like he said, it was the standard operating procedure for all of us at Tilganga Institute. And I understood what restoring vision in high volumes at low cost really was. It was really, truly amazing. There were few or no recording devices. We couldn't record, but our brain worked as, a record player, rewinding and fast forwarding, and then we were sharing experiences. And I still remember the ophthalmic technician who was assisting me was telling me, don't do this, don't do that, don't do this, because he had seen so many young ophthalmologists like me making mistakes that he knew exactly, how for a young ophthalmologist to avoid complication. In 2001, I observed visiting surgeons doing phacoemulsification at Tilganga, and I was completely devastated, and I thought, all these fluidics and all these machines and vacuum and all this, I said, no way, I can never do it. And I did my first case, and I was like, it went terribly wrong. And at the same time, I had the opportunity to do a fellowship in Melbourne University in 2002, and the prerequisite was for me to be a phaco jockey to be able to do the glaucoma fellowship. So that's a photograph of in the year 2002 when I was doing a glaucoma fellowship at the Melbourne University. It was a hands-on fellowship. It was one of its kind, and it was run by Professor Hugh Taylor, who's a dear friend of Nepal as well. And I learned a bit of phaco, but I learned much more about glaucoma. In 2003, I returned to Tilganga. I pushed myself to do phaco. I read books on basic phacos. I read books on advanced techniques. And I had the opportunity to observe David Chang and Nagahara perform live surgery at Tilganga. So I was very intrigued by their techniques, and somehow I was able to combine two of their techniques, like Nagahara's, the full force vacuum, and David Chang's chopper. So I combined, and I even use it now. So from 2004 to 2021, I had a continuous journey as a cataract surgeon in Tilganga. I learned phaco, I learned SICS. I addressed more challenging cases of cataract. I got a better understanding of what goes behind doing cataract surgery. And I became a trainer for phacoemulsification. And in 2022, with a heavy heart, I again went to Dr. Ruit and I said, I wanted to leave Tilganga, not for this private practice, but my path had changed. During the earthquake, Ek Paila, a social initiative was born, and it was an idea brought about by a group of us. So my heart was bent on that, and I went and said, asked Dr. Ruit that I think I found my path, another path in life. I think it's time for me to move on. And he very graciously, he accepted, and he advised me, and he said that, these were his exact words, if I take your permission to quote Dr. Ruit, said that if I were in your place, I would have done the same thing. So today where I stand with Ek Paila Foundation, it's been with a lot of encouragement from Dr. Ruit. And then I started my own private OR because, of course, I had to do my surgery. And I became a more aware cataract surgeon, and I started customizing visual outcomes to patients, and I commenced on toric and multifocal IOLs. Because in a high volume situation, sometimes we are doing cataract surgery without really analyzing cataract like we analyze a person with a disease. So I started doing that, and I started taking additional risks with high cost IOL. So in all these years, I don't know what the numbers are, I don't know how many operations I've done, but I'm telling you, I've done plenty of surgery, and numbers really matter. The more you do, the more experienced you get. And the speed of surgery is not important, but becoming a careful cataract surgeon is what is more important. And with Ek Paila, what really happened, the beautiful thing that happened was that I also got non-institutionalized. All these eye hospitals have been gracious enough to collaborate with Ek Paila And we have done these outreach camps in so many of these areas, from the far west to the far east. With Mechi Eye Hospital, we have done in Phaktanglung, in the remote part of Taplejung. With Tilganga, we are going to do one in Humla next week. And just recently with Geta Eye Hospital, I just returned yesterday from Kulti in Bajura. So it's been a phenomenal journey for me. And our organization has been able to reach almost all of the mountainous districts throughout the country. And what I learned, more than cataract surgery, is that I got to see Nepal. So I was one of those, privileged kids, that who studied in Darjeeling, who came back, who had never seen Nepal, who only spoke English. Nepali पनि राम्ररी कुरा गर्न आउँदैन थियो जस्तो लाग्थ्यो त कुरा त गर्न आउँथ्यो तर I felt like a misfit in my own country. But the outreach clinics of Tilganga, it showed me the meaning of my life. It made me meet these beautiful people in my journey and sitting down and talking with them. And, bonding with the team, playing music in camps as always, and the first time I had Mustang coffee was coffee mixed with the local Raksi, made by Amro, Karma Dai, our cook, and then, dancing in the camps. These were all great memories. So now, looking really into the premium IOLs. Premium IOLs really means toric and multifocals. And it's my personal experience, which is not too many years, but whatever I know, whatever I've learned, I would like to share with you. So these are the modern landscapes of IOLs now. They are monofocals, improved monofocals, IOLs with extended range of vision, IOLs with a full range of vision, and in all of these comes the toric versions. So what the monofocals did? So it gave you one focal point, and it gave you a really bright spot out in the distance. And you needed a plus correction in the intermediate zone, and you needed a further stronger plus correction for the near zone. So if you look at this, take this as an example as a patient with cataract. Everything looks blurred. So when we put a monofocal, our distant vision is clear. When we put an enhanced monofocal, the computer vision is also clear. We look at the extended range of vision, or the EDOF as we call it. Then the mobile becomes clear. And then when you take a full range of vision, then everything appears clear. It appears clear. So if you look at the principle of optics, in the monofocal there is one focal point. In the bifocal there are two focal points. And in the extended depth of focal there are multiple focal points. But there is always a trade-off. Is that the monofocal will always give you the sharpest vision, and the trifocals will give you a little less of the distant, not so clear, clear vision, but not the sharpest vision. So there is always a trade-off. And these are the diffractive lenses that are there. And we have the monofocal, and there's the EDOF, and there is the panoptics, or the trifocals. So when we break that ray of light into more focal points, we are trading off. Some of them, there is a loss of contrast. In some, there's a loss of contrast. And we can look at halos and glares. So this is what a glare is. That's a halo, and that's a starburst. And this is what it looks like sometimes when we have multifocal lenses in our eye. And sometimes it can even get worse. And when we look at contrast sensitivity, we are really talking about the quality of vision. So in glaucoma patients who have loss of contrast sensitivity, we have to be extremely careful about putting all these multifocal lenses. Now the two lenses that I have used are the Alcon lenses, are the two varieties, is the IQ and the Clarion. The Clarion is the new version of the Alcon lenses. And these are made of better hydrophobic material. They are known as the HEMA. It has got more water content, more optical clarity, and it causes less glistening of IOLs as the lens stays in the eye for a longer duration of time. And the one change is that the Clarion, the aspheric anterior surface is the aspheric surface is anterior, which is further away from the retina. Therefore, it takes care of more of the spherical aberrations. So how do we work up a cataract patient with premium IOLs? There's no exact method, but there's something known as a defocus curve, which is extremely hard to do, but whom to select? So if I see a person who's relatively young, driving, and who wants to use the computer and the mobile phone, then I say, okay, let's go for an extended depth of focus. But if there is somebody who's sitting at home, who's not really driving, who wants a better near vision, then you say, okay, let's go for the panoptics, right? But every time we implant these lenses, we must pre-counsel them about the side effects. We must tell them that if you put an EDOF lens, not necessarily you're going to have great near vision. You may get great intermediate vision, but you may not get great near vision. And sometimes when you're driving, you can get halos, you can get starburst, but with the new hydrophobic material in the Clarin lenses, this is much, much less. We do a biometry. The biometry that I have is an Olsen formula, but the Barrett formula is the most accurate, the Barrett Universal 2 formula, because it really takes into consideration the posterior corneal astigmatism. There's an online calculator for an Alcon lens, and you can put your surgically induced astigmatism there, and it'll give you a printout of the kind of lens power that you need, the kind of toric placement that you need. So this is a technique that was taught to me by my friend Kishore. You know, I said, like, Kishore, how do we mark these, toric patients? He said, Dai, is very simple. You don't need all these fancy things. Just put this person on the slit lamp, and we ask put the beam horizontally, and you just split the pupil into half with that beam, and there you get your 0 and your 180-degree axis. I have used this, and believe me, it has never gone wrong. And on-table marking of IOLs, I don't like that big marker because it really marks the entire cornea. There are big lines that come in, so I just try to mark a little bit in the periphery, and that's how we mark the cornea. And what you shouldn't do is you should not hydrate and mark, because if you do that, it'll smudge. It'll get smudged. I won't show you the whole video because of the time that's running out. So your capsular rexus should be about 5 millimeters. Try and do it, make it 5, and really you can place the lens really well. And implanting an IOL, I like the Alcon injector because it pushes it right into the bag. You really don't have to keep fiddling and the half of it coming out of the bag and trying to push it inside. And we must take out all the visco, and then we must place the lens. And we should try to put these Purkinje's images together, because centration of the lens is also important. So the yellow one is from the lens, the white one is from the cornea. So if you're able to do that, overlap each other, then we know that the lens is very centered. So far, approximately in my clinic, I've done about 73 of these lenses, and I've had excellent results with 95% of the people having better than 6/9 vision, and people have great intermediate vision, and this is how I check. Oops. Well, this video is not playing, but this is a video of a patient who's had EDOF in both eyes, and I ask, are you able to read? And he says, I'm very happy with my distant vision as well as my intermediate vision. And to conclude is that patients have to be explained about intermediate and near vision. You cannot get away by not explaining about intermediate and near vision. And cataract surgical outcomes can be customized for patients' need. And patients are willing to pay for their vision. If you ask a patient, they'd say, the last thing that I want to do is, go blind. And there are people who are wealthy. There are people who will strive harder to get that money to put the best lens in their eye. But the greatest joy for me has always been going out in the camps and restoring vision. And this is a video. I think a lot of you have been talking to me about it. And I don't know whether I can, but this is the video from Bajura, where after we restored vision in one of the ladies, she's giving me a little bit of a competition in my dancing skills, but I think I gave her quite a good competition. Thank you very much.
Thank you, sir, for that enlightening session. Your passion for glaucoma care and innovation reminds us that early detection and sustained outreach can truly save sight and shape futures. We are deeply grateful for your commitment to both research and humanity. Thank you again, sir. And now, saving the most special for the finale, we have with us a leader who has been the guiding force behind Mechi Eye Hospital, the proud host of Noscon 2025, a man whose dedication, humility, and leadership have shaped Mechi Eye Hospital into one of the most respected centers of excellence, not only in Western Nepal, but around the globe. He currently serves as the president of the Nepal Ophthalmic Society and is a recipient of the SAU Excellence Award 2022. It is my deepest honor to welcome our own very medical director, Dr. Purushottama Joshi, to deliver the final plenary address.
My respected teachers and my VC of NAMS, the General Secretary of Nepal Medical Association, and my dear colleagues, namaste and good evening. Now I'm starting not the clinical subject we had previously, it's about the medical, legal and ethical issues in ophthalmology. So we ophthalmologists come across the legal cases or in court in three ways. As a third-party expert, and in cases where we are expert in civil matters or criminal matters like accidental trauma, trauma by assault, trauma while working, and the point of the Consumer Protection Act, and the legal proceedings against ourselves, the ophthalmologists. So the one rule of law is ignorantia juris non exuset, which means that the ignorance of law is not an excuse. We must have seen the interview of our NMA General Secretary Sanjeev Tiwari, Dr. Saab, who is here, with the lawyer in Sidha Kura and other TV programs where the lawyers fought us so vigorously. So ophthalmologists and their team members, including optometrists, OAs, eye health workers, are regulated by various ethical guidelines and statutes and legislations, and we should be knowing all these. And these are applicable to the practice of ophthalmology as well. So when the patient is unsatisfied for any reasons, he can go to three places and claim medical negligence. It's a case of triple jeopardy for us. He can go to the criminal court, Muluki Ain. He can go to Nepal Medical Council Act in 2020 and 2024, Bikram Sambat, that's, and Consumer Protection Act, the latest one from 2075. And the Medical Negligence Act offense under National Penal Code Act 2017 is section 231, we can get imprisonment up to 3 years and fine up to 30,000. Section 234, if there is death of a patient, life imprisonment, grievous hurt up to 15 years imprisonment. And section 231.1, 231.2, 32.2, and these are all the sections of the National Penal Code, which we can be penalized against if proven of medical negligence. So in Nepal Medical Council Act also, we could be penalized. Our license may be revoked for a certain period or suspended if we do misdiagnosis, delayed diagnosis, surgical errors, medication errors, failure to obtain the informed consent, negligent post-operative care, anesthesia errors, and lack of proper medical attention in emergencies. And now the most hue and cry is about the recent one, the Consumer Court, which came into operation from March 15, 2025 under the Consumer Protection Act 2018. And it has already slapped the medical professions with more than 3 crores of penalty. And how the legal procedure is: step one, from the patient side. Step one is filing the complaint. Step two is investigation in it. Step three is the prosecution on trial. Step four is judgment. If no negligence, we are okay. If medical negligence, we go to step five, appeal within 30 days to the High Court. If they are okay, very good. If we lose, then the final one is the Supreme Court. This is the hierarchy of our legal procedure here. So elements required to prove the medical negligence is there must be a doctor-patient relationship. The doctor must have breached the duty of care, the minimum standard. The breach must directly harm or cause injury to the patient, and the patient must have suffered because of this harm either physical, emotional, or financial trauma. So what would be our defense against those negligent cases? We can say patient's contributory negligence, like he was not putting medicine as advised, and the final result is unavoidable complication, or we can say novus actus interveniens, like it was an unforeseeable independent event that broke the chain of causation between the initial cause and the final effect. And we can also say that as a life-saving condition in an emergency situation, we act as on a good Samaritan way. Or we can have a res indicata or res judicata, where it was previously decided that this is not a crime, like in Nepali, Nazir, pailako Nazir bhayo bhane pani bachyo hami. And another is voluntary non-fit injuria. This patient voluntarily accepted the risks, like it's the informed consent. Okay, so what are the things that we can do to protect ourselves? So we must have the informed consent for medical and surgical procedures. We should have good documentation of each and everything, and we should be ethical, like there should be no misrepresentation of service and charges, no altering of medical records, and ophthalmologist economic interest, including clinical judgment and practice should be disclosed. If any other conflict of interest must be disclosed. So even with our best of the efforts, if we lose, then starts our emotional response to the litigation. First one is the stage of acceptance, like first is the shock, second is denial, third anger, like the GABDA, fourth bargain, fifth depression, and sixth acceptance. Some may stop in fifth, will always be depressed, can't go forward. Some may be in fourth, bargaining, but we should always go for the stage of recovery. Maybe after acceptance, we would see the chaos and our accidental response, our own intrusive reflections, our integrity is lost because of this. There is rumors. We must work hard to restore our personal integrity and endure the inquisitions of the court and obtain the emotional first aid. I'm very lucky in that way because my wife is psychiatrist. So emotional first aid I have a lot. And then we should move on. And then even with the best of effort and utmost effort, and if we go all these cases and we lose again in the Supreme Court, then what to do? We must compensate. And then we go through another emotional cycle, and to control and to minimize all these risks, we should and must have indemnity insurance. And that compensates for an insured party certain damages or losses, usually to the amount of loss. And it is the protection from the risk of paying the liable amount after found guilty or negligent. So one should, we medical professions know this very much. All the other lawyers and all the other citizens should also know. It is not possible to ensure that every treatment done by a doctor is successful. If it had been so, अस्पतालमा छ अस्पतालको गएको मान्छे कोही पनि मर्दैन थियो सबै अजम्बरी र अमर हुन्थे so we must know that the real fact मृत्युस्य ध्रुव सत्य that death is the ultimate thing, so we cannot prevent it. Medical care is fraught with life and death, and in our case loss of sight and even death also. And it is not like selling and buying consumer goods, because there are a lot of idiosyncrasies and inherent conditions like latent conditions, quality of medication, patient compliance. And after these consumer court hearings, we will try to protect ourselves, and this would be doing endless costly investigations for simple fevers, admitting patients in the hospital for simple injuries. Rather than clinical examination, we would focus more on documentation. The harsh reality would be the cost to the patient with more. So Nepal is at crossroads with the verdict of the Consumer Protection Court. Many have praised the establishment of the Consumer Court to rule on the claims of the medical malpractice, but fear defensive medical practice with the possible flight of the healthcare professional. If it is so, many would opt to better leave the country rather than serve here under the fear. So we have our General Secretary of Nepal Medical Association who has been fighting for this, and we'd like to say that we are with them in this fight for our justice for all the medical fraternity. Another thing, like how to prevent this? We must have the informed consent, and it must be the informed consent with real choice, and it should include all these fundamental things required for the informed consent, including the complications and any other alternative. If it is an off-label drug or a biosimilar, everything that is to be included in the informed consent, so that later on no one can point at us or sue us. Like this is the consent form of Mechi Eye Hospital. It is a blanket consent form. It is written that if anything happens to the patient during surgery or treatment, the hospital is not liable. But this is not enough. We need to change it. And this is one of the consent form that I presented during NVRS session. This is for the bevacizumab. Like it is to be in English, and it should be in Nepali also, like this. And if it is an off-label drug, we should mention it as an off-label drug. It is not FDA approved. The drug is actually used for colonic cancer, but we are using in eye. It is to be clearly written. And these are the list of off-label drugs we are using, like Avastin, infliximab, and a whole lot of mitomycin C, 5-fluorouracil. These are all off-label drugs. So if we have not informed the patient of this, we might get sued. And we should tell this in English as well as in Nepali, and we should include, like in cataract surgery, endophthalmitis also, like it might happen. So we should get our patient signed. And another thing is we should keep our hospital workplace also clean. Like there is one broken window theory. If a people sees like this, hospital's condition is like this, they are more excited to break more windows, and this is called broken window theory. So we need to keep our workplace also clean and quiet. Like mainly this is for the general hospitals where the conditions are usually like this. And now briefly on to the ophthalmologists, what legal problems we are facing. Like there is employment contract. In employment contract in many hospitals, we have to pay 3 months salary back if we do not fulfill our regular contract. It's not a bond contract, it's a regular contract. And in bond contract, we have MD bond and fellowship bond, and in the same way. And in government bonds, there is placement issues. Doctors are placed where there is not even a torchlight for the patient, for a slit lamp to examine the patient. We only have torchlight and other issues, and no other instruments. And my request to my colleagues, because all the hospitals, there are medical directors, they are in the governing positions. If they can say that if anything in our contract contradicts the rule of Nepal, then we should not do that. Like this employment contract and paying back 3 months salary, I urge all my ophthalmologists, especially the senior ophthalmologists who are in the position to change this, that if we go in the court of law, we cannot prove it. So it becomes void ab initio, void from the outset, as if the contract was not done. So I request senior ophthalmologists, my colleagues, to carry out the contracts which is in accordance with the Nepalese law, because we already have a legal advisor, and we will be doing everything to ensure that every contract is within the Nepal's law. And also, that was about ophthalmologist, and also about ophthalmologists where we work. Like this is one eye hospital in highway in Birta Mode. This is Birta Mode Eye Hospital, and there is another one new hospital here. You see, yes or not? Yes. And this is Mechi Eye Hospital. There is another new hospital here and here. This one was older hospital that was established before the introduction of 1 kilometer law, and this one was newly established between the two. So there also these things are to be also sorted out, because like some hospitals in their nameplate it is like this. It is Mechi, there is something other, and then eye hospital. If one looks, it is Mechi Eye Hospital. And in their bus, it is written like this, Mechi Eye Hospital. But there is something in between. So it is sort of deception also. Sort of deception. So we should, and if you could read or not, this is another eye hospital whose website is www.mechieyehospital.com. And you know that it is, the imitation is the highest form of respect, regard. So we think it's the highest form of regard for us from our colleagues, like this and this. And what this will always lead to is, we must have gone through Peda Bazaar in Burma, you know. And what one is like that, Asali Peda Bazaar, Asali Budo ko Peda Bazaar. Another, someday it will be like that in anywhere, maybe Jhapa, anywhere. So we have a noble profession of serving the people, and we should be ethical and moral also in doing that. And then lastly, we have our ethics, which is driven by our religion, beliefs, and we have our law. Above law and ethics, we must have our conscience to know what is right and what is wrong. If we do not have good conscience, we will be nowhere. Our profession will lose. Because if this kind of thing happen, all the patients who are coming from, like Dr. Sanduk Ruiz said, the exodus from the neighboring country, it will finish off. So to safeguard us also, we should be doing, our decisions must be legally sound, morally just, and beneficial to the patient. And on top of that, there's another thing also. There is ad in the website, if you go through it. If damage caused by doctor's negligence, we can do it this and that. Okay? And what they want to do is, do like this. Okay, so we must be very careful, and we should act very wisely. There is triple jeopardy, as already described. We may be incarcerated 3 times, later in High Court 4 times, Supreme Court 5th time again. But we should always have the courage to strike back. 3 strikes, still not out, and going on. So in summary, ignorantia juris nos existat. So we must know the law, and our saviors are informed consent, documentation, 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 and work towards indemnity insurance and ethical, moral, and legal practice from all of us. Thank you very much. And I would like to welcome you in November 12 to 14, in 2026 in Kathmandu. There is going to be another, our other annual conference will be in Kathmandu, and it will be in conjunction with 9th Asia Pacific Ophthalmic Trauma Society meeting, APOTS. So, and we are trying to make this in collaboration with NESOS, also Nepal Oculoplastic Society, and we'd like to see you all there. And one last, though the time has finished, we have President of Vitreoretina Society, Dr. Sanyam Bajima here, President of Nepal Oculoplastic Society, Dr. Ilya is here, and General Secretary of Nepal Glaucoma Society, Daki Didi is here, President of Pediatric Society, Sabina Didi, he is here. Let's pledge and let's plan to make at least 3 informed consents in Nepali as well as English. We, Nepal Ophthalmic Society, will help in whatever we can. If we make 3 from 5 of us, there will be 15 informed consents. We can work in that way, and let's do it, and let's save ourselves from all the pain of this. Thank you very much. Namaste.
Thank you, sir. Your word truly reflects the heart of Mechi Eye Hospital. Service, teamwork, and vision. You have shown us that leadership is not just about titles, but about trust and transformation. And just like that, this wonderful plenary session comes to a close. What an incredible evening of wisdom, humility, and inspiration has been. We heard from the legends who changed ophthalmology forever and reminded us that every surgery, every diagnosis, every outreach camp can be a story of hope. Before we close, we extend a heartfelt gratitude to all our distinguished speakers, Professor Dr. Tipi Das sir, Professor Dr. Sandhugrit sir, Professor Dr. Suman Thapa sir, Associate Professor Dr. Purushottam Joshi sir, for sharing their invaluable time and insight. Thank you so much, sir. Now I'd like to call upon Dr. Purushottam Joshi to hand over the token of love and appreciation to Professor Dr. Tipi Das sir. Next, I would like to call upon Professor Dr. Sandhugrit sir to be given the token of love by Dr. Purushottam sir. And now I would like Dr. Purushottam Joshi sir to hand the token of love to Dr. Sandhugrit sir. Finally, I would like to call upon Professor Dr. Suman Thapa sir. And of course, a heartfelt thank you to you all, our wonderful audience, for your presence, patience, and participation. This is me, Dr. Miraz Pokhrel, signing off. Thank you. Ladies and gentlemen, we'll be starting the inauguration program in about 10 minutes from now. So if you can, you guys can take a short break. I have an important announcement to make. For CPD points, please contact Mr. Raju Kesi. For CPD points, please contact Mr. Raju Kesi. He's waiting just outside Hall A.
phone silent कराया. Hello. Opening ceremony is about to begin.
May I please request everybody to be seated for the opening ceremony? यो टिक्क भएको छ है त्यो अर्को सरलाई पनि राख्दैन म
We would like to welcome everyone on Hall A for welcome opening ceremony.
May I request everybody to be seated for the welcome and inauguration ceremony? सुरु गरौँ क्या यो हटाउनु कन्फ्युज हुन्छ यहाँ राख्नु ल
सुरु गरौँ त्यो सरहरू आनन्द सर आउनुभयो एकजना पारबाट 1 2 3 4 5 सुरु गरौँ होला सरलाई आउँदैन
I request everyone to come inside and be seated for the opening ceremony. Good evening and namaste to everyone. A very warm welcome to all respected dignitaries, professors, colleagues, and my friends present here. I am Dr. Rajani Kesari.
And myself, Dr. Binita Thapa.
We feel truly honored to welcome you all to the 27th Nepal Ophthalmic Society Annual Conference 2025, held together with the 16th Eastern Regional Ophthalmic Conference and the Nepal Vitreoretina Society Annual Conference.
Yes, indeed, Dr. Rajni. It's a special moment for all of us. Today, under the roof of Mechi Eye Hospital, we unite the brightest minds and the warmest hearts of ophthalmology from across Nepal and the world. It's a celebration of science, service, and the spirit that connects us all. The vision to restore vision. We are truly honored to stand here as your host for this prestigious inauguration ceremony, surrounded by mentors we have long admired and colleagues we are proud to learn from.
So, to begin the program, may I kindly invite our respected dignitaries to take their seats on the dais.
Let's welcome Associate Professor Dr. Purushottam Joshi, President of Nepal Ophthalmic Society and Organizing Chairperson of Noscon 2025. Sir, welcome on the dais. With great respect and admiration, I would like to call upon our chief guest, Professor Dr. Bhupendra Kumar Basnet, Vice Chancellor of Nepal National Academy of Medical Sciences. Sir, please join us on the dais.
May I now request Dr. Sonyam Bajimaya, President of NVRS, to kindly come to the stage. Next, I would like to invite our guest of honor, Mr. Jal Kumar Gurung, the esteemed patron of Mechi Eye Hospital. It's my privilege and pleasure to call upon the General Secretary and Nepal Medical Association Secretary Dr. Sanjeev Tiwari. Sir, please join us on the dais.
And I would like to call upon the President of Nepal Medical Council, Professor Dr. Churamani Bhusal. Since he is unavailable, may I request Professor Dr. Anand Sharma as a representative from NMC to the dais. Sir. I would like to call upon the Scientific Chairperson and Vice President of NOS, Dr. Ranjana Sharma. Ma'am, please, the dais is yours. General Secretary of NOS and Organizing Secretary of Noscon 2025, Dr. Tejasu Singh Malla. General Secretary and Co-Organizing Secretary of Noscon 2025, Dr. Pratap Karki, to join the dais.
We would also request President of Nepal Optometrists Association, Mr. Neeraj Dev Joshi, and President of Nepal Ophthalmic Assistant Society, Mr. Ramesh Ghimre, to come forward to the dais.
In the front rows, I would like to request President of Nepal Cornea, Cataract and Refractive Surgery, Dr. Mini Chaudhary, or her representative, Dr. Poonam Lavazu, President of Nepalese Society of Oculoplastic Surgeon, Dr. Elias Resta, President of Nepal Glaucoma Society, Dr. Indira Paudel, or her representative, Dr. Daki Sherpa, President of Nepal Pediatric Ophthalmology and Strabismus Society, Professor Dr. Sabina Shrestha, and President of Young Ophthalmologists, Nepal, Dr. Amit Yadav, to have seat on the front rows. Likely, we would also request our foreign delegates to join the first row, along with the other executive members of NOS and
societies on the front rows. A warm welcome to you all.
Okay. Now, may I request everyone to rise for the national anthem of Nepal.
ढुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौमै फैलिएका मेची महाकाली सयौं ढुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौमै फैलिएका मेची महाकाली प्रकृतिका कोटि कोटि सम्पदाको आचला वीरहरूका राजधानी भूमि शान्ति भूमि तराई पहाड हिमाल अखण्ड यो प्यारो हाम्रो मातृभूमि नेपाल बहुजाति भाषा धर्म संस्कृति छन् विशाल अग्रगामी राष्ट्र हाम्रो जय जय नेपाल।
Thank you.
Light represents knowledge, peace, and positivity. I now request our chief guest and Nepal Ophthalmic Society president and guest of honor to come forward and light the panas to formally begin the conference.
Dr. Bhupendra Kesi, sir. May this light guide us toward a brighter future for eye care in Nepal.
Now, to make this evening even more special, let's enjoy a short welcome performance by our local artists. They are going to perform in a Satar dance, which is a traditional dance of Satar community in eastern part of Nepal. To celebrate the victory of good over evil and has a deep cultural and spiritual significance.
beautiful start to the evening. Thank you to all the performers for adding color and warmth to our program. Thank you.
What a wonderful, wonderful performance. Now we have Rajbansi dance, which is also a traditional folk dance in Rajbansi community of Eastern Nepal. It reflects theme of nature, daily life, love and community bonding. Let's welcome them.
Music. The stage is yours.
तमाक सभाके स्वागत छ हृदय राजवंशी यूट्यूब च्यानलमा यदि तमाक च्यानललाई सब्स्क्राइब नि गरौँदा सब्स्क्राइब गर्ने सँगै बेल आइकन दबाउने जरुर थिचिदिनु क्याकि तमा देखोस् त भन सबसे पहिला
स्वागत करे भाई बहिला 2000 बंदगी सभा के स्वागत छे सभा के स्वागत छे सभा के स्वागत करे दादा भाईला स्वागत करे भाई बहिला आदिकालीन भूमि पुत्र हमारे वासी अपना है भाषा संस्कार सदाई जगलदानी 2000 बंदगी सभा के स्वागत छे सभा के स्वागत छे सभा के स्वागत करे दादा भाईला स्वागत करे भाई बहिला वंशेर वीर हमा अलग छेसा अपन दुख वीर सहे पछै असर मान कुछ वंशेर वीर हमा अलग छेसा अपन दुख वीर सहे बचाई असर मान जागे रहे दादा भाई बहिना भाइ बहिनीलाई
2000 बन्दगी सभा के स्वागत छे सभा के स्वागत छे सभा के स्वागत करे छु दादा भाइलाई
स्वागत करे छु भाइ बहिनीलाई
A huge thank you to the Mechi team for their fantastic dance. The energy and skill were incredible.
Now, we have with us the guiding force behind Nepal Ophthalmic Society Annual Conference 2025, our organizing chairperson and president of Nepal Ophthalmic Society, respected Associate Professor Dr. Purushottam Joshi. I'd like to invite sir for his welcome address and opening remarks.
मेरा श्रद्धेय गुरुहरू सन्दुक रोहित सर, आनन्द शर्मा सर, बद्री बडु सर, राजेश प्रधान सर तथा मेरा अग्रजहरू सबैलाई मेरो नमस्कार। म यहाँ तपाईहरुलाई स्वागत गर्न आएको छु। आज सेसनहरू त्यतिकै पनि ढिलो गइरहेको छ, त्यसैले म सर्टकटमा स्वागत गरिहाल्छु सबैलाई। मुख्य स्वागत गर्नुपर्नेमा I would like to welcome Professor Dr. T.P. Das, Dr. Somnath, Dr. Santanu Ganguly, Dr. Banod Kumar, Dr. Avnish and Dr. Abhishek Anand from India, Professor Dr. Shah Mohammad Shamsunoman from Bangladesh, Dr. Iftikhar Iqbal and Dr. Faria Osman from Bangladesh, Dr. Agoy Abera and Dr. Az Laudari from Ethiopia. And I would like to welcome one and everyone who are present here. In this Noscon, we have, from the traditional part, we have done 2-3 things different. Like we have started a LDP course, and we are having a separate hospital infection control session. And we are doing this in Mechi for the 3rd time. And I would like to once again welcome you all. And मलाई एउटा भन्नै मन परेको कुरा के छ भने हाम्रो आज हिजो जसरी वायुले आफ्नो कार्यक्रमहरू गर्यो वायु नाइट, त्यो अति नै सराहनीय र उदाहरणीय थियो। हामी अप्थाल्मोलोजिस्ट भएपछि वायु भनेको 40 वर्षसम्मको छ। मलाई लागेको कुरा चाहिँ अप्थाल्मोलोजिस्ट एमडी सकेपछि 5 वर्ष वायुमा गर्ने, 5 वर्षपछि नसमा आउने हो कि यो बारे एकचोटि सोचेर हामीले त्यसरी गर्यो भने रोलको डुप्लिकेसन हुँदैन होला कि, किनभने वायुमा हुनेहरू पनि नसमा छन् तर डुप्लिकेसन भइरहेको छ। त्यसो भयो भने अझ पारदर्शी र अझ हाम्रो सहभाग इन्क्लुसिभ हुन्छ होला जस्तो लाग्छ र यो कुराबारे हामी अझ पनि छलफल गर्छौं। र म फेरि पनि सबैलाई स्वागत गर्छु र यो इभेन्ट हुनमा सबभन्दा महत्त्वपूर्ण भूमिका खेल्ने हाम्रो मेची आँखा अस्पतालका सबै कर्मचारीहरू र मुख्यतः डाक्टरहरू र डाक्टरहरूमा पनि डाक्टर ईशा, डाक्टर अशेष, डाक्टर अंकित, डाक्टर चन्द्र, हाम्रो भन्यो भने लामै हुन्छ नाम, सबै कर्मचारीहरू तर हामीलाई जहिले पनि मार्गदर्शन गरिराख्ने मेची आँखा अस्पताल संघका अध्यक्ष तथा मेची आँखा अस्पताल संघको टिम, हाम्रो अध्यक्ष जलकुमार सर, सबैलेको मार्गदर्शन र इन्स्पिरेसनमा हामीले यो गर्न सकेका छौं। र हाम्रो छोटो सर्टकटको निमन्त्रणामा हिजो मात्र अमेरिकाबाट काठमाडौँ ल्यान्ड गर्नुभएको नाम्सको भिसी प्रोफेसर डाक्टर भूपेन्द्र बस्नेत हिजो ल्यान्ड गर्नुभएको, जेट ल्यागको पनि वास्ता नगरी आज यहाँ उपस्थित भइदिनु भएको छ। उहाँलाई पनि धेरै धेरै धन्यवाद दिन चाहन्छु। र योपालि एउटा के भने राम्रो खबर चाहिँ के थियो भने योपालिदेखि हामीले त रेजिडेन्टहरू धेरैलाई सिकाइराखेका थियौँ पेरिफेरल सर्जिकल पोस्टिङ गराएर, तर योपालिदेखि चाहिँ हामीले आफ्नै रेजिडेन्ट पनि पाएका छौँ। यसको लागि पनि नाम्सलाई धेरै धन्यवाद दिन चाहन्छु। र यति भन्दै म सबै उपस्थितहरूलाई स्वागत गर्दै म बिदा हुन्छु। नमस्कार। यहाँको बसाई खवाई सब चिज एकदम राम्रो होस् भन्ने कामना गर्दछु। धन्यवाद।
Thank you, sir, for your kind words and inspiring leadership. Next, we would like to invite Associate Professor Dr. Ranjana Sharma, Vice President of Nepal Ophthalmic Society and Scientific Chairperson of the Conference 2025, to share a brief message on the behalf of the Scientific Committee.
Thank you. Respected Chief Guest, Vice Chancellor of National Academy for Medical Science, Guest of Honor, President of different societies, sub-societies, representative from Nepal Medical Council, General Secretary from Nepal Medical Association, distinguished guest of plenary session, distinguished guest, faculty members, seniors, my dear colleagues and friends. Namaste and warm greeting to you all. It is a great honor and privilege for me on behalf of Scientific Committee to welcome you on Noscon 2025, the 27th Annual Conference of Nepal Ophthalmic Society, held together with the 16th Eastern Regional Ophthalmic Conference in the beautiful city of Pitambor, Jhapa. This year, our conference is very special because we have collaborative session with the Vitreoretina Society, because with the aim of Nepal Ophthalmic Society to have a greater bond with the sub-societies and to promote academic growth. Our theme this year was bridging the gap in eye care, innovation and challenges. This expresses our goal to improve access to quality eye care service. We hope this conference will help us to learn from each other, share knowledge, find solution to the challenge we face in providing eye care service to all. For the last 2.5 days, we have rich scientific programs that includes around 55 oral presentations, 22 poster presentations, nearly trained instruction course, leadership development program, young ophthalmologist program, scientific competitions, panel discussion and answer workshop. The change this year is all the abstracts were in the conference were submitted by website and were pre-reviewed blindly, and which was done carefully to make selection process fair, scientific and more ethical, because to encourage our young researchers for the better improvement in research quality and research. This effort is commitment in maintaining high academic excellence in the field of ophthalmology. I like to thank, sincere thanks to Nepal, President of Nepal Ophthalmic Society, President of Vitreoretina Society, and all the presidents of sub-societies for dedicating their focal person in the scientific group, because of which we could discuss and we could plan our scientific session very effectively and very fruitfully. So I like to thank everyone and welcome. So enjoy this 2.5 day session for the knowledge exchange, to exchange your experience and strengthen our ophthalmic practice. Thank you. Enjoy Noscon 2025.
Thank you, ma'am, for that encouraging message and for leading such a rich scientific program this year. We now move to the inauguration of the abstract book and Mechi Eye protocol. For this, may I kindly invite Mr. Jal Kumar Gurung, patron of Mechi Eye Hospital, to do the honors. Yes. Mm-hmm.
This represents months of hard work and collaboration. Congratulations to everyone involved.
Now, the most awaited part of the evening, the awards ceremony. These awards celebrate years of dedication and excellence in ophthalmology. The awards will be presented by our President, respected Dr. Purushottam Joshi, Chief Guest Dr. Bhupendra Kumar Basnet, and Guest of Honor Mr. Jal Kumar Gurung.
We begin with the Lifetime Achievement Award given to our respected senior for their lifelong contribution to the field. Dr. Bal Kumar Kesi, Senior Ophthalmologist and Medical Director of Virat Eye Hospital and KCC Mechi Nagar.
Dr. Gokarna Dhakal, he is a senior ophthalmologist. He began his eye care services in 2014 BS from Lahan Eye Hospital and later served in several major eye hospitals across Nepal, including Rapti and NAMS, earning the title of Associate Professor, and he established the ophthalmology department at the Civil Service Hospital.
To invite Dr. Chunlok Tenzing, Medical Director at Seva Foundation with over 20 years of global experience in eye care program design, implementation and evaluation. He holds medical degree from Kolkata and Mangalore universities and an MPH from Johns Hopkins University. Specialized in cornea and cataract surgery with extensive clinical and teaching experiences in Nepal and Tibet, he has represented Seva Foundation internationally and contributed to the key research on blindness and cataract outcomes. He has also been recognized with the Asia Pacific Academy of Ophthalmology Distinction of Service Award. I would like to call upon Professor Dr. Sabina Shrestha, a renowned ophthalmologist, academic leader, and a creative professional from Nepal. She serves as a professor at Kathmandu Medical College and she has several national and international awards. Beyond medicine, she is also a published poet, singer, and award-winning visual artist. Congratulations to our respected seniors.
Professor MPU Oration Award. This year is represented to Professor Dr. Tara Prasad Das for his outstanding contribution in ophthalmology and medical leadership. Dr. Tara Prasad Das sir is a renowned ophthalmologist and highly respected academic leader in the region. He has served as a director and vice chair of LV Prasad Eye Institute in Hyderabad. Dr. Das has contributed significantly to national eye health programs and policy development, shaping standards of quality and ethics in ophthalmic practice.
Next is the Professor Ram Prasad Pokhrel Best Resident Award 2025. Congratulations to our winners, Dr. Kusal Guru from BPKHS. Dr. Siwani Raimazhi from NAMS.
May I please request respected Professor Dr. Purushottam Joshi to hand over the award to all the winners.
Dr. Sophia Makazu from Kathmandu University. Dr. Dicheng Megan Lama from Tribhuvan University. great success in your careers ahead.
Now, the Professor Dr. Jeevan Kumar Shrestha Best Research Award goes to Dr. Pragati Gautam. The second winner is Dr. Barsa Suwal. I think she is not available at this moment. So now finally, the Nepal Ophthalmic Society Drishti Travel Grants are being announced by Professor Dr. Bhupendra Kumar Bhatne sir. So this award will be on hold today. Okay. So this will be based on the judgment round of oral and poster presentation. So it will be hold for today. Everybody, let's put your hands together for another awards.
Any other representative for Dr. Barsa? Please. For Dr. Barsa Suwal, any representative? Now may I invite our respected patron, Mr. Jal Kumar Gurung, to share his remarks. Sir.
धन्यवाद उद्घोषक महोदय, यस कार्यक्रमको अध्यक्षज्यू, आजका प्रमुख अतिथि बिसी भूपेन्द्र बस्नेतज्यू, वरिष्ठ नेत्र चिकित्सकज्यूहरू, उपस्थित सम्पूर्ण विभिन्न स्थानबाट पाल्नुभएका देश विदेशबाट पाल्नुभएका सम्पूर्ण डेलिगेट साथीहरू, उपस्थित दाजुभाइ दिदीबहिनीहरू, म स्वागत गर्न चाहन्छु, सम्मान गर्न चाहन्छु मेची आँखा अस्पतालमा। र यो जुन किसिमको यो कार्यक्रम कन्फरेन्स गर्नको निमित्त मेची आँखा अस्पताल बिर्तामोड झापालाई तपाईँहरूले दिनुभएको छ, यसको लागि पनि म धन्यवाद दिन चाहन्छु। अब समय धेरै गइसकेको छ, अब भोलि पनि हाम्रो 15 नोभेम्बर भनेको चाहिँ मेची आई हस्पिटलको वार्षिक उत्सव पनि छ। त्यस कारणबाट सम्पूर्ण उपस्थित डाक्टर साहबहरू लगायत सम्पूर्ण डेलिगेट साथीहरूलाई हाम्रो वार्षिक उत्सवमा पनि 3 बजेपछि उपस्थित भइदिनका लागि अनुरोध गर्दै मन लाग्छ तपाईँहरूको यो 3 दिनको बिर्तामोड झापा बसाइ राम्रो नै भएको हुनुपर्छ भन्ने लागेको छ। जे भए पनि रमाइलो गर्नु, जिन्दगी नै यस्तै हो, तपाईँको राम्रो नराम्रो तल माथि जे हुन्छ हैन, सङ्घर्ष गर्नुपर्छ। र तपाईँहरूले चाहिँ नै भनौँ न धेरै चाहिँ नै के अरे भनौँ न आँखा रोगीहरूलाई चाहिँ तपाईँहरूले चाहिँ नि भनौँ न उद्धार गर्नुभएको छ। आज मलाई खुसी लागेको छ, डाक्टर सुन्दक रुई जस्तो भनौँ न संसारकै चाहिँ वरिष्ठ चिकित्सक उहाँ आइदिनु भएको छ। यसको लागि उहाँलाई म फेरि पनि म स्वागत सम्मान गर्न चाहन्छु। बिर्तामोड झापाले भनौँ उहाँलाई धेरै चाहिँ नि भनौँ न यहाँका आँखा रोगीहरूले पनि सम्झनुहुन्छ, किनभने उहाँले धेरै उद्धार गर्नुभएको छ। त्यस कारणबाट आज समय छैन, त्यस कारणबाट फेरि पनि म सम्पूर्ण उपस्थित दाजुभाइ दिदीबहिनीहरूलाई स्वागत सम्मान गर्दै बिदा हुन्छु। धन्यवाद, नमस्ते।
Thank you, sir. Next, we have our chief guest, Dr. Bhupendra Kumar Basnit. We are deeply honored to have your presence, sir. May we request you for your remarks.
Thank you. नमस्कार, गुड इभिनिङ। आजको यस कार्यक्रमका सभा अध्यक्षज्यू, नेपाल अप्थाल्मिक सोसाइटीका अध्यक्ष डाक्टर पुरुषोत्तम जोशीज्यू, ड्यासमा आसीन हुनुभएका मेची आँखा अस्पतालका प्याट्रन, विभिन्न सब स्पेसियालिटी अप्थाल्मिक सोसाइटीका अध्यक्षज्यूहरू, नेपाल चिकित्सक सङ्घका महासचिवज्यू, ड्यासमा आसीन उपस्थित महानुभावहरू, साथै यहाँ अग्रपङ्क्तिमा उपस्थित हुनुभएका सम्मानित मेरा अग्रज चिकित्सकज्यूहरू, डाक्टर सुन्दर पुरोहित, डाक्टर बद्री बडो, अन्य उपस्थित सिनियर चिकित्सकज्यूहरू, सम्पूर्ण यस सम्मेलनमा उपस्थित सहभागी सम्पूर्ण चिकित्सक, अन्य स्वास्थ्यकर्मी ज्यूहरू, सर्वप्रथम त आजको यस कार्यक्रममा मलाई प्रमुख अतिथिको आतिथ्यताको लागि निमन्त्रणा दिनुभयो र यहाँ छोटो मन्तव्य राख्ने मौका दिनुभयो। यसका लागि म आयोजकलाई हार्दिक धन्यवाद भन्न चाहन्छु। यो चिकित्सा क्षेत्रमा नेपालमा थुप्रै स्पेसियालिटी सब स्पेसियालिटीहरूले धेरै नै विकास गरेका छ। त्यसमा मलाई लाग्छ आँखाको सबैभन्दा अग्रणी स्थान छ। अन्य थुप्रै स्पेसियालिटीहरूको डेभलप भएको छ, तर अप्थाल्मोलोजीले जति सर्भिस विस्तार गरेको छ, जति आफ्ना अस्पतालहरू विस्तार गरेको छ र जति आउटरिच टाढा टाढासम्म ग्रामीण क्षेत्रका आम नागरिकलाई सेवा दिएको छ, सायद मलाई लाग्छ अरू कुनै स्पेसियालिटीले यति गर्न सकेको छैन। जसरी यो एमडी प्रोग्राम सुरु भयो त्रिभुवन युनिभर्सिटी इन्स्टिच्युट अफ मेडिसिनमा, त्यसपछि क्रमशः न्याम्समा र अहिले विभिन्न मेडिकल कलेजहरूमा पनि यसको स्पेसियालिटी ट्रेनिङहरू सुरु भएर गएछ। न्याम्सले मात्रै भन्ने हो भने अहिले 250 भन्दा बढी अप्थाल्मोलोजिस्टहरू ट्रेन गरिसकेको अवस्था छ। अहिले न्याम्सको ट्रेनिङ इन्स्टिच्युटको हिसाबमा मेची आँखा अस्पताल पनि यहाँ कार्यक्रम सुरु भएको छ। यो कार्यक्रम सुरु भएर यो ठाउँमा आएर मलाई यो आतिथ्यता गर्न पाउँदा अत्यन्त खुसी लागेको छ। म सम्झन्छु आज होइन, आजभन्दा 20 वर्ष अगाडि म यो ठाउँमा काम गर्न आएको थिएँ। म मेची अञ्चल अस्पतालमा एज अ फिजिसियन काम गर्दाखेरि म दिनमा यो 2 चोटि यो बाटो हिँड्थेँ। यो सैनिक चोकबाट यतापट्टि पुरा खाली जग्गा थियो। चिकित्सकहरूको हिसाबले हेर्ने हो भने मेची आँखा अस्पताल जहाँ पहिले सुरु भएको थियो त्यहाँ डाक्टर सञ्जय सिंह हुनुहुन्थ्यो, बिचमा अरू बडु सर हुनुहुन्थ्यो, कोही अरू चिकित्सकहरू हुनुहुन्थ्यो। त्यसमा मेरो बेटा हाफ पनि त्यहाँ काम गर्ने भएले पनि सायद म यहाँ आएको थिएँ होला। त्यसपछि त्यो टाइममा धेरै कम चिकित्सक भएको ठाउँ यो मेची अञ्चल भरिमा हेर्ने भने हामी फिजिसियन 2 जना काम गर्थ्यौँ। अहिले यो ठाउँ हेर्नुहोस्, यति धेरै चिकित्सकहरू भएको, यति धेरै हस्पिटलहरू भएको र यति धेरै सुविधा सम्पन्न एक किसिमले भन्ने हो भने यो क्षेत्रको एउटा मेडिकल हबको हिसाबले डेभलप भएको छ। त्यसमा पनि यो अप्थाल्मोलोजीकै मात्रै भन्ने हो भने कुनै त्यो टाइममा जुन बेला मैले यहाँ हेरेको थिएँ, यहाँ खेत थियो। नेदरल्यान्डका ग्रुपहरू डोनरहरू आउँदाखेरि हामी सँगै यहाँ आएका थियौँ। अहिले यो ठाउँमा यति भव्य अस्पताल, सबै सुविधा, यति धेरै विकास भएको हेर्न पाएछौँ। यो सँगसँगै थुप्रै आँखाका अस्पतालहरू यहाँ छेउमा देख्न पाइएका छ र यसले पक्कै पनि हाम्रो सर्भिसलाई धेरै अगाडि बढाएको छ। हामीले कति फोरमहरूमा सुन्छौँ कि मेडिकल टुरिज्म डेभलप गर्नु पर्यो, वास्तवमा मेडिकल टुरिज्म अप्थाल्मोलोजीमा अलरेडी डेभलप भइसकेको छ। हामीले यसलाई अझै ठुलो प्लेटफर्ममा लगेर यो भएको कुरालाई राख्न सायद सकेका छैनौँ होला। हामीले मेडिकल टुरिज्मको बारेमा अन्य थुप्रै फोरमहरूमा हामीले कुरा सुनेका छौँ, तर अप्थाल्मोलोजीमा जुन भएको छ यो एकदमै उदाहरण दिन मिल्ने सराहनीय कुरा छ र यसलाई अझै अब जसरी तपाईहरुले विकास गरेर लाग्नु भएको छ यसको लागि वास्तवमा हामीले मात्र हैन कि राज्यले नै यसलाई एकदम सम्मान गर्नुपर्ने अवस्थामा चाहिँ मैले देखेको छु। अब आजको यो 3 दिनको तपाईहरुको सम्मेलनमा पक्कै पनि धेरै रिसर्चका नयाँ डेभलपमेन्टका कुराहरू भएका छन् र हुनेछन्। त्यसले हाम्रो यो प्लेटफर्ममा जे डिस्कसन हुन्छ त्यो पेशेन्टको सर्भिससम्म ट्रान्सफर्मेसन भयो भने त्यसले क्वालिटी सर्भिसमा निकै नै सहयोग पुग्नेछ र अप्थाल्मिक सोसाइटीले काठमाडौँमा मात्रै नभएर काठमाडौँ बाहिरका विभिन्न स्थानमा यस किसिमले सम्मेलन आयोजना गर्दाखेरि काठमाडौँ भन्दा बाहिर प्र्याक्टिस गरेर बसिराख्नुभएका चिकित्सक अन्य स्वास्थ्य कर्मीलाई पनि अपडेट हुने मौका हुनका साथसाथै यो आयोजना गर्ने अस्पताल अथवा आयोजकलाई पनि अझै आत्मबल बढ्ने अवस्था मैले देखेको छु र यो एउटा उदाहरणीय सराहनीय कुरा छ र अप्थाल्मिक सोसाइटीका अहिले भएका जो एक्जिक्युटिभहरू हुनुहुन्छ उहाँहरूलाई यस्तो एकदम सराहनीय कामको लागि धन्यवाद भन्न चाहन्छु। र अब यस सम्मेलनमा तपाईहरुले सर्भिस मात्र हैन रिसर्चको पाटोलाई पनि अझै अगाडि बढाउनु हुनेछ भन्नेलाई मलाई विश्वास छ, किनभने हामी जति सर्भिसमा अगाडि छौं त्यति धेरै रिसर्चमा छैनौं। एकदमै नभएको हैन, हामी छौं, तर त्यसलाई रिसर्चको पाटोलाई हामीले अझै अगाडि बढाएर हाम्रो भूगोलमा हाम्रो लोकालिटीमा जे छ त्यो रिसर्चमा ल्याएर त्यसलाई इम्प्लिमेन्टेसन गर्यौं भने अझै सर्भिस राम्रो हुन्छ र रिसर्चको पाटोलाई पनि हामी अगाडि बढाउने गरी यो सम्मेलनले अझै अगाडि बढोस् र यो सम्मेलनको सफलताको कामना सहित मेरो मन्तव्य यही पूरा गर्छु। धन्यवाद।
Thank you, sir. Now I would like to welcome Dr. Purushottam Joshi on the stage. Sir.
Thank you. Thank you. Thank you. I would like to call upon the stage Dr. Madhu Thapa, Dr. Santanu Ganguly, and Dr. Daki Sherpa. The story just now told by our VC, Bhuvendra sir, 20 years ago, his better half was here. 20 years ago, Madhu Didi was here and she taught me how to do cataract surgery that time. And it is a rare coincidence. 20 years ago, Daki Didi, Madhu Didi and Santanu Dai, they were all here. And another interesting fact is they are all glaucomatologists, all presenting on glaucoma. So now we are going to award them for their service, and it is not as such gold, silver, bronze, but it is according to the duration served here at that moment. The most duration was served by Madhu Didi, so she is getting the gold award, and then the Santanu Dai for the silver award, and Daki Didi the bronze award. They were here 20 years ago, and I would like to request our chief guest and the chairman of Mechi Eye Hospital Sangh to kindly give award to our senior past doctors of Mechi Eye Hospital. First Madhu Didi gold medal, then Santanu Dai silver medal, and Daki Didi bronze medal. नारायण The award is yet not finished. I'd like to call upon Professor T.P. Das once again to the stage. There is a medal as well.
To conclude the formal part of this evening, may I invite Dr. Tesu Singh Malla, General Secretary of Nepal Ophthalmic Society and Organizing Secretary of Noscon 2025, to deliver the vote of thanks.
Our executive team of the Nepal Ophthalmic Society has always stood for its member, for our communities, and for the betterment of eye health advocacy across our beloved country, Nepal. Respected President and Organizing Chairperson, Associate Professor Dr. Purushottam Joshi, distinguished guest, past President of the Society, respected seniors, and my dear friends. On behalf of the Organizing Committee, I extend my heartfelt gratitude to all of you for attending the 27th Nepal Ophthalmic Society Annual Conference and the 16th Eastern Regional Ophthalmic Conference held in collaboration with the Nepal Vitreoretinal Society. Truly meaningful and memorable. My sincere thanks to our chief guest, special guest, and dignitaries for honoring us with your presence and inspiring us with your guidance. To our national and international speakers, thank you for sharing your wisdom so generously.
Your insights strengthen our collective mission to improve eye care across the country. I'm equally grateful to the session chairs, moderators, and panelists for ensuring that every scientific session was enriching, engaging, and well conducted. To all participants, residents, fellows, and ophthalmologists, your active involvement gives us great hope for the future of eye health in our country. A warm thank you for our partners, sponsors, and supporters for standing with us and believing in our efforts. And lastly, to the organizing committee and our dedicated volunteers, thank you for your hard work, long hours, and unwavering commitment. This conference is a success because of your tireless efforts. Thank you all for being part of this journey of wisdom, service, and hope. See you all at the 20th Nepal Ophthalmic Conference from 12 to 14 November 2026. Namaste.
Thank you, Desudai. Thank you, everyone. We now invite all dignitaries and participants for a group photo session. You want the photo.
डिस्टर्ब गर्छ यसले कि यो खोज्दिउँ होइन पछाडिबाट नारायण नारायण यो क्यामेरा टुललाई एकछिन दिनमा खोलेर नि पछाडि हटाउनु पर्ने भएर डिस्टर्ब गर्छ ग्याङ ठुलो हुनुपर्छ गर्दैन ल भाइ
To invite executive members of Nepal Ophthalmic Society and organizing committee of Noscon 2025.
The beginning of the exciting days of learning, sharing and celebration. We hope everyone enjoys the rest of the evening.
And now, please don't forget, tonight we have our gala dinner and special music performance by Sugam Pokhrel.
Thank you and namaste.
Let's have a wonderful, wonderful evening. Thank you. I'd like to request all the team of scientific committee to have a group photo. Scientific committee members, please, and organizing committee for a group photo. May I request organizing committee and scientific committee of Noscon 2025 for a group photo. Thank you so much. Have a wonderful evening.
भाषा र भेषा मौलिक पहिचान